6 oncology meetings going on today in the city of Kolkata as of now. So that's a physical meeting what we are having. So having said that, that actually reflects the spirit of the what we call a revenge reunion, we can say that way, so far as an academic meeting is concerned. So that certainly boosts the model of the organizers and of course the faculties, delegates who have pressed the button for registration. That's always a pleasure. Now, so far as this meeting is concerned, International Breast Cancer, this is our second of type meeting under the aegis of Apollo Hospital and Aroy, West Bengal. In fact, in 2021 April, in middle of COVID, we organized an international prostate cancer meeting. And you'll be surprised to know we had 150 delegates glued to the screen for a 3-hour session. So wish us good luck, hope we'll rock. And this, so far as agenda for our breast cancer meeting today is concerned, it is actually a very, very tight 8 hours schedule. So my only request to the experts, moderators, speakers, everybody for that matter, will try to respect the time because we have got international speakers with a different time zone. So time is something which needs to be taken care of, and I hope we are all matured by now and we'll respect to that. So far as the sessions are concerned today, we have almost 5 sessions. We have divided it imaginary in form of early breast cancer, neoadjuvant treatment options and guidelines in breast cancer, locally advanced breast cancer, and metastatic breast cancer. And that is interspersed with some crisp panel discussions and hopefully some like dogfight style debates also we have. So let's see how we go on. So friends, my request to you that please look into the agenda. There are some very good talks and deliberations from different speakers and panel discussions. We have as a guest speaker Dr. Badwe, Director of Tata Hospital, and he'll be covering a topic on evolution of breast cancer in last 5 decades. We have Dr. Vijay Anand Reddy, Director Apollo Hospital, Hyderabad. He'll be covering on landscapes of radiotherapy in last few decades. And we also have virtually Dr. Duncan Whitley. He is the clinical coordinator for the Fast Forward trial. So he's excited and wants to enthuse and incite us about with the new kid in the block. That is what we are talking about, Fast Forward trial, the ultra short duration of radiotherapy. So we are all waiting for that. And finally, we also have many faces of TNBC, another pot boiler which is brewing hot. Sudeep Gupta, he is the director of ACTRAC, the research wing of Tata Memorial Hospital. He'll be unveiling a bit about the newer innovations which is happening in the tricky TNBC, that is triple negative breast cancer, and as a troubleshooter, how we can tame this disease. So with that, I welcome you all once again, and I would request Dr. Naziba to start the meeting from here. Thank you once again.
Thank you, sir. I would now like to invite our experts to preside over the next session. Dr. Suchanda Goswami, Senior Consultant in Radiation Oncology in Apollo Multispeciality Hospitals, Kolkata. Dr. Shubhashish Sarkar, Senior Consultant in Surgical Oncology at Bellevue Clinic. Dr. Saurav Ghosh, Professor and HOD, Surgical Oncology, Medical College, Kolkata.
Hello, welcome everybody. Let me start by thanking the AROI and Apollo Hospitals for taking this wonderful initiative to have a focused single theme conference on breast cancer. The first session will be started off by Professor Diptendra Sarkar, who needs no introduction in front of such an august gathering. He is a professor of surgery in SSKM Hospital for many years and has a lot of original work on breast cancer. and he's one of the persons of the task forces of the ABSI who brought out the guidelines for management of breast cancer in India, which was the need of the hour at that time. So I'm sure he'll be informing us about global cancer screening strategies and leave us with a clear message of its relevance or its applicability as far as India and West Bengal is concerned. Professor Shorkar, please.
Thank you, Shoram. And it's always a pleasure to be the opening batsman. The only thing is that when I used to go to Eden Gardens, I used to see only few people sitting in the crowd, and later on people start pouring in. But those who are not in the first few overs are going to miss the real fast bowling in the morning dews. So I'm sure I'm going to raise some controversies, and this talk as such is filled with controversies where we can argue, we can have at least 10 debates on every areas. So number one is the question that I'm going to ask myself, and the question that I'm going to ask all of you: is screening needed in developing countries? To answer this question, I have been doing a lot of homework, and if you look at the 35 years and the cutoff above that, it would be around 19 crore female in India. And if the likely incidence is 1 in every 28 to 30, that would mean that India expects an annual incidence of 6,59,391 cases. The actual reporting as per the last consensus was 1,43,000. So that means we are missing almost one third of the breast cancer patients who are not been officially registered. I am taking you back to 1.5 decades back, Globocan data. And if you look at that, it states that roughly the high economic countries and the mid low socioeconomic country, the distribution of cases will be 50-50. But if you actually look at the fact of underreporting, then actually the mid and the low socioeconomic countries have more load of breast cancer compared to the less populated but more affluent countries. But this is one thing, one important table that you must all understand, that in US, if the annual incidence is around 1,82,000 and the absolute death is 40,000, whereas in India it's 1,43 to 1,47,000 and the absolute death is 73,951. So roughly what happens is that the mortality is close to 50% in India, and that's probably because of the late presentation or at least the late initiation of treatment. And therefore, needless to say, yes, countries like India and the low and mid socioeconomic countries do need a training program. And therefore, there is no reason to believe that this lecture is not required, but I'm going to take you through what is essential and what is not. There are three options: breast self-examination, mammography, and clinical breast examination. Let us look at breast self-examination to begin with. There were two major trials, one from Russia, the other was from Shanghai, and both the trials actually put breast self-examination into a long bin basket. It's not required. That's what the conclusion, and therefore there was a lot of frowning when you talk about breast self-examination being a tool, and it was criticized because of the overdiagnosis bias. But you have to reopen the studies and find that actually in those two countries, the median size of detection is 2.1 to 2.3. So that would mean in a country where the median size is 4.5, this is a good enough tool for early diagnosis. And even if you feel that there will be a large number of overdiagnosis bias by this tool, we have to understand that it makes a lady aware of their breast and also gives us the opportunity to treat. I think it's gone. Can you correct it? So it gives us the opportunity to at least to treat the benign breast diseases. Can I have the next slide, please? So therefore, the verdict is very clear. It does have a valid role in developing countries, not the way the affluent society will look at it, but it has its role definitely. The second talked about option is mammographic based screening, and we all know this data and the chart, and all of us have gone through that. And of course, there are strong evidences, at least on paper, to suggest that mammographic screening helps. Of course, there are two trials which actually have got an opinion which is against the reverse of what the rest of the globe would actually feel. But if we try to extrapolate this data on Indian subpopulation, we'll find that the median age being 46.7, of course, because of the fat middle-aged group, you are going to miss the majority of cancer if you use mammography as a tool, which is more. And if you look at the evidences are strong after the age of 50 years. So it is not suitable according to the Indian age of presentation. In a country where 30 to 50% are locally advanced breast cancer, and the mean size in most of the studies ranges between 4 to 4.5 centimeter, you don't require mammograms to diagnose an early breast cancer. Above all, if you are able to ascertain in a single go the amount of money the United Kingdom spends on a mammographic screening program, and down there it comes to 1/4 of the Union Health budget of India. So of course, both from the views of the age, the large size, the financial unacceptability, it is not an acceptable tool. And if you have a drone photograph and you try to understand this is cricket and that's baseball, but from a drone photograph, both of them actually look the same, but it's a different ball game altogether. So what lessons we learn from the West? It, though on paper promised to have a reduction, this reduction actually didn't happen. And these are due to these problems. Number one is, this is an hypothetical thing that you are seeing. Now, if you have inception at A, and if you have a screening program which starts at B, and you look at that you are going to diagnose maybe more indolent cancers, and we are unsure with whether we are able to push the bar D. But we are sure about the fact that if you have triple negatives being treated by molecular targets, you are directly going to get a benefit. So in the era where therapeutics is coming up strongly, it makes for countries like us to invest more on therapeutics and get immediate reduction in population mortality than to spend the equal amount of money on a mammographic-based screening program, which might or might not give a reduction in mortality after 15 years. So what that the West have done is they have picked up more of the C's, and the A's were detected, and the A's died in 2 years' time, and probably they had more therapeutic intervention on A, and you picked up C, and so the trend of DCIS went up. So now there are 3 major trials that are happening in the West to make people understand that not all DCIS needs to be treated. So it was not being treated, and it is not being treated in this country. Now you have tons of 80% DCIS, which you picked up by a mammographic screening method, and you are trying to generate an evidence to tell that most of them, which are low risk DCIS, should not be treated. But if you go back to the time machine, let's see what was reopen the file of Swedish 2-county trial. That was a hugely biased trial. The confounding bias was tremendous. Now there was one arm where the volunteers went to their home, they spoke about breast cancer, made them aware, took them for mammography, and the other arm, you never went into their house. But the trials that India generated, I'm going to show that, has actually removed this confounding bias. So the verdict is possibly we avoided the blunder unknowingly. Now we come to the third option, which is the clinical breast examination as a screening modality. Now we all know that this was published in the British Medical Journal last year during the pandemic. the old trial that was started by Indranil Mitra, which ran over 20 years. Now let us reopen the trial once again. Now look here. In this trial, both the intervention as well as the control group were made aware about the signs of breast cancer. And then in every 2 years, the female health workers actually did the clinical breast examination. And what was found after 20 years of prospective trial was there 10% reduction in the premenopausal and 30% reduction in the postmenopausal age group. But far more important facts are evolving from the IARC trial, and that is done by Shankar Narayan. He started the trial, and I have had the opportunity to work with him in Bangladesh for quite a long time. And the last data that came out, the interim publication, shows that the CBE arm is picking up at least 18% or 18 out of 100,000 women which were early breast cancer, compared to the control group where it was 8. So therefore, it is generating an adequate evidence, and by 2023, the final verdict is going to come, which would be concordant with the Mumbai trial. So if we look at all the 5 options, this is an option that must go for all low and mid socioeconomic countries. So we are once again on the crossroads. Now we have a mammographic program which is going to give you a reduction of 25 to 29%, and the CBE, that's 20%, but the newer evidence is 30% reduction. So the question is, are they equally beneficial? The answer to the question is no. Now let us say why it is no. Now you have to look carefully that this is when the United Kingdom in 1987 started. The mean size was 2.7 centimeter, and it made sense that mammography was available at that point of time. And now the mean size of presentation has gone into the sub-centimeter level. But India is standing somewhere here. So if you start a CBE-based program, in another 15 years, hopefully you are going to come down to 2.7 centimeters. And by that time, if this breast meet happens after 10 years and mammography still exists as one of the tools for detection, then you can start. But at this point, it's complete waste of the hard-earned taxpayers' money. So in 2017, we were all there in the planning commission. We had multiple brainstorming meeting and to choose what was the best form of breast cancer screening, and before it was rolled out. And at that point of time, it was 3 yearly, then they expanded it to 5 yearly, of course, with some amount of political element in 100 districts. But this is the modification that we started in this state. Now, this is the modified model that we have started, rolled out in 5 districts in West Bengal. The level 1 is, which is part of the National Non-Communicable Disease Program, where every house there is a door-to-door survey which is done by the ASHA workers, and we had trained almost 10,000 of them over a span of 6 months. In level 2, it goes to the community health officers, and there in the Shastha Surakha clinic, the clinical breast examination is being done. Once it is picked up by the ASHA workers, we have trained 450 of them, and all of them a video to make them understand how it is being done. In level 3, we have started district breast clinics in 5 districts on 2nd of July, and we are generating data. We have trained 60 breast physicians who are doing this clinic, and then it is being, if they wish to do it there, it's fine, or else in the level 4 care, they're going to come to the comprehensive clinic at IPGMR. So what are the barriers? Barrier number 1 is quality assurance. We are struggling with that, and we are going to find a solution. The over referrals. Now look at this. This is the data from CBE, which was generated in Odisha, and it goes straight to IARC, and Parthoda and I have actually gone into the whole thing and found that there were 20 lakh patients which were referred, which were officially at least breast self-examination was done, and there was no referral, but the cutoff is at least 10% should be referred. So it means that proper breast self-examination or CBE has not been done. The second is you need a filter. And what is this filter? Now we are going to start this trial in November this year at our institute at IPGMR jointly with WHO, and there you see is a tool which is a handheld probe which is linked with Bluetooth, which can be done. Initially, we thought non-medical persons. Now we have eliminated that. We are starting it with the medical persons, non-radiologists, who are going to do a very simple test on the spot and generate a risk-based, that validation has been completed, and risk-based assessment of whether it's a benign or it's a malignant one. The second one is mRNA in the blood. Just give me 30 seconds. I think I deserve that because it was not there. Now, this is a very interesting publication from one of my friend called Bindu Salem, who she is a fantastic lady who works in Coimbatore. And she actually did this technique where mRNA is being taken in the blood and it's being studied. Now we have given a modification and we are generating another study on this to make understand whether this is a valid one or not. A very interesting one again comes. We formed the Breast Global Hub, and this is Jill Darts, who is the immediate past president of the American Society. And we have had at least 5 meetings, and I met her in Las Vegas this year. And this is the tool she is recommended. What they are doing is they are taking the nipple duct fluid and looking at abnormal proteomic cells. And if you find that there is one, you are suspecting cancer. Of course, the question that comes to your mind is how every lady is going to generate a ductal lavage. They are having a small oxytocin patch which will be rubbed in the back in the post-auricular area, and immediately in 15 minutes ductal fluid is going to be generated. So that's where the Western world is actually going into. So the strategies therefore have to be different. Now I come to the end of the talk, and this is a very favorite slide of mine. These are from different 5 areas of the globe, and each trying to understand how the elephant is and describing it it's in their own way. And this is how they would describe, and this is then what the elephant actually looks like. So if we blindly follow a model which is completely non-Indian, we are going to fail completely. Thank you very much.
Thank you, Dr. Sharkar, for this illuminating lecture. The session is open for a couple of questions. Anyone in the audience? We can take one of the questions. Maybe Dr. Sharkar, you can answer. So, what would you say is the optimum strategy for population-based screening for West Bengal? Ultrasonography or clinical-based examination?
Clinical breast examination. Now, screening by classical definition means identifying cancers in the preclinical stage. We are not talking of identifying cancers in preclinical stage in India. We are talking about picking up cancers in the earliest symptomatic phase. And for that clinical breast examination, there is robust level 1 evidence, both an Indian trial and the WHO trial, to suggest this is the tool. And the model that we have started, and if it works out, that can be a good model for all developing countries.
When can we expect a publication on this data?
No, these 2 data are going to be published. Our main problem now is motivating people at the ground level to do this. I mean, it would take a lot of sweat to motivate a person to start a breast clinic. Of course, the government is helping and we are motivating them. Hopefully, it will take another 2 years time to come to a conclusive statement. The issue is not about the evidence. The issue is implementing it in the ground reality.
Professor Sharkar, I have a question.
Yeah.
So, sir, there is a difference in the demography of patients we find in Bengal, urban versus rural. So, in city like Kolkata, where we have a lot of women coming for self breast examination, and if we don't find anything clinically, should we just reassure them? Because sometimes they're very eager to do a test to find out whether they're okay or not.
Madam, opportunistic screening is not disappearing. I mean, if somebody wants an opportunity, that's called an opportunistic
Yes.
screening. Somebody wants, it's fine. Now, I'm going to show you, it's not there. We did another study on 100 patients with equal amount of representation from urban, rural, and extreme rural population. We have found it conclusively that there is no link between socioeconomic status and educational level. A lady who is taking a bath in say Fuldani village would pick up a small lump. that nothing to do with the education level. Again, a lady who is taking a bath in a jacuzzi also picks up a lump. What happens in the next level? There is an access delay. That's why we are talking about infrastructural building. The lady in Purulia will walk into the first available quack whom they think is a god. And we have seen all patients of gastric cancers taking pantoprazole for 5 months, then coming out when there is a melena. So the fault is not about ignorance. And we have also found that almost in every village, there is 1 or 2 breast cancer reported. So they are already aware what we need to reach them. It's not a question of why they are not coming. They are ready to come, but we are not reaching them.
Okay. We thank Dr. Shorkar for his excellent talk. Now our next topic is by Dr. Sanjay Chatterjee. He is the senior consultant in TMC Kolkata. His topic is simultaneous integrated boost in breast RT. Dr. Sanjay Chatterjee, please.
Good afternoon, everyone. And Prosenjita, thank you very much for inviting us, especially inviting me. You know, this has been around 2.5 years that haven't been to many physical meetings, and again, meeting with colleagues and friends for after such a long time physically is certainly something that I cherish. The topic you had chosen is a technical topic, but I'll try and give you all. I don't know how many of you are radiation oncologists, but I'll try and give you all a bit of a idea as to what this is and what is the clinical implication of this topic. So time in general defines our existence, isn't it? If time is not there, we don't exist. And when we look at time, we always want to start on time. If Prosenjita doesn't start on time, his meeting is going to be delayed. If you don't start on time, then you are late for some work. And this poor patient who's got breast cancer, who's coming over from whichever part of the world he or she is, she also values time. And that is what we as clinical or radiation oncologists looked at. And we are lucky that we were able to crack the conundrum of time in the treatment of adjuvant breast cancer, in that 15 fractions of radiation have been conclusively proven now to be equivalent, or rather non-inferior, to 25 fractions of radiation even in the Indian population. So basically, someone who was having adjuvant breast radiotherapy over a period of 5 weeks has saved 2 weeks by getting the radiation in 15 fractions, or over 3 weeks. The question is, what about the new data that has come out from the West suggesting that fast forward 5-day fractionation is likely to be as good as the 15 fraction radiotherapy trial? Now, that is a bit of a question that we need to think about, because these are the parameters of our patient, and I would entirely agree with Ditendra, who was the previous speaker, in that we have a different data set of patients. We have unscreened population, patients who are predominantly younger, higher grade 3 populations, significant proportion receiving neoadjuvant chemotherapy, and a significant proportion of them requiring regional radiotherapy, which were underrepresented in the fast forward trials. Now you might say, but what about the current guidelines? There are certain guidelines that have come during the pandemic, and those guidelines suggest that you could actually treat with 5 fractions. Friends, it was the time when the pandemic was rip-roaring. It was an emergency guideline, both by the WHO, it was an emergency guideline by the RCR group, and I would certainly not believe that without strong Indian data, we would change over as 5 fractions or 5 days treatment as standard. Now, coming to the topic, boost? Well, whole breast radiotherapy, we talk about whole breast radiotherapy is important. But look at this. There's something with radiation and breast cancer that gives effects which are really significant. A hazards ratio of 0.65, a relative 35% improvement in IBTR with just boosting the tumor bed after whole breast radiotherapy. And that is important. That is important in the bigger tumors after BCS. That is important in the younger patients. That is important irrespective of the grade of the tumor. But most importantly, if there is also DCIS, it's important. So boost mainly in younger patients, mainly in bigger tumors, mainly in patients who have associated DCIS. Now, how do we boost? I mean, there's no question that whether we have to boost. We have to boost after whole breast radiotherapy in breast conservation because there's a significant improvement in ipsilateral breast tumor recurrences. The question then is, how do we identify as a technician, as a radiation oncologist, how do we identify the tumor bed? And again, we go back to our surgeons and say, look, can you please mark the area with clips? If you mark the area with clips, we can see. If you don't mark the area with clips, God help the patient, it's anyone's guess, because with the mammoplastic procedures and other mobilizations that you do as breast surgeons, marking the tumor bed is essential, because if we boost based on the scar you produce, we definitely boost the wrong area. So there's no doubt that if you give a tumor bed boost, you would enhance the in-breast tumor control rates in your patients. But that, again, if you look at time, will increase the treatment time. Now, let's try and see how we address this issue in Tata Medical Center. And I think, if you're interested, you can actually use this template in your center to try and see if it would fit your own idea of starting your simultaneous integrated boost protocols. So look, we first said, yes, if we have to boost, let us try and identify if electron boost is the way forward. And what we tried to do is we tried to calculate the tumor cavity. And we said, let's try and see if we have photon mini tangent boost. By photon mini tangent boost, we mean that, if you have this as a tumor cavity, if we can shape a small field which can give a mini tangent boost, then is that any better using photon mini tangent boost compared to electrons? And we then showed that yes, electron boost is actually much more wider, less conformal, and likely to give you a slightly higher lung dose as well. Now that is important because when we are saying that the techniques we use are not optimal and there are better techniques like, changing over from electron-based boost to mini tangent photon boost, then of course we have to move to that. And that's what we did in Tata Medical Center. We changed over to the photon mini tangent boost. And we said that, well, look, if we are changing over to photon mini tangent boost, what next? We are still giving the patient those extra few days after the whole breast radiotherapy. I mentioned that, 15 treatments is 3 weeks of commitment from the patient. And you've got to remember these patients have had their surgery, their systemic therapies, and now their radiotherapy. They're really tired. So what do we do? Can we actually reduce their time even further? And that's when we tried thinking about the simultaneous integrated boost class solutions. So how did we go about it? Well, look, the mini tangent boost was being delivered as a sequential boost. What if we can integrate the boost during the course of the whole breast radiotherapy, if we can simultaneously boost the tumor? And this is an example of that with the mini tangent boosts versus, this is what we would identify as the tumor bed. And you can see we actually have 2 mini arcs. Now, the rule of thumb over here is that the arc should be so small that your exit dose does not go through the contralateral breast or the ipsilateral or contralateral lung. If your arc is big enough, then you will actually hit the contralateral breast and the contralateral lungs, and you are not going to do any benefit to your patient because they'll have more side effects in future. In doing that, what we did is we did an isodose coverage comparison, and this is on the left of your screen. You've got the conventional treatment of sequential boost, and this is the simultaneous integrated boost treatment. And you can see that the high dose isodoses are actually very well conformed to the tumor cavity compared to the photon mini transient boost. And if you remember, the electron mini transient boost was even worse. And this is again another comparison of the low dose spillage, because that is one of the most important things to consider in adjuvant breast radiotherapy. You're giving treatment as an adjuvant. If you're talking about low dose spillage, and if your boost is such that you are spilling your, with 1 gray, 2 grays, your entire lung is being spilled, then you're not doing any justice. And look again, conventional radiotherapy versus the simultaneous integrated boost, our doses were comparable. And that's when we said, okay, we've cracked it. Now, are we ready? And again, this is the statistical comparison. And we published the class solution in the RCR journal. The question is, that was a dosimetric study. Are we ready to implement it? Now, to implement something in real life patients, we thought that we need something close to a phase 1, phase 2 study. And that's what the HIPORT B study gave us. So basically, it was a 26 gray in 5 fractions plus 6 gray simultaneous integrated boost in incurable breast cancer. So basically, these patients had breast cancers already in them, and they were symptomatic from the breast cancer. So we were treating them palliatively, and we gave them radiotherapy with simultaneous integrated boost to the tumor. 2 reasons. One, to check whether dose escalation, because there was a previous study called the HIPORT A, in which we gave a slightly lower dose to try and palliate the tumors. Now, the SIB technique actually tried to see if we can implement the feasibility of implementing SIB in patients and assessing their toxicity and quality of life. We did in vivo dosimetry to confirm that we are delivering the right treatment, and that is important again if once you try and commission a new technique. And then we published and we said that yes, look, compared to whatever we do, our quality of life of our patients with SIB is maintained, and that they do not have grade 3 toxicity, which is most important, because you don't want an inverse planned simultaneous boost to actually give them extra toxicity, skin toxicity. So that is when we realized that we are ready to use it now, not on the patients with bigger tumors, not on the incurable ones. So phase 1, phase 2 study is over. Let's try and see if we can now do it in the adjuvant setting. Whilst we were doing this, the group from Cambridge, Prosenjit's friend Charlotte Coles et al., they actually published on the IMPORT High study, which was again looking at a simultaneous integrated boost with 3 weeks of radiation. And they said that, yes, look, if you give this boost, similar to what I showed you, boost around the tumor bed, what is the morbidity? And they showed that, you have similar morbidity, 6% versus 7% grade 3 in duration at 5 years. And this is not just acute toxicity. This is 5 years morbidity. And they showed that, it is actually safe to give SIB in these patients. So that gave us the impetus. And that's what brings us to a study that I'm grateful that Shona and her family has supported. Thank you very much, madam. And, through the breast cancer research initiative. And we've also got some funding from the Lady Tata Trust on this study, and it's a multi-center study between Tata Medical Center, Christian Medical College Vellore, SGPJ Lucknow, and AIMS New Delhi. We went on with a daunting task of recruiting 2,100 patients, and as I was sitting there, Shona mentioned that what about the progress report? Whilst I was sitting, I had the progress report. We have recruited 1,500 odd patients. And we've published, I'm pretty sure many of you have seen the publications on the acute toxicity, which suggests that, it is safe. What does the acute toxicity look at? It looks at all the skin toxicity, even within the SIB arm of these patients. So how did we get on to the dose fractionation? Well, Shantam and me, we sat together, we thought about the radiobiology of the study, and we thought for the different alpha betas that if for radiation oncologists this is, what would be the likely difference in the dose that we deliver, and this is how we went ahead with the endpoints of the study. Hopefully within a couple of years, you will have more data. In fact, this year you will have local control outcome data. Next year, possibly a clinical quality of life outcome data, and within the next 2-3 years, you should have the initial local control data with SIB published from your own country using a 5 fraction. If you look at the trial schema, again, it's a 5 fraction simultaneous integrated boost versus a 15 fraction simultaneous integrated boost in the HIPORT adjuvant study. With this, I rest my case. I think this is something we are really gearing up and looking forward to try and improve the patient journey. 5 treatments is all that you need, irrespective of whether you need boost or not. Is what we would hypothesize, and we would say that this is what we can hopefully safely show within the high voltage trial.
Thank you, Sanjoy. So we can have 1 or 2 quick questions.
Which problems? First is funding. Are you talking about problems for patients or problems for running the study?
Problems in carrying out this trial, particular trial.
No, it was. I must say, it was a lot of enthusiasm, and I really can't think of. I don't know if Shantam has come. He's supposed to come. I can't think of any problem running the hypoadjuvant study at all. It's a privilege. It's something. It's the first multicentric randomized controlled trial in breast cancer using radiation therapy in the country. It's looking at a futuristic technique, robust quality assurance, external peer review, data safety monitoring committee, which is internationally accredited. So I'm privileged to be part of this study. I don't think there was a problem. I mean, with anything there will be problems, but
Quality assurance. That is
yes,
one of the
we
most
have. We are doing external quality assurance in that each center is doing the quality assurance for the other center, and the quality assurance I talked about does include all this. In vivo dosimetry, it does include film dosimetry. So all this has to be done. So class solutions have to be developed. So it's been a tremendous experience interacting with other centers, getting their planners to come up to speed, then getting on with the quality assurance and standardization. What I didn't show is, there's even better quality assurance program that we are proposing called Suraksha through our Chavi image bank, which I'm pretty sure you will all come to know very soon through a publication. It's again an external quality assurance process adapted from hypoadjuvant.
I think 1 more question from you.
It's very nice presentation, Dr. Sanjay. Do you think that the late skin toxicity may be concerned while planning for the SIB?
So, if you're talking about late toxicity, yes, SIB is not giving any extra dose to the skin because you're off the skin. It's inverse planned, and you're just like I said, this is what you're treating. You're just treating this over here, this cavity. Yeah, so you're not expecting more skin toxicity, more skin fibrosis. And if you look at the import high results, there was no extra skin toxicity either. So we're not concerned about extra skin toxicity over here. You can see that the skin is being spared over here. There's skin sparing because we're using megavoltage X-rays. So skin's been spared. Sorry?
DMAT. Do you use DMAT?
No. I mean, again, I must say that, if I wasn't clear, SIB is a hybrid technique. It's a technique where you use, to treat the whole breast, you use tangential fields and you use, hybrid arcs to try and treat the tumor bed. Now, I would strongly recommend that you carry on this exercise of low dose conformity, high dose conformity index, homogeneity index in your patients, and then develop a class solution before you take on SIB. As of now, within the hypoadjuvant, it's Tata Medical Center only that's doing the simultaneous integrated boost. CMC Vellore, AIMS New Delhi, and MVCCRI has also joined us, and there was another center.
Problem is the identification, as you told. If there is no clip during the surgery, how do you?
If there is no clip, God help the patient. If there is no clip, how do you boost? I mean, that's if even now we're talking about targeted therapy, immunotherapy in triple negative breast cancers, and if we can't give our patients a clip, then it's a lost game altogether. For a benefit I showed you, I mean, you're giving a 35% relative improvement in breast tumor control with boost, and if you don't know what to boost, it's such a lost opportunity.
I think we are really fighting with time.
Thank you so much.
So thank you, Sanjay. We could just continue, but we need to move on. So I would like to invite our next speaker, Dr. Shaina Dawood, Head of Medical Oncology and Head of Breast Cancer Program in Dubai Hospital, UAE. The topic is Optimal Neoadjuvant Strategy in Triple Negative Breast Cancer.
Thank you for the invitation. This is actually my first time to Calcutta, and after 2.5 years of being banned from India because of COVID, this is actually good to see everyone in person. So I was asked to talk about the optimal neoadjuvant strategy for triple negative breast cancer and I think this is a very, very important topic because now as community oncologists, I think it's unacceptable if you're not offering your patient with a stage 2 and above triple negative breast cancer neoadjuvant therapy. These are my disclosures, and if anyone wants to get in touch with me, you can scan the barcode and you can see all my social accounts. So, as clinicians, as community oncologists, we have a straightforward, simplistic view of seeing our patients in the clinic. They either have triple negative breast cancer, where all you can do is give chemotherapy, or hormone receptor positive breast cancer, where endocrine therapy is the mainstay of therapy, or HER2 positive breast cancer, where anti HER2 therapy is the mainstay. And today we're going to discuss about the various methodologies that we're using now to incorporate the optimal treatment strategy in a patient with triple negative breast cancer in that neoadjuvant setting. Now, we know that over time, the prognostic outcome of patients with early stage triple negative breast cancer has certainly improved. And this is largely due to the fact that we are using neoadjuvant strategies, we're incorporating anthracyclines, we're incorporating taxanes as well. But more importantly, we've understood that when we give patients neoadjuvant therapy and then they go in for surgery, if they attain a pathological complete response, they do very, very well. Their prognostic outcome is at its best. But if they have residual disease, prognostic outcome is significantly impacted. And that is the reason why we have tried to have regimens that will improve pathological complete response rates. And we've tried to direct therapy based on residual disease in those patients who do not achieve a pathological complete response rate. So, among patients with high risk triple negative breast cancer, could we improve prognostic outcome even further beyond using an anthracycline taxane based regimen in that neoadjuvant setting? The first question was, could we add platinum based therapy? Now, we do have a number of different trials that have actually looked at this question. We have had JEPR-6 CLGB 40603, and then, of course, the latest brightness study, which have all shown that the minute you added a platinum in your neoadjuvant strategy, you were in fact significantly improving the pathological complete response rate. And you can see it on your slide over here. And we've also had meta-analysis that has shown that an increase in PCR rate from 36% to 52.1% is what we have achieved when adding carboplatin. However, the problem was that the addition of carboplatin was perceived to be associated with more toxicity and a higher discontinuation rate. And there was a complete lack of consensus as to whether we could add carboplatin or not. If you look at the NCCN guidelines, it's still not routinely approved as standard of care. But then again, we had the updated analysis from the Brightness trial last year at ESMO. This study looked at patients with triple negative breast cancer, neoadjuvant setting, where patients were randomized to receive either chemotherapy alone or chemotherapy plus minus platinum plus minus a PARP inhibitor. I'll be focusing only on the platinum-based part of this study, and you can see that adding carboplatin to paclitaxel followed by AC, in fact, improved the event-free survival after a median follow-up of 4.5 years. It's very clear, although there was no improvement in overall survival. There were higher rates of hematological adverse events with the addition of carboplatin, but this did not compromise treatment delivery. And I can tell you in my practice, it's very hard for me to actually find a patient that's not completing that 12 weeks of taxane plus a platinum. Plus, there was no increased risk of MDS, AML, or other secondary malignancies. Now, what about incorporating the use of immunotherapy to increase those PCR rates? Well, we did see the results of the Keynote 522 trial that took patients with triple negative breast cancer, again, stage 2 to 3, randomizing them to receive a platinum-based chemotherapy alone or a platinum-based chemotherapy plus immunotherapy. This immunotherapy did go on to the adjuvant phase as well. Post-surgery, the primary endpoint of this trial was pathological complete response rate and event-free survival in the intent to treat population, with secondary endpoints of overall survival. Now, before we go into the results of the Keynote 522 trial, I just want to say that the control arm of the Keynote 522 trial that did not incorporate immunotherapy was platinum-based. That means Taxol, carboplatin, followed by AC. And when you see the little box I've put over here, you can see that the control arm, in terms of PCR rate, 51.2%, very similar to what we saw in the JAPR 6-dose CLGB 40603 trial and the Brightness trial, suggesting to us that we indeed need to add platinum. It's a cheap drug, it's not expensive, it increases your PCR rate. Now, in terms of the Keynote 522, you can see that with the minute you added immunotherapy to this platinum-based regimen, you can see that there was an improvement in PCR rate from 51% to 64.8% with a delta of 13.6%. And you can see that this improvement was irrespective of the PD-L1 status in the Keynote 522. Now, this year in the ESMO virtual plenary session, Peter Schmidt actually presented the event-free survival, which is the second primary endpoint of this study. And you can see that there was an absolute benefit of 7.7%, with translating into a 37% reduction in the risk of recurrence of disease the minute you added pembrolizumab to the platinum-based chemotherapy regimen. And although overall survival was not statistically significantly improved, there was a strong trend towards improvement in overall survival. Now, going forward, I think in patients with triple-negative breast cancer that are eligible for neoadjuvant therapy, there are a number of questions we're going to ask ourselves. Number one, is the increased pathological complete response observed responsible for the event-free survival benefit that we've seen? And is a PCR induced by chemotherapy the same as that we see with immunotherapy? Now, when you go back to the Keynote 522 trial, you can see that in patients who achieved a pathological complete response, almost a 95% event-free survival at 3 years. And in those patients who have residual disease, you can see that there was a benefit to adding that immunotherapy. So irrespective, you are seeing a benefit to addition of IO therapy. Is 1 year of adjuvant pembrolizumab in fact required for all patients? And are all PCRs in fact created equal? Well, when you go back to the JAPR-NUVO study, now the JAPR-NUVO trial was a phase 2 trial that also incorporated neoadjuvant immunotherapy in the form of durvalumab in patients who were getting neoadjuvant chemotherapy, but they did not give it in the adjuvant phase. They only gave it in the neoadjuvant phase. And you can see that there was an improvement to adding durvalumab in terms of invasive disease-free survival, distant disease-free survival, as well as overall survival. Now, when you look specifically at those patients who achieved a pathological complete response, you can see the durvalumab arm, irrespective of the IDFS, DDFS, or overall survival, brilliant 3-year rates in terms of IDFS, DDFS, and overall survival. Really asking the question, do we even need to go in that PCR group? Do we even need to give adjuvant immunotherapy? But as of now, the data is as it is, and we do need to continue our IO therapy in the adjuvant setting. But if a patient is unable to afford it, I would be very comfortable looking at the JAPR-NUVO study to say, look, you can stop after you've achieved a PCR. Now, we also know that not all pathological complete responses are the same. This is a very interesting study that was published last year, looking at patients with triple-negative breast cancer who had achieved a pathological complete response post-neoadjuvant therapy. You can see the 5-year DFS was approximately 86%. But when you sub-stratify these patients based on their baseline clinical CPS-EG score, the higher that score, that means the higher the worse their clinical factors at presentation, you can see that their prognostic outcome was worse. So not all PCRs are in fact the same. For patients with residual disease, will we need to change therapy? Well, when you go back to the Keynote 522, again, those patients who had residual disease post-neoadjuvant pembro plus chemotherapy did better than those patients who did not receive neoadjuvant immunotherapy. You can see a 10.6% improvement in pathological complete response. But continuing that pembrolizumab in the adjuvant setting is an unknown factor. Will it further improve outcome? We simply do not know. But as it is, the Keynote 522 was designed with an adjuvant phase, and it's important to continue into the adjuvant phase as well.
Now, when you compare it to some of the other adjuvant studies that have tried to direct therapy to residual disease such as CREATE-X that used capecitabine, as well as Japernuvo where there was no adjuvant therapy, and then if you look at the EA1131 trial that was presented last year at ASCO that looked at capecitabine also in the adjuvant phase, you can see apart from the outlier, which is the ECOG 1131 trial, all these regimens were doing very, very similar. Should patients with node-negative disease receive immunotherapy? Because these are the patients that we would think would do better than patients with node-positive disease. Now, when you go back to Keynote 522, you can see that those patients who are positive as well as node-negative did actually very well. If anything, the hazard ratio for patients with node-negative disease is better than the hazard ratio for patients with node-positive disease, again suggesting that both groups of patients are in fact benefiting from neoadjuvant IO therapy. Now, we cannot forget those patients who have a low ERPR expression. And that's the group of patients that we're always debating as to whether to treat them as triple negative or not in our MDTs. And you know, those patients who are ERPR low expression are those patients with an ER percentage of less than 10%. Well, we do know that these patients, and this comes from a large data set from our German colleagues and our Italian colleagues, has categorically shown that those patients with an ER negative versus those patients with an ER low HER2 negative disease, the time to distant recurrence, overall survival, and even pathological complete response is very, very similar to those patients with pure triple negative breast cancer. That means ER negative breast cancer, suggesting that the clinical behavior of patients with ER low disease is very similar to triple negative. And as of now, at least in my practice, if someone has an ER low disease, I will treat them as triple negative breast cancer, but this is an area of debate. And finally, what is the optimal neoadjuvant chemotherapy backbone for our patients with triple negative breast cancer? And the reason why I bring this question up is, should we be giving AC or EC in a dose-dense fashion in our patients? A very interesting meta-analysis that was presented by Elizabeth Mittendorf at the Miami Breast Cancer Conference earlier this year. She actually put all the data together, and it's a very busy slide, but essentially showing that in patients with triple negative breast cancer, they are the ones that benefit the most from a dose-dense regimen. Now, this will have implications if you're planning to give dose-dense AC or EC, and you're going to be giving pembrolizumab as well, because you know pembrolizumab is given on a 3-weekly basis. So you could in fact shift from a Q3 weekly to a Q6 weekly regimen for your pembrolizumab and still incorporate dose-dense regimen, something that a lot of universities are doing in the US. However, in my practice, I will admit I'm still using it as per Keynote 522, where AC is given on a 3-weekly basis. Now, how could we potentially incorporate the use of a PARP inhibitor amongst patients with BRCA mutation positive disease to further improve prognostic outcome? And I think this question is very important because we now do have the results of the Olympia trial, which has shown you that in patients with a BRCA mutation positive disease who have residual disease post-neoadjuvant therapy or who have high-risk disease in the adjuvant setting, when you randomize them to receive either adjuvant olaparib or placebo, they have an improved IDFS. You can see a 3-year absolute improvement of 8.8%, a 3-year absolute improvement in DDFS of 7.1%, a strong trend towards improvement in overall survival with a 3-year absolute of 3.7%. Now, this is updated, and we did have the results earlier this year at the ESMO Virtual Plenary showing a clear-cut improvement in overall survival. Now, when you're putting it all together with CREATE-X, Keynote 522, you can see that, in fact, Olympia has the best 3-year event-free survival, really asking the question that in the presence of a BRCA mutation and residual disease, what is the best strategy in that adjuvant setting? Are you going to give adjuvant olaparib, capecitabine, pembrolizumab, or pembro plus olaparib in that triple-negative setting where patients have residual disease? I think there is no right or perfect answer, but in my mind, the Olympia study is the only one that has shown an overall survival benefit. So this is my last slide, a potential future algorithm in those patients with triple-negative breast cancer, stage 2 to stage 3. If you're going to give them immunotherapy or not, please do give them a platinum-based therapy in that neoadjuvant setting. If they achieve a pathological complete response and you've given them IO, you can continue IO. And you could potentially add olaparib if a patient had very, very high risk features to begin with. In those patients with residual disease with a BRCA mutation, consider strongly using olaparib, and if you have the means to be able to add it in terms of cost, you may consider adding IO therapy or using IO therapy alone. And of course, in the BRCA negative setting, you could think about using capecitabine with or without an IO therapy. So thank you very much.
Thank you, Dr. Shaina, for finishing in time. I think we can have one question from the audience. This one question, we are running a little late.
Guidelines of using neoadjuvant chemotherapy in HER2 positive setting.
HER2 positive. So in the HER2 positive, at least in my practice, anyone above a T1C, so T1C and above, I will give them neoadjuvant therapy, because if you look at the Catherine trial, they did include those patients clinical T1C and above, because we know that if they have residual disease post-op, they'd be candidates for TDM1. However, T1C, I do tend to de-escalate therapy in terms of the type of chemotherapy I'm using. Most of these patients will be given 12 weeks of paclitaxel plus an anti-HER2 therapy in the form of trastuzumab. And higher than T1C, I do give them the whole gamut, usually the TRAIN-2 trial, where I'll give Taxol plus carboplatin, trastuzumab plus pertuzumab. And then, of course, if they've got residual disease, I will give them TDM1 in the adjuvant setting.
Thank you, Dr. Shaina. I think we can have any further questions covered in the panel discussion, which is about to follow. So that was a panel discussion on the management of early stage breast cancer. And we've got a good mix of surgical oncologists, radiation oncologists, and medical oncologists in the panel. And to conduct this panel, we have our good friend Dr. Kaustubh Talabatra, who is the Director of Radiation Oncology at Naravati Hospital. Welcome, Dr. Kaustubh, to come to the stage and call up the panel, please. Dr. Subhadeep Agrawal is a radiation oncologist and associate professor of radiation oncology at IPG India. Dr. Devnaya Rangapatra is a consultant medical oncologist at Apollo Multispecialty Hospital, Kolkata. Dr. Shantanu Chakraborty is a senior consultant radiation oncology at Tata Medical Center. Dr. Shubhadar Chakraborty is a surgical oncologist and a senior consultant at Apollo Multispecialty Hospital. And Dr. Suman Malik is the director of radiation oncologist and director of Narayana Super Specialty Hospital. So I think we have an extremely esteemed panel, and I would just request the panelists to take the time regarding us. Not to wrap up so that we can draw a lot of questions and make this panel thinking of, I will start by saying over 2 hours students, again radiation oncologists, about quite a bit of basics also. So let us go through the basics. So directed to in 0 and 1, it depends on the therapeutic specialty in which you might want to bring that center in at the So before going on to the case, let
resource constraint, it's better that screening continues on this way.
So basically, various guidelines and various recommendations have slight differences. Like if you go to ESMO, they say strictly it's 50 to 69, and they also do not from 50 to 49 and 70 to 74 years. However, benefit is lesser. Having said that, the other guidelines like ACR and US preventive and untested first degree relatives of carriers, screening has to start much before that and usually recommended at 25 to 30 years. MRI for screening. Any radiologists here? We have a radiologist here. Radiologist here.
It is common sense, dense breast, family history of cancer, BRCA of the tumor, BRCA positive plague failure.
Yeah, so this is really the NCCN guideline. They talk about individuals with a genetic mutation or a first degree relative of a gene mutation, individuals who receive thoracic RT between the age of 10 to 30 years. Suman, would you? Jyoti Rup?
Dolapatru, would you use MRI only in selected cases? Because we had a very interesting session by Professor Shorkar, Master regarding screening in India. And as Madam has said that we use MRI screening only for those with genetic mutations, dense breasts, or where the clinical findings don't correlate with the conventional imaging findings.
Yeah. So only in those situations, MRI screening is still not routinely recommended, and I was just insisting where you would be, which are the recommendations where you would consider MRI screening. So this is a point which I found interesting, and I thought I would ask one of the radiation oncologists for individuals who receive thoracic RT, NCCN guideline. This is who receive thoracic RT between ages 10 to 30 years. Would you recommend MRI screening in that subset of patients? Jyoti Rup, Suman, anybody?
See, with the rampant use of MR screening, we can have false positive, more false positive, and the more intervention in the breast. So I think if it's not dense breast, even for irradiated breast, USG or in elderly mammography is good enough. But if there is high suspicion, then we can consider for mammography.
Yeah, so although NCCN recommends it, I do not think in India we are still practicing this age group. And in India we have, as Suman has rightly said, we have made it more individualistic, and you have to use your common sense and your applications to decide whether for this subset would you use MRI based screening or not. So now let us come to the case. One simple case to start with, and we will get on to discussion. So we have a 70-year-old post-hysterectomy lady presented with a screen detected right breast lump. On examination, 3 into 3 centimeter palpable in the lower inner quadrant of left breast and 1.5 centimeter palpable accessory node. No family history. For mammogram, left breast 2.3 into 1.9 centimeter, right breast NAD4 biopsy, IBC grade 2, GRPR strongly positive, HER2/neu1, Ki67 is 35%, PET CT there is no evidence of metastatic disease. Radiologist, anybody we have? No radiologist. So may I ask Dr. Devlina Gangopadhyay to talk about diagnostic workup? Just brief on diagnostic workup.
So in early breast cancer, unless there is a tumor which is say more than 5 centimeters or node positive, will not recommend investigation to look out for distant metastasis. If it is stage 3, say fixed lymph nodes or the size is more, the burden is more, then maybe a CD chest, abdomen and bone scan, or else PET scan will.
MRI for diagnosis of breast. So again, we have talked about MRI for diagnosis. And primarily MRI for diagnosis, since everybody is not in a position to do well, bifocal or multifocal. Or going to our nuclear medicine expert, Dr. Pandey, who will take PET CT in early breast cancer mandatory in all Professor Proctor.
As early breast cancer is concerned, there is a clear-cut evidence that there is no benefit in doing a PET-CT in a stage 1 disease patients. Normal nucleus rhesus is a case. In stage A, it is not yet confirmed what is going on, but it is still the phase 1 is there. After it becomes a stage B disease, there is evidence that doing a PET-CT.
So I'll ask you a very specific question.
Yes.
How important of accident is to do a PET CT?
Yes, sir, definitely.
So, suspicious of elevated sites, painful distant sites, or high burden of accident, high burden of suspicious accident was, these are the three areas where you would recommend PET CT. Do you agree with this?
Right.
So that is about PET CT. Regarding core biopsy or FLSC, can we ask Dr. Saurabh Sarkar to talk about it?
I think Dr. Over basically sometimes students will get see from a typical hyperconstitution is very difficult on the cytology, so we prefer biopsy. And also for detection of immunohistochemistry markers and PI67 also prefer biopsy.
Dr. Sarkar, what's the importance of PI67? Do you assess all samples for PI67 or there is a subgroup of patients where we need to assess PI67?
So basically, it has a significance in prognostication in luminal type of breast cancer. So other than that, it has no use basically for treatment purpose. We are doing this Ki67 mainly for those presenting with high ER receptor and low Ki67.
So I don't think so nowadays anybody does FNC anymore for a breast tube. Yeah, I mean, yeah. Not recognized. The trend is changing. See, when I'm in the medical college and I do get cases still now, but then they keep on saying I need a core biopsy, but only indication of FNC patient when he say you need an urgent something to do a thing. And Ki67 nowadays happens reflex. We are not asking the DR, HER2 and Ki67 comes with the
So role of PET CT we have already discussed. The reason for not asking for a PET CT in early breast cancer or afternoon breast cancer is the probability of to 2% is what most of the literature says. Dr. Sarkar, something we agree with you? Great. Genetic counseling, any difference? Dr. Sohari? Genetic, anybody, doctor, which patient you are sending for these guys are good because I just wanted to give you a refresher for this.
Generally, when there is family history, if there is a history of male breast cancer in the family, or their mother or first relative having breast and ovarian cancer, or triple negative breast cancer below the age of 50, so those are where we go for BRCA testing.
Any woman below the age of 25 getting an ovarian has been something. Very young woman.
So basically, very young age, male breast, diagnosis of TNBC at an earlier age than where it is usually diagnosed. These are the indications for sending or asking a genetic counselor. And germline BRCA1, BRCA2 mutation in this subset of patients. Neoadjuvant chemotherapy versus upfront surgery. So Dr. Suvadi, you were there for the case. Would you recommend upfront surgery in this patient? If it's a 2.7 centimeter mass.
I have to go for a FNAC of the X-ray, no. Whether it has a metastatic quality. If it's not positive, obviously I have to.
Even if you have done a course for the primary, you would still be doing an FNAC for the X-ray.
Generally,
core is there. Core is said it is IDC breakthrough.
The X-ray no could be infective also. It's not metastatic. So if you do a FNAC, that confirms it gives us a NACT upfront. Or otherwise, if
would you be doing that after doing a before for the primary, are we routinely doing a absolute oral FNS?
At times we get patients, we are doing it on a few cases, sir, not all cases. Because if it's not positive clinically, generally we send for NSP. Considering the age and if the node is mobile, I would like to go for upfront surgery for this patient.
So L1 node, do we need to send all patients for neoadjuvant chemotherapy, and if at all, which patient? Dr. Dhammakar.
So if the histology is triple negative or it's HER2 positive disease, patient is fit enough to tolerate chemotherapy, then neoadjuvant. In this case, 70-year-old lady with strong hormone positive disease, operable breast cancer will go for surgery first.
Yeah, so I think this case poses a better, case or a selection criteria for upfront surgery. Of course, if you had a higher nodal burden in the axilla or HER2 neo positivity, TNBC, those are the situations, as she has rightly mentioned, are the situations where you would consider neoadjuvant chemotherapy. When we have a primary diagnosis from the primary tumor, an additional tissue diagnosis from an axillary node is on judgmental basis, and we cannot say to the audience that should be performed routinely. Of course, based on judgment, clinician can take a call and perform. I think that.
Now there is a lot of papers and emerging trend for more role of medical oncology in the early stage breast cancer. Even with the smaller HER2 tumors, you can plan for pertuzumab, trastuzumab based triple negative neoadjuvant. Even some of the IUs have now come up as a neoadjuvant. So people are looking into, even in a smaller tumor, how we can give you the pathological response rate. So I think as far as we are concerned, we have not completely jumped into it, but there is evidence to suggest, yes, we can continue, start with the systemic therapy in a small tumor as well.
So this is, I think this is a sitter breast conservation surgery or mastectomy, so I'll not get into the details. Of course, I think if you have a facility and if a patient is willing, breast conservation surgery is the way to go. What I would ask is, what are the contraindications for breast conservation surgery?
Obviously, the mammogram is showing a diffusely appearing microcalcifications. That means a multicentric disease. And also, if there is some contraindication to adjuvant radiation, in those cases, and also if you're during this surgery, if your persistent margins are positive in frozen section, those are the situation you can avoid risk. And also, obviously, the patients will have to explain that radiation is mandatory after breast conservation. And in early stage, there may be a possibility, though it's not sure that after mastectomy there may not be a need of radiation. So this is patient decisions is the one of the important factor that we have to give them.
So I mean, you can, Dr. Sohani can educate us. Actually, most of us are, the non-surgical crowd here, a lot of non-surgeons here. What is oncoplasty and the role of oncoplasty in operable breast cancer when you are doing breast conservation surgery?
First of all, we have to first evaluate the patient who is not fit for BCS. Saying that there are two types of oncoplasty, where basically is type 1 oncoplasty, where we take the local tissue and move out and reconstruct the breast. In type 2, we take a tissue which is from the other side. It can be from a LD flap, it can be a ALT flap or a thigh flap to reconstruct the breast. The only thing added is that when we compare our studies with the UK and stuff, we see that in UK, whenever they are doing BCS, the contracted breast, they undergo mastopexy also. But in India, when we try to say the patient, explain to them that you might require to have the same contour or opposite side surgery, patients do not.
So breast tumor breast ratio, is that a ratio that you use?
That's the thing. Obviously, that is a thing, and also the position also.
Reconstruction post mastectomy, I think it's a vast topic, and let us follow this, because our radiation oncologists, a lot of them are sitting quiet, and I definitely want to have an interaction with them also. And next we will be talking, we will discuss a little bit about radiation, because we have almost 7 people from the radiation oncology who are there on the panel. So prophylactic bilateral mastectomy in which setting? So quickly, any of the surgeons can take it.
If there is a BRCA1 and 2 is positive and it's patient is willing for it, you have to explain. In Indian scenario, it's a little difficult to explain, and if the patient is willing, then you can go.
So management of axilla, Dr. Santam. is radiation equivalent to surgery? You have two large trials now, results of two large trials. Is radiation equivalent to surgery?
After axillary lymph node dissection,
No, either after axillary lymph node dissection or per primum.
right. Per primum in patient who has a clinically node positive disease, data from older trials suggests to be and
So I'll make it easy for you. I'll give you a scenario. Sentinel lymph node done. Micrometastasis in two nodes dissected, micrometastasis in one. And surgeon has not operated forward.
as per IPCLC, you don't need to give one.
So this was the question, can RT replace AL and B? Anish, do you agree with Santam?
Even for one single node positive, I will keep radiotherapy instead of axillary.
No, the question is radiotherapy to axilla.
Yeah, radiotherapy axilla.
You will give radiotherapy to axilla.
And
So can I have a voting from all the who will do one sentinel node positive? Who will do radiotherapy to axilla among all the six of you, and who would not do? Santam, Jyotirup, Anish, Suporno, Sheila, Suman. You would do radiotherapy to axilla. Okay, and you are not concerned about axillary morbidity. Sentinel node. Shantam, do you agree?
I think there's a nuance involved in this question, right?
Yeah.
This is a 70-year-old ERPR positive, 2 centimeters migrating into one sentinel lymph node and have dissected 3 which are clearly negative.
Not this case. I'm saying any case. One out of two nodes dissected, one positive.
I don't think you can make a judgment like that, Costa. We don't routinely give it yet because our auxiliary class solution we are still developing. Radiotherapy class solution for auxiliary radiotherapy we are still developing it. And so we don't
More than
routinely
half
do
the
it.
panel think they should do axillary radiation in this setting.
If you ask in US, more than half the panel will there also will agree that you should do
Finally,
auxiliary
I have,
radiotherapy.
finally, I have managed to create.
Yeah, but the question that remains is that what are you giving and what are you taking?
So can you just elaborate and
Yeah,
sum it
so
up
if
for
you
us?
basically look at the trial which answers this question, it is the Amaros trial, which clearly shows that if you give auxiliary radiotherapy after a patient who has a sentinel node positive disease, instead of doing axillary lymph node dissection, you do get away with a lower risk of arm lymphedema. It's not insubstantial. It's still there, around 10 to 12% patients still experience arm lymphedema. What they lose is...
But Amaros, the surgeons have always claimed that it was never well powered for recurrences.
That is true for Z11 also. None of the sentinel node trials have been powered for recurrences. Anyway, so what you lose by giving axillary radiotherapy vis-a-vis lymph node dissection is more shoulder mobility. That has been clearly shown in the pro outcomes, which is there unfortunately in the sublimate.
Good, fine. So I think we'll stop it here, this discussion. Move on to the next discussion. So this patient underwent a right BCS with sentinel node biopsy, partial breast reconstruction with a thoracic epigastric flap. These are the reports, 3 out of 17 positive axillary nodes. How would you proceed? Chemo versus no chemo, choice of endocrine therapy, and reducing aspect. Chemo versus no chemo. Do you think this is a patient with whom you would refer something like multiple years? Positive, strongly positive. That's what on the histopathology itself. Same way. So would you also after that? Yeah. So it's so coming to the next question, which cases would you offer after that? Because anyone node positive would you have offered after that?
Computer EX has mainly node negative disease, T1, T2. But there is also a sub-analysis where we have taken into consideration N1 disease, small tumor to see what's the recurrence rates. So whether we are low, intermediate, or high, and along. And wanted to look into whether we can avoid the systemic therapy in this subset of patients.
So computer EX is primarily for node negative
How old is this patient?
How old? She was, I think,
74.
71.
So in a postmenopausal woman with 1 to 3 lymph nodes positive, the RX-Ponder trial, which was a mirror image of the node-negative Taylor-X trial, showed distinctly that if your recurrence score is less than 25, there's no need to give chemotherapy in a postmenopausal woman. So in her 70s, I would really advocate that this woman have Oncotype DX with 1 to 3
So my
positive lymph.
next slide is RX on this trial. And that's exactly what Dr. Shaina has been talking about. So postmenopausal women with 1 to 3 nodes positive and RS 0 to 25 can likely safely forego adjuvant chemotherapy. Having said that, in India, still asking for Oncotype DX in 2 nodes positive and 3 nodes positive has still not become the general trend among medical oncologists. I mean, would you agree with that, Dr. Nita? 3 nodes positive.
We don't do
Right.
we don't do it. No.
But these are the results of RX model trial. And as Dr. Shaina has mentioned, these are the recommendations for postmenopausal and these are the recommendations for pre-menopausal. Endocrine therapy for pre and postmenopausal women, of course, I mean, we all know that it is tamoxifen and AI, so we will skip that. And let us get on to radiation questions now. In which, if this patient was 77 years old, would you have omitted radiation? So, Paula?
Yeah, the thing is, this is a she has a she has a she, if she was 77 years old, and since she has a what, 3 nodes positive, which is N1 disease, I would still consider radiation, but if she was a node negative patient, being ERPR positive.
Anish, can you just sum it up? Which patient would you omit radiation in this subset?
ER positive, strong ER positive, node negative, maybe. Yes.
Age?
This age group, which is 77 years.
Mike?
No LPI, no Hydes factors, and hormone receptor positive, HER2 new negative. They did omit whole breast radiation after BCS in a certain subset of this.
Anti-HER2 therapy, of course, these are the recommendations. Role of adjuvant whole breast irradiation after BCS. What vaccination each one uses in this setting? 2.7 centimeter primary, 1 node in the axilla. 1 node in the axilla. What is the dose vaccination?
So for this category, nowadays we are using fast forward for up to N1 for early breast.
So to do fast forward or moderate height vaccination?
So, for this patient, because she's not positive, I wouldn't be thinking of fast forward actually, because we need to treat the nodes, so that would still be 14, 15.
Which nodes would you treat in this?
So because she
one
has-
node positive,
yes.
would you? So my next question is, in this setting, 1 node positive, would you still be treating the supraclavicular?
Yes, sir.
Axilla we have talked. You would. So all 1 node positives, do we treat supraclavicular or we see the yield to dissected ratio and additional features of LVI and PNI, and then take a combined decision on whether to treat supraclav for 1 node positive out of 14 or 1 node positive out of 8. If that is a clinical situation. Or do we treat it for all comers? Sarthak?
Currently, we treat it for all comers.
1 node positive, all comers. 1 out of 18, no LVI, no PNI, still you will treat it. All comers. Sheila? All comers. Okay.
Not moderate, not fast forward, moderate.
Moderate. Superno, moderate or fast forward? Sheila? Any takers for fast forward here? Santam?
Not outside the trial.
Is Rima there in the audience? Is Rima, your comment please, quick comment. Mike, please, quickly. Mike.
So at TMH also beyond the pandemic, T1, T2, N0 is where we will be using. So definitely postmenopausal.
Even if it's one node positive, no fast forward.
No fast forward.
Okay.
That is because we just don't have the data to support lymphatic irradiation yet.
So choice of vaccination we have talked about, and 40 grade treating traction is your choice of vaccination, or is anyone using your Canadian LTI vaccination 42.5? Is anyone using? Anish is using 42.5. Okay. So, in whom should we consider fast forward? Ideally, left-sided breast cancer, medial quadrant. Otherwise, all your features are fitting well. Medial, lower inner quadrant, say, left-sided. How many of you would consider fast forward? And the second question would be, would you add a boost? I know Samson is running a trial of Samson. I'll ask Samson to sum it up. But currently, with the current evidence available, left inner quadrant, left-sided, 2.7 centimeter mass, no node. Would you use fast forward? And how happy would you be to add a boost to it and finish off the whole protocol in 5 days?
So I don't think that side is necessarily an issue, but the boost is definitely an issue. So I was fortunate and unfortunate enough to be in the UK during COVID, and they changed over to the fast forward for all patients who were node negative. The only difference with our practice is actually with regard to the boost, because they don't boost everybody, whereas we tend to do that for all comers. So that's something which we have to consider regarding the boost.
So is site not a problem? Sarkar, is site not a problem? Left.
If you are doing fast forward, I imagine you would adhere to the constraint before doing fast forward, right? If you cannot, you should not be doing fast forward.
So left-sided, what structures would you be worried about? Anish, Suporno?
Heart.
Heart. What in heart? I mean, what in heart means not the structure. Of course, the structures and what else? Are you worried about pericarditis more, or are you worried about arrhythmia, or are you worried about, left anterior getting damage and related coronary events 10 years down the line?
Yeah.
All of them you are worried about. Are you worried about all of them or
Coronary events?
Right. So are we considering left anterior descending separately and giving constraints to them?
In routine practice, no.
Chapter are we doing? All patients, all left-sided breast patients. Jyotirul, Suman, Suporno.
How do you? Without
There's a way to control it, of course. There is a way to control it, but without contrast also. But are we doing it in our routine practice, all left-sided patients? And should we do it? If not, should we start doing it?
First of all, you tell me, are you using DIBs? Then you should be doing it.
But I think we should be doing it for all patients. Left anterior descending subsequent is for all patients.
Yeah.
It's a previous lung and
Yeah. It takes like literally 2 minutes of time.
it just takes additional 2 to 3 minutes. And the myth about it cannot, it is little more difficult to be controlled on a non-contrast scan. But I mean, most of the recommendations now say that you will be doing it on a non-contrast scan.
There is good data emerging from the Dutch side that LAD is the way.
Arrhythmias, are we concerned about? Anyone?
Unless you are treating the AV node for some reason.
Yeah, but there is data. There is data that late arrhythmias after patients who have undergone left-sided breast radiotherapy, and there is data for arrhythmia also being a concern. So, hypo, can you just, I think Sanjay have a word about it. Are you seeing encouraging results with hypo?
Too early to say over control results. Our anti-toxicity results were quite favorable. So, and we have an interim analysis of the outcome which is due. So once that is done, we should be able to give you that answer that we're looking for.
Fine. So I think time is over. So only last question with the radiation oncologist. In which situation, this is not related to this patient, this is just a question that I wanted to address. In which situations would you avoid radiation post-NSCT in a patient who has undergone mastectomy? Let me be very clear. Patient has undergone mastectomy. Before that, NSCT, and now you have to make a
we do for all patients. We do for all patients.
All patients.
Basically,
So, okay, so two related questions. PCR and upfront N0 status, NHET was given for some other reason, maybe last slide. Upfront N0 status and pathological complete response. These are the directives you have given. In these two, will you still do radiation for all comers or will you avoid in particular patients? Or maybe one of these two percentage. Yeah. So there is a lot of studies which are going on where can we omit radiotherapy in PCR and original N0. Having said that, right now there are no recommendations and right now it is recommended to do radiation for all comers. Rima, are you doing radiation for all comers in this setting?
If not adequately investigated whether more positive at baseline, we would treat all patients with radiotherapy.
So with this we conclude the session. If anyone has any final small comment to make, you are most welcome. Any of them. Great. So I think we have had a nice session. Thank you.
Thank you, Dr. Kaustaf Karapatra and the respected panelists for the excellent panel discussion, addressing very relevant questions. Now, moving forward to the first debate of the day, APBI is obsolete in the era of fast forward. I would like to invite Dr. Vikas Jagtap, Head of Radiation Oncology at Migrants Shillong, to kindly preside over the debate. Thank you.
Very good afternoon to all. Thanks for the session. We'll be going ahead with the debate. The topic is if APBI is absolute, will the APBI will become absolute in the era of the fast forward trial? We have two esteemed debaters. First is Dr. Sayan Das, who will be speaking for the motion, and Dr. Abhishek Basu will be speaking against the motion. And the time will be 8 plus 2 minutes, 8 minutes, and then followed by 2 minutes of rebuttal. So first I would like to invite Dr. Sayan Das. Dr. Sayan Das is a radiation oncologist and senior consultant and head of the department at Medica Super Specialty Hospital, Kolkata. So Dr. Sayan, please go ahead. And please stick to the time. There will be a small bell after 6 minutes and then followed by 2 minutes. Thank you.
Thank you, Dr. Vikas, for this kind introduction. Very good evening to you all. Today's debate is on APBI is obsolete in the, so move with this. So APBI is obsolete in the era of fast forward, and I'll be speaking for the motion. Before I begin, I think there is a larger number of radons in the audience. Just a quick question. How many of you have done, say, more than 5 APBIs in the last 2.5 years since the publication of Fast Forward? Kindly raise your hands, please. More than 5 cases of APBI in the last 2.5 years. Well, so is there any debate at all? Okay, let's still go on because no one is doing APBI, at least in the audience. So I just put up some pictures of these items, and what's common with these items is that all of them were once pretty useful and popular, but now obsolete. And I believe that it's time we add APBI to this list. Why? Let's dig deeper. If you ask me that is APBI a valid treatment option in a suitably selected population? Yes, definitely. But should it be used
in today's era in 2022? The answer for me is a resounding no. So what are the patients who are suitable for APBI? So several guidelines, but overall, so elderly ladies having small tumors less than say 2 to 3 centimeters, node negative, are suitable for APBI. To put things in perspective, if you look at the inclusion criteria of the fast forward study, this group was included in this trial. Now, there are several approved techniques of APBI. Most commonly used are the interstitial brachytherapy or LINAC based. You can use intraocular and Namocite. Let's spend some time with this slide. I've jotted down is a nice summary of all the landmark trials using partial breast irradiation. Look at the first two, the Hungarian study, the Jekistro, they used brachytherapy with compared to whole breast radiotherapy, similar local control, better cosmetic outcomes, accepted. The Florence study used IMRT, so a LINAC-based APBI. They also showed similar local control with slightly better cosmetic outcomes. The IMPACT trial was not exactly APBI, but rather PBI. Target and Elliott used intraocular radiotherapy, several issues with those trials, and they had slightly increased risk of local recurrence. Let's come to the last two. The RAPID trial, which used 3D CRT, twice daily fractionation, and what it showed was, although local control was similar, but the cosmetic outcomes were worse with APBI, which kind of says that probably 3D CRT is not the way to go. The largest of these studies was the NSABP study, 4,000 patients, which used either LINAC-based or brachytherapy. It did not, it's a negative trial because it did not meet the pre-specified equivalence criteria. And most importantly, APBI did not improve cosmetic outcomes. So to summarize, so there is level of evidence of non-inferiority of using PBI with brachytherapy or LINAC-based. However, probably 3D CRT is not the way to go. It may lead to worse outcomes based on the RAPID study. IORT leads to increased risk of local recurrence. Now, there are several issues with APBI. Let's take one of them one by one. Starting with brachytherapy. It's very good talking about brachytherapy in academic meetings, but whenever I ask someone, are you actually doing it? There's an eerie silence. Why? Because it's complex, it requires a lot of training, expertise, steep learning curve, and it requires a multi-department collaboration. You need a final histopath report ready within 3 to 4 days. I think TMH is the only center that has been doing it for ages. And even in TMH, in the last 2 years, they've done only 2 brachytherapies. So it's time we call it obsolete. APRT, preferably IMRT. Target volume dilation is a challenge. Those who have done it know it very well, especially patients undergoing oncoplasty. And if your surgical colleague doesn't put the clips in proper place, it adds to the confusion. Just a representative diagram. IMRT is not easily available. You don't have a final HPR when you're doing the procedure, and there's an increased risk of local recurrence. So why take so much problem when I have an easier, simpler solution for you, which is this one. If you are asked, name one study that has been practice changing in the last decade, I would say this is the one in the field of radiation oncology. We all know it's a randomized trial that compared 14-15 versus 2 1-week schedules, 27 or 26K in 5 fractions. These were the dose constraints. They used tangential pair beams. And if you feel that these dose constraints were difficult to achieve, I'll just share this study, already been discussed, the HYPO trial. They presented their initial safety results. Their dose constraints closely match that of fast forward, and they have shown that they were able to achieve with field-in-field arrangements in almost 100% of the patients. For left-sided, I would suggest you use cardiac sparing techniques which are nowadays available, which can lead to reduced cardiac doses. For setup verification, they used electronic portal imaging with MV or KV X-rays for 5 fractions. They said it has to be done daily. See, the primary endpoint, what ipsilateral breast tumor relapse. The curves are almost hugging. They could claim non-inferiority for both the test arms. However, for cosmetic outcomes, what was seen that the 27 gray arm was worse, but the 26 gray arm kind of was similar to the 40 gray arm, both for clinician assessed as well as for patient reported outcomes. So to summarize this study, both schedules were non-inferior, normal tissue effects, 26 gray was similar to the 3-week schedule, and the 1 week is obviously more convenient for the patient, substantially less expensive, and for the patient as well as for the health service globally. However, what I feel is there a lot of reluctance among the radiation oncologists for clinical introduction of extreme hyperfractionation, not only for breast, but for prostate and rectum as well. But we must accept that extreme hyperfractionation is a concrete reality. Probably people are skeptical of the results, they want long-term results, and probably delayed information flow, which is why we need more such debates. Infrastructure and financial challenges, as I showed, there is no added cost. To address the concerns for late toxicity, what these several landmark trials of using moderate hyperfractionation and extreme hyperfractionation shows that the changes appear early, which kind of stabilize over the years. The Valiant trial, you see 5 years and 10-year results were almost similar. The STAR-P trial as well, the hazard ratio between the for breasting between the two arms, 0.83 at 5 years, 0.8 at 10 years. So it kind of remains the same. The absolute values may increase, but the relationship between the arms remain the same. Same for fast trial as well. The RAPID trial, the significant difference in cost mass is shown by 3 years. It's kind of stabilized by 5 years, which kind of moves on as time progresses. BOOST trial, 20 years follow-up. We look at the results, 10 years, 28% versus 13%, remains the same at 20 years, 30 versus 15%. STAR-B showed that ischemic heart disease and symptomatic lung fibrosis and even rib fracture were rare and not really different between 5 and 10 years. So don't wait for 10 years. Start practicing fast forward. Before I finish, the UK consensus statement already has mentioned. Look at statement 4 that offer 26 and 5 partial breast radiotherapy. Before I finish, this picture I think perfectly sums up the current scenario. Thank you.
Thank you, Dr. Sai. We just finished in time. So I request you to please be seated on the front only. And I next request against the motion, Dr. Abhishek Basu, who is the Associate Professor in the Department of Radiation Oncology at Bardhaman Medical College and Hospital. Thank you.
So at the outset, I would like to thank Dr. Prashanjit Chatterjee and Dr. Shayan Pal for giving me this opportunity. And it's always fun to debate on a Saturday afternoon, and even more so when the debate topic is very loaded. So it's not any fun to debate something which has no spice in it. So what I'll try to do in the next 8 minutes is to give you the overview of why I think APBI is not obsolete in the era of fast forward. And just to start, I think, although I could have put both our pictures here, I think it is important that I looked at two of these great surgeons who have completely changed the paradigm of how we look at breast cancer, and I'll come to it why I have put it. So, APBI is obsolete in the era of fast forward. So, this is the thing that we are trying to debate, and obsolete, as we all know, for the sake of just wondering on it, no longer produced or used. So, it is nowhere used across the world. So, that is the thing that we are trying to debate. So, what are we actually debating? Even my 4-year-old daughter actually knows the difference between these two shapes. One is a whole and one is a part. And coming to the question of volume, I think every student of radiation oncology is well versed with this concept that even a 5 millimeter thick pill of the orange leads to almost the equivalent volume. So essentially, in radiotherapy, we are trying to reduce volumes across the board when we are trying to treat. Of course, in this case, maybe not, as my learned opponent just told us. The only similarity, mark my words, the only similarity between these two regimes is the treatment time. And that is
about 5 days, which is the external, or I mean the fast forward, as well as most of the cases of APBI. But as we'll show in the few slides, there is a hole in the hole. Again, it is important to note that we are not debating. We are not debating whether APBI is better or worse compared to fast forward. We are only debating APBI is obsolete in the era of fast forward. And of course, we can take picks as to who is best with a preconceived notion, but that is not what we should be doing. We should actually be debating in the spirit of harmony, as we can see two arch rivals here, and perhaps not like this. And I hope certainly we would not do this. Coming to the historical evolution of breast radiotherapy, and this is again a seminal paper which all surgeons know. Important to note that breast conservation surgery actually led to increased local recurrences but did not impact overall survival. And this has completely changed the paradigm of treatment of breast cancer in terms of surgery. And we also know from here that these recurrences occur in the index quadrant, in the vicinity of the primary tumor, which has led to the entire change in the concept of delivering radiotherapy, where the dose of action has perpetually increased, the treatment time has gone down, and the treated volume has also gone down. Whether you do the question of whole breast, we are trying to decrease the volume. Even when we are doing a boost, we are trying to decrease the volume. And this is how it has evolved. So I'll skip over this slide quickly because my opponent has already shown you this. The evolution of breast radiotherapy coming to the UK FAST trial and then to the fast forward trial. But before we move to the question of APBI, it is important to ponder on some aspects of the fast forward trial. There were protocol amendments made in the trial to actually exclude the very low risk patients. There were questions raised by the trial authors already whether it was generalizable, and that point was alluded to by Dr. Chatterjee in his talk previously. Post-mastectomy therapy in the selected group of patients was used only in 6 to 7%. Boost, most importantly, was not given to all. It was left to investigator discretion, and only 2/3 of the high-risk patients received a boost. Novel irradiation again was not allowed in the main study. I know there's a sub-study, but we don't have the results out yet, and no formal subgroup analysis was done. And as we look at this, it is very important that only one gray increment actually led to detriment in the local, in terms of the late toxicities, and this is important if you look at the BED values. We already have the HIPOT, the early toxicity data is there. I think this is possibly, if I may say, a better design trial, because that will also be looking at boost within the primary radiotherapy and also non-early radiation. Coming to the different types of APBI, which has already been shown, so I'll skip over these trials. Definitely, there is no question that APBI is not for all patients. Again, the fast forward is again also for not all the patients. This is something that we need to be very cognizant about. It is for a selected group of patients, and we have to appropriately select out those patients who are candidates for either of these treatment regimens that we do. And this is important, especially for people who are starting on the learning curve, either for the fast forward extreme hyperfractionation or for APBI. These trials again have been shown by my learned opponent. So what I'll try to just quickly run through is what were the problems of the earlier APBI trials and what were corrected later. So brachytherapy trials were definitely better because the volume of irradiation was small. And coming to whether you use brachytherapy or not, I think this is more or less the same case even for using interstitial brachytherapy for carcinoma cervix, where it is a mandate. So it's entirely a matter of practice. I would slightly differ from my opponent in saying that you do not use brachytherapy. I have myself used breast brachytherapy in a number of patients, including APBI. Coming to rapid, definitely there were more toxicities, but that was because the dose was more. And we know that even one-grade dose led to inferior cosmesis in the fast forward trial. The NCBPB39, a trial whose design has been widely criticized by many, including a very beautiful paper by Chirag Shah in brachytherapy. And we know that the final outcome results have only been reported in abstract form. Okay? It was a heterogeneous trial, and the outcome that they were looking at was not properly designed. So that was the major issue with this trial. Coming to the second generation trials, which were using RMRP photon, you can see clearly that these trials were positive. In terms of definitely there. And resoundingly, I would say that APBI is here to stay. There are meta-analysis of APBI which actually look at the more than 10,000 patients in different scenarios, and they have said clearly that local control is equivalent and toxicities are lesser. And there are unique clinical scenarios actually. Although these are small reports, where APBI can be used in patients not suitable for external beam radiotherapy, where you want to further reduce the cardiac dose, especially with brachytherapy, in elderly women who would not otherwise be candidates, or where you want to use very accelerated APBI, 3 fraction 7.5. These are reported in good journals, although may not be outside of clinical practice. So in summary of APBI, there is clear rationale to treat. Certainly it is not for all, but in suitable patients it's a good tool, and the evidence I think is robust, and if I may say, is more than the fast forward trial, because both in terms of time and patient numbers, fast forward still needs to be implemented for generalizability. And interestingly, a number of premier organizations all across the world clearly endorse APBI as of 2022. Coming to the ASEAN guidelines, which my opponent also showed, you can see very, very clearly that they clearly said that cancer-based irradiation in terms of the input load, I completely agree that this is part of APBI, but it is definitely the partial breast, not the full breast, is important, and 84% of the patients said that it is completely relevant in 2021. Now the question is, how do we practice it? Obviously, how do we want to evolve? We want to evolve like this, or this is completely up to us. So I would say that we would want to definitely practice it. It's not this that you want to equal up the answer by force. If you want to practice APBI is completely relevant, and because of that, I did one last thing. I thought, because Dr. Mara Pant was not coming to this meeting, I thought of mailing him. And this is the answer that Dr. Brandt actually gave me. So I think this summarizes the debate. There's no more debate here because the PI is clearly saying that APBI is still relevant for appropriate breast cancers. So it is acceptable, pragmatic, and maybe I'll end here by quoting Dr. Robert Hutchison, very well-known quote, from inability to let well learn, from too much zeal for new, and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense. Good Lord deliver. Thank you.
Thank you. I request Abhishek, please be seated. Now is the time for rebuttal, and I request Dr. Sain Das to please come forward. And please stick to the time. Abhishek, you are a little bit over the time.
Right. So thank you once again. Just a few points. My learned colleague was kind of trying to find faults in the fast forward study. He was alluding to very few test wall patients. The study of nodal irradiation is not yet available, but that's not relevant for this discussion at all. We're talking about APBI, not post-mastectomy patients, not node positive patients. This did exclude the low risk group of patients who probably do not need radiotherapy, leave alone APBI or fast forward. So again, that's not relevant. The latest study, yes, there were issues regarding methodology, but bottom line, APBI did not improve cosmetic or outcomes or late toxicity. Brachytherapy, yes, it all depends on practice, but my question is, who are practicing it? Nobody, excepting few premier centers. So it requires a lot of training, skill, and unfortunately we lack that. We better accept it. And when you have a much simpler solution, why go after such complex techniques? My colleague did show some small studies where EBRT is not feasible and all those, but comparing such small single-centered studies vis-a-vis well-conducted phase 3 randomized trial, I'll leave it to the audience. Thank you.
Thank you, Dr. Sain. I request Dr. Abhishek to come forward for the rebuttal.
So again, just to make it very simple, I think we are confusing the topic, right? So the topic was whether APBI is obsolete. The question is not comparing APBI with fast forward. There are clear niches for both. It should be a question of the person who's treating the breast cancer to select whether partial breast irradiation would be required or whole breast radiation would be required. So the moot question of what we are discussing is this. Coming to the modality of giving APBI, again, that is completely left to the person. My learned colleague already showed you clearly that using electron and intraoperative, which are also forms of APBI, have clearly been shown to be inferior and have gone out. So we have to select the best form of APBI versus the best form of whole breast radiation and then do a comparison. Unfortunately, as has clearly been mentioned both by RCR and by Dr. Mario, such a study will not be at least designed by the Royal College because they already have the input law as well as the fast forward, which were designed in parallel, and they are very confident in their statement, stating that both partial breast as well as whole breast are relevant options. So the only moot question that I would like to say is that something which is being less used is not obsolete. Do not say that APBI is obsolete. It is a valid option. It's completely up to the audience to choose whether they would be using fast forward versus APBI. And just to give you an example, there were 7 radiation oncologists on the panel, the early breast panel just now. The question was asked regarding APBI. I think 2 persons raised their hand among 7, and only one of those 2 said that they would be using it outside clinical trials. So the majority of radiation oncologists faculty in this conference, they are not using the fast forward regime. In spite of using, so all of them said it's moderate hypofractionation. Does that make fast forward bad? No. It's just a question of practice. So that's my case. Thank you so much.
Thank you to both the speakers. So just we need to improve the brachytherapy skills in the current era of technology. I will not announce the result. I'll just ask the audience who feels that it is absolute in the area of fast forward. Just raise their hands. And who feels that it is here to stay and it will continue till the long time. So the result is great. Thank you so much. Thanks to both the speakers.
Thank you, Dr. Vikas Jagtap, Dr. Sayan Das, and Dr. Abhishek Basu for the excellent debate. Now, moving forward to the next session, I would like to request our experts to kindly come on stage to chair over the next session. Dr. Nitin Nahar Biswas, Professor and Senior Consultant in Radiation Oncology, Apollo Multispeciality Hospitals, Kolkata. Dr. Suparna Ghosh Ray, Professor and Head of the Department, Radiation Oncology, Badwan Medical College, Badwan Medical College, and Dr. Santanu Acharya, Professor in Radiation Oncology, Arjikar Medical College, Kolkata. Another announcement, there is no official tea break, but tea, coffee and snacks are available outside from 4 to 6 p.m.
the first speaker of this session is Dr. Rosina Ahmed. She is well known to us, practicing as surgical oncologist and senior consultant at Tata Medical Center, Kolkata. Oh, yes. Oh, okay. So Rosina has some problem with the technical problem. So we would call the second speaker. Second speaker is has he come online? Oh, Dr. Sudeep Gupta. Sudeep Gupta, medical oncologist and professor of TMH. He is not present physically. He will give his presentation through the webinar, and that is being it is being prepared. And after completion of Dr. Sudeep Gupta's presentation, Rosina will come. Okay. Is it ready?
Okay. After an excellent debate, we are going for the next session. Our next session is with surgery, and the well-known speaker is Dr. Rosina Ahmed. He is now ready. There was some technical glitch at that. In the meantime, it has been corrected, so she can deliver her lecture. Okay, sorry, Dr. Sudeep Gupta will take our conversation first. It is on TNBC, the many phases of TNBC.
Participate in this excellent conference. The many cases of triple-negative breast cancer, a wonderful and evocative title of my talk. Those are my disclosures. Several years ago, we conducted an audit of consecutive cases in our institution in one calendar year and found that in contrast to Western population, TNBCs constituted almost one-third of our patient population. The phenotypic heterogeneity of TNBC has long been appreciated by pathologists, and you can see the common, the not so common, and the rare varieties of breast cancer depicted on this slide. But more recently, using gene expression profiles as well as mutations, we have begun to understand the molecular heterogeneity of TNBC. This has been stated several times in the past, but let me say it again. The basal-like and triple-negative breast cancers share substantial overlap but not complete. There are several other classifications of triple-negative breast cancer. The widely quoted Lehman classification or the Vanderbilt classification, the Metacritic classification into integrated clusters, and in the latter, most of the triple-negative breast cancers fall in integrated clusters 4 and 10. Lehman and colleagues revised their classification in 2016. From the 6 subtypes, they revised it to 4, and it is instructive to learn as to why they did so. Transcripts in the previously described immunomodulatory contributed from infiltrating lymphocytes and tumor-associated stromal cells, respectively. And therefore, these two subtypes were deleted from the subsequent classification. And a very important lesson that tumor microenvironment contributes to molecular profiles and must be considered when we undertake molecular classifications. In terms of DNA, TNBCs carry on an average about 1.68 somatic mutations per megabase of coding regions, about 60 somatic mutations in each tumor, but this is not uniform across tumors, ranging from high to low mutational burden in various tumors. There are frequent pathological alterations involving genes that may lead to multiple pathway alterations. There are several studies, but this is the one that I like the best because I think among all, it is most apt to depict the many phases of TNBC. And there were 4 TNBC cases subjected to deep sequencing. There was a wide and continuous spectrum of genomic evolution, hundreds of mutations per tumor to very low mutations in other patients, marked variation in copy number differences between cases, only 1/3 of mutations expressed using RNA-seq, and very importantly, TNBCs varying widely in their clonal makeup at the time of diagnosis. The case on your left has 3 dominant clones, the case on your right has 5 dominant clones at the time of diagnosis. So TNBCs well and truly come in many hues and many varieties. The ecosystem of this tumor can be thought of as a cancer cell. DNA repair defects closely related to mutational burden, microsatellite instability, several known pathways such as the PIK3 pathway, proteins that have begun to be useful targets for treatment, and several uncommon and rare mutations that can occasionally be therapeutically useful. The environment comprising of stromal cells such as the fibroblasts and the cancer-associated fibroblasts, but very importantly, various kinds of immune cells that infiltrate or do not infiltrate a particular tumor. So we can therapeutically exploit the TNBC ecosystem starting from cell surface to intracellular signaling pathways, intranuclear pathways, and the DNA damage response system itself. How about exploiting the immune environment with cells has been an important consideration, but now also where they are located, and single cell, high resolution single cell techniques with spatial resolution capabilities have begun to provide important insights into this theme. So various immune cells, the regulatory T cells, the helper T cells, macrophages, others, how abundant they are and how they are distributed into the tumor has begun to provide a description of tumors from being hot or fully inflamed to immune deserts that hardly have any immune infiltration. A very important consideration is the fact that TNBCs are not immunologically frozen during their life history. The primary tumor is immunologically warm or hot with higher antigen presentation capabilities, reduced clonal diversity, higher immune cell infiltrate, and many of these findings reverse in metastatic tumors, especially multiply treated metastatic tumors, and also importantly, reduce expression of genes that encode for antigen presenting machinery that are listed here, such as the MHC class 1. So there can be immune exhaustion and depletion. There can be infiltration by immunosuppressive macrophages and exhausted T cells. Genes can be expressed that are involved in various immune escape mechanisms, such as the ones that are listed here. And to compound matters, metastatic sites such as the liver are most immunodepleted and immunotolerant, making them particularly difficult sites for immune targeting. The PDL1 scoring system itself, from the clinical and therapeutic point of view, has been a point of contention for quite a while now. Different antibody clones choose whether to score the immune cells or the tumor cells or both. And there is some perhaps substantial overlap between various scoring criteria, but not a complete overlap, and therefore each treatment has its own companion biomarker. So monotherapy with immune checkpoint inhibitors has shown modest responses in patients with metastatic TNBC, but it has been very instructive from the point of view of biomarkers and has shown that with all the caveats and all their weaknesses, criteria such as the PD-L1 scoring does have some predictive capability as we move forward. So how to create rational combinations with immunotherapy? I think the partner should increase antigenicity and reduce immune escape, perhaps reverse the mechanism of resistance, and of course must be tolerable when given along with the immune checkpoint inhibitor. And several classes of drugs, chemotherapy, PARP inhibitors, ADCs, etc., fulfill at least some of these criteria. So combination of immune checkpoint inhibitors with chemotherapy, I will not go into the details of these studies because they have been shown many times over. This is the Impassion 130, atezolizumab compared with placebo in combination with nab-paclitaxel, significant improvement in progression-free survival in the ITT and PD-L1 positive patient population, but no improvement in overall survival in the intent to treat population. There was some evidence that perhaps the PD-L1 positive population did benefit by the addition of atezolizumab, but by the rules of hierarchical testing, this was not a common statistical comparison. The confirmatory study, Impassion 131, no benefit in either PFS or OS, either for PD-L1 positive or the intent to treat population. I think in all conferences, it is the idea to try to reconcile these contradictory results. So therefore, I will not recount all of them here, except to say that my own take is that we don't really know. And also, I would like to provide my 2 points bit about the possibility of chance. The results of Impassion 130, I would like to submit to you, never formally proved that overall survival was significantly higher with atezolizumab in the PD-L1 positive population. The comparison that is often depicted, which I just did a couple of slides ago, should not have been done by the rules of hierarchical testing. These rules exist to reduce the probability of making a false positive conclusion, and therefore, in my opinion, at least with respect to OS, there is no formal discrepancy between 130 and 131. Atezolizumab, Keynote 355, very similar design, no significant improvement in the patient population with a CPS score of more than or equal to 1, but a significant overall survival benefit in those with CPS more than or equal to 10. And the subgroup analysis confirms that the benefit is confined to patients whose tumors have a CPS of more than or equal to 10 as measured by the DACO antibody. So those are the various features of the Impassion 130 and Keynote 355. My own take is that this is likely to be a difference between pembrolizumab and atezolizumab rather than the other points that are listed on this slide. So there is a definite signal of activity of immune checkpoint inhibitors in combination with chemotherapy, at least in a subgroup of patients. But the predicted biomarkers are far from ideal and somewhat limited with the precision in oncology. We are using PD-L1, but there are several other things that we know about prediction. Perhaps all of these, or at least some of these, need to be combined in an integrated score that will perform better than PD-L1 testing, which we use at the current time. Furthermore, new combinations are likely to modify the current treatment recommendations in the very near future. Exploiting DNA-repair effects, we already know about platinum from many studies that have been done in the past. More recently, we have the PARP inhibitors. 2 important studies, again, have been known to all of you, the Olympiad trial patients being platinum naive, benefit in progression-free survival, but no overall survival benefit, and better quality of life with the PARP inhibitor. EMBRACA study with talazoparib, again, no platinum in the control arm despite 80% of patients being platinum naive, benefit in PFS, but not in OS, and better quality of life with the PARP inhibitor. In India, these results seem to have increasing importance. This is a study from my colleagues in AIIMS in Delhi. Consecutive patients of breast cancer, 236 of them, 18.5% had pathogenic or likely pathogenic germline mutations in a variety of genes. 2/3 of these were in BRCA1 and BRCA2, but very importantly, 1/3 of these were in a sprinkling of other genes that are shown to your left bottom on this slide. So, what about the use of olaparib in patients with mutations in other HRD genes? In terms of germline mutations, PALB2, patients with PALB2 mutations do seem to derive some benefit from the use of PARP inhibition. In terms of somatic testing, BRCA1 and BRCA2 seem to indicate some benefit of these drugs, but other mutations such as ATM and CHEK2 perhaps not predictive of benefit. Several other HRD scores, but none of them clinically useful and ready for prime time at the current time. So, from the efficacy point of view, I would say that the results of PARP inhibition in metastatic TNBC are underwhelming, especially considering the fact that platinum was not even allowed in the control arm. PARP inhibitors are expensive and not completely devoid of toxicity. Their proper sequencing with platinum is unclear. I would say that they are a reasonable option when easily available, but I wouldn't fret if they are not easily accessible. Targeted delivery of a toxic payload, antibody drug conjugates, several physicochemical properties of these conjugates that have been described for a variety of conjugates, and I will not recount them here, but they are important in the therapeutic ability. So this is the phase 3 study of sacituzumab govitecan. Patients with more than or equal to 2 prior chemotherapies for advanced stage TNBC, and those of us who treat this disease know that this is a heavily treated population with very poor prognosis, randomized to sacituzumab govitecan or treatment of physician's choice, which could be one of these 4 chemotherapy drugs listed here. Both for progression-free and for overall survival, there was a statistically significant and clinically meaningful improvement with the use of sacituzumab govitecan. The survival of 12.1 months with this drug. I would like to request your attention to this number. Not too long ago, this used to be the average survival of patients with first-line metastatic TNBC. So, well and truly, substantial activity of this drug in this disease in this setting, manageable toxicity. There are several other antibody drug conjugates targeting a variety of cell surface antigens that are listed here in this table. But how to improve the outcomes that we have achieved with, for example, with sacituzumab govitecan, and the outcomes do need improvement. Many patients respond, but not nearly deep enough with this drug. So perhaps combinations with what? We know, for example, with sacituzumab govitecan that SN38, which is the payload, is a DNA targeting agent, a topoisomerase inhibitor, and it would make sense to combine this with another agent that damages the DNA, such as the PARP inhibitor, and such studies are ongoing. Other targets, the androgen receptor axis, occasionally useful, but in my opinion has not really lived up to its original promise. However, one important fact is the presence of PIK3CA and AKT mutations in this subtype of triple negative breast cancer. So perhaps the combination with inhibitors of this axis might might be useful, and some studies are ongoing to exploit this. AKT inhibition, promising one phase 3 study with ipatasertib negative, the other phase 3 study with capivasertib awaited. This is our own study where we looked at few patients whose tumors were longitudinally sampled over time. All of them had triple negative breast cancer, and two out of those three had a germline BRCA1 mutation. The tumors and bloods at each of the time points were subjected to deep sequencing for whole exome, whole transcriptome, as well as synthesis. What we found is that truncal mutations that are present in the original tumor persist throughout the life history of a tumor, but gives off daughter clones at various time points, perhaps correlated with Darwinian pressures exerted by chemotherapy that is given at each time point. Somatic copy number alterations increased in these tumors over time, and also very importantly, circulating tumor DNA completely captured the clonal architecture of evolving cancer in these three patients. So the study is about to be published. We conclude that metastatic TNBC rapidly evolves over time in any given patient, and also tumors in different patients are substantially different from each other. So there is inter-patient heterogeneity, there is intra-patient heterogeneity, and these considerations will present exceptional challenges to all treatments that we devise for this for TNBC. These are several drug classes that, including local treatments that we can use. You can see the interconnections, the combinations that are being investigated at the current time. Several arrows converge understandably on the immune checkpoint inhibition. But what is most required are predictive biomarkers that have a high positive predictive value and a very high negative predictive value. And I think that single cell techniques, including those involving spatial resolution, repeated liquid sampling, as well as artificial intelligence, will improve the biomarkers that we have at the current time. My final thoughts: Dobzhansky said almost 50 years ago that nothing in biology makes sense except in the light of evolution. Over a period of time, I have come to appreciate the force of this statement. Where were we in the past, and will this understanding help us gaze into the future? This is a cartoon that I drew not too long ago for another meeting. On the y-axis is progress, however defined. On the x-axis is time. Progress can be linear over time, exponential, begin to plateau. Which trajectory are we following at the current time? But also, very importantly, where are we at present on the arrow of time? And only with some understanding of these two points will we be able to gaze meaningfully into the future. And I think this is very true of metastatic triple negative breast cancer and triple negative breast cancer in general. I end by mourning the loss of a genius who brought joy to millions of his fans, including myself. Thank you very much for your attention.
So you can ask questions. Dr. Gupta is very much.
So I always agree with anything that
Dr.
Sudeep
Sudeep,
says, and I always
there is a
disagree with
question.
everything that he says as well. Can you hear us, Doctor? Can you hear us?
Yes, yes.
Yes, we can hear you. So, what are your thoughts on the use of PARP inhibitors in both metastatic and early stage breast cancer in the triple negative setting?
Extremely so, and if I cannot use them, I don't think patients are being harmed to a very great extent, at least in the metastatic setting.
So in the metastatic setting, in the triple negative setting, do you think that the trials, and I completely agree with you, I think Olympia D and the Embraca trial, I think the reason why there was only a modest benefit and no overall survival benefit was because of the timing for the use of the drug. Do you think if it was used much earlier, we would have seen a bigger benefit?
That's a speculation, and I think that when we should perform the study that you are proposing, we should do it. And once we have proof of the results, then we can have a discussion.
So there was a subset in the Olympia D trial that there was an overall survival benefit if they had used it pre-chemotherapy. What are your thoughts on that?
I have said it many times earlier, and let me say it again, that whenever you chop up the data in one or more ways, you introduce a very high probability of making a false positive conclusion. And which is why it is taught to all students in their initial learning that one must not chop up the data in many different ways and then fish out some results. So it is interesting. I have noted that I know about the data, but I don't think it will have an impact on my practice.
Good evening, sir. This is Joydeep here. Sir, do you suggest that we use Pembro plus chemo in the subsequent lines if the patient is a CPS high?
By subsequent lines,
You mean somebody, yes, sir, somebody who is like in the third line or the fourth line situation, and we have a CPS score high. Can we add Pembro with chemo in that setting? Oh, thank you.
That's my own take on that. I think that there are some translational studies suggest that there is increasing immunodiagnosis, which I also refer to in my talk.
Hello, sir. Rima here.
Yeah,
Hi. I just wanted to know when will we start, making the molecular subtypes of TNBC more actionable? Like we don't really do the molecular classification yet. I don't see any companies trying to make drugs for a specific subtype. Do you think that it is far down the future? Do you think it is a waste of exercise? Why is it that we are not exploiting that as of now?
That's a very good question. It's not that it is useless. There is a biological understanding that we develop when we do the Lehman classification or the Metathric classification, for example. It is just that I showed you in our own study, there is exceptional interpatient heterogeneity. And even patients, for example, within the immune subgroup of the Vanderbilt classification, no one patient is similar to the next one. So unlike other cancers such as HER2 positive or even ER positive breast cancer, TNBC presents challenges that is at least in order of magnitude higher. So it's not that people are not interested, it is just that the biological understanding is not being translated into actionable outcomes.
So you think a better classification using more complex pathways are in order, or how is it that we see this in future being implemented in clinics?
See, just now, if I look at our own study, I find that three patients will have three different tumors. And if you look at the study by Surab Shah and colleagues that was published in Nature, they had about 104 patients who will fall into 60 categories. So the problem is that it is not that people are not trying, and even more complex classifications may not necessarily become actionable. It's just that we have not really hit upon what shall I say, the Achilles heel of this tumor. So that's still an ongoing quest.
Thank you, sir.
Congratulations, Shudip. You were absolutely audible without any lag time or an echo. So that was a good hybrid session. One question to you. How many percentage of de novo TNBC metastatic cancers do you see in your clinic, sir?
They're not very common, but I try to include them into some ongoing studies. I find it hard to get such patients. I cannot give you an accurate answer, but my guess is that they might be about 15% of our patients.
And here there is an immense role of sacituzumab, and I think you should give a take-home message to the postgraduates over here, because as we know about this drug, this is certainly a magic drug in this subset of patients. So what is your take-home message for the young postgraduates?
So I am not certain that it's a magical drug. It is useful and it has produced very nice results in hard to treat patients. I'm not really sure whether it is magical yet. I don't think we can call it magical until the time that, like trastuzumab, it begins to cure more patients with triple negative breast cancer. And there I agree with Shanita that the use of olaparib in the early breast cancer, the non-metastatic triple negative breast cancer, is a useful outcome because perhaps more patients are being cured of it.
Thank you, Dr. Sudeep, for the excellent interaction. And now I request Dr. Rosina, please come over and give your presentation.
Sorry, there seem to be a few little technical issues. Thank you very much for inviting me to talk about this rather interesting topic, which I think goes beyond just what we do as surgeons and crosses over into what a variety of different medical oncologists are doing. Right, okay. So back in the early 90s, first the BRCA1 and then the BRCA2 genes were described. And this created a shockwave because these were the first genes that were ever found to be causative of breast cancer, of any cancer, in fact, not just breast cancer. And so it went from scientific literature to the lay press. And this is the article that came out in the New York Times when there was this first cautious announcement that there was a gene that might cause hereditary breast cancer. The woman who did the research, Mary Claire King, talked around the world about this, and this photograph on the right is when she talked here in Kolkata a few years ago. And then 20 years later, there was another announcement, and this time, instead of going from scientific literature into the lay press, the announcement was in the New York Times. And of course, the Angelina Jolie effect is something that has changed the perspectives on gene testing and on the way women see gene mutations. Look at what happened. This is where surgery started to change because of genetic testing. Before her very public announcement, down here we see the number of patients who had unilateral or bilateral mastectomy, And suddenly, as soon as she had announced this, the number of patients having bilateral mastectomies went up, and it has continued to do so. So what are these BRCA genes? Well, they are tumor suppressor genes, and they're associated with the incidence of breast or ovarian cancer. But it's important to realize that they're not associated with the outcome of disease treatment. Apart from these two well-known genes, there are a whole lot of other genes which are spread across the whole genome. And it's important to remember these as well, not just concentrate on the BRCA genes. The recommendations for which patients should have testing is evolving with time. It's just getting to be a longer and longer list. But basically, testing falls into three different groups. You can test a person because of their personal history of breast cancer, such as young patients, triple-negative patients, male patients. You can test them because of their family. So cancers of the same or different kinds in other members of their family, or if family members are known to carry a mutation. And increasingly, there is some change towards testing for the purposes of changing treatment. As you will notice, surgical planning has not come into these guidelines yet, but they are still in evolution. In fact, if you look at family history and at cancer biology, actually just looking at family history, using the sort of tools that are available to us shown on the right, a large number of people who carry mutations may actually be missed. And so it's important to look at the type of cancers that patients have before deciding whether they need to be tested or not. Now, to understand all this, there is data, a little bit of data from Indian patients. This was the first study of about 1,000 patients, but for young patients, almost 40% of them had some kind of a mutation. You heard Dr. Sudeep Gupta just talking about the number of variations of unknown significance, and that was high in this study. And it's also true when we look at the data from our hospital. 51% of our patients had a mutation, but 1/3 of those mutations were of unknown significance. 50% had no family history. The majority of BRCA mutations were of BRCA1, and there were a variety of other genes involved as well. Now, to understand the way through this, I want to show you a few examples. The first patient I'm putting up is a 42-year-old woman with breast cancer who had a 2-centimeter primary, multiple axillary lymph nodes. There's her family history. Her mother had a breast cancer earlier in the same year, which was not a triple-negative breast cancer. And her core was IDC grade 3, triple-negative. The options here are for her to have upfront surgery or neoadjuvant chemotherapy, and I don't think there would be much conflict with this patient. There are various reasons for giving her neoadjuvant systemic therapy, and one of them may be that germline testing may be considered, and I can see my medical oncology colleagues thinking about how they might change her treatment. Here's another patient in contrast, and I've put up the contrasts in red. This patient was 33 years old. She had the same 2-centimeter lesion in her breast, but was clinically node negative. She also had a triple-negative breast cancer. There was no cancer at all in her very close relatives, but in the distant family on both sides, there were some hematological malignancies, which are probably unrelated. In this patient, the decision is a bit more nuanced, isn't it? Because whatever we do for this woman, whether we do upfront surgery or neoadjuvant therapy, what we would be considering would be to give her breast conservation. And yes, she will need chemotherapy. And yes, following breast conservation, she's going to need radiotherapy. There's an argument for upfront surgery because after all, she has stage 1 disease. But also there's an argument for giving her neoadjuvant chemotherapy as well. What this would do from a surgeon's point of view is it gives a window for germline testing, because to get the results often takes 4 weeks or even a little longer, and the surgical options may be changed based on the results of her mutation testing. So here are the questions to us as surgeons. The first one is, if she is BRCA mutated, can breast conserving surgery be recommended? And the second consideration is whether additional surgery is required either to her contralateral breast or her ovaries. Let's have a look at the evidence. Now, from this meta-analysis, which was published a couple of years ago, you see that at 5, 10, and 15 years, there is a difference in the incidence of local recurrence between patients having breast conserving surgery and having mastectomy. But if you look at the long-term cancer outcomes, both at 5, 10, and 15 years, there is no difference in either breast cancer-specific mortality or overall survival, whichever sort of surgery they had. This is also nicely shown in this, which is another systematic review and meta-analysis, where there is a difference in loco-regional control, but no difference in the other cancer-related outcomes. So it seems that breast-conserving therapy and mastectomy have equivalent outcomes, partly because any further breast cancers tend to be low-grade and picked up early, small tumors. So the answer is that breast-conserving surgery may be offered with equivalent survival. Now, what about additional surgery? For these two patients I showed you, there is a difference. Following the treatment of locally advanced breast cancer, we should definitely defer doing anything to the contralateral breast if she has triple negative disease by at least 2 or 3 years. If she has ER positive disease, it also depends on the prognosis and how you think she's going to do with from the point of view of early recurrence. Oophorectomy, on the other hand, may be advisable depending on her age, but because of the risk of ovarian cancer and not because of breast cancer. However, with early breast cancer, there might be a different approach. Now, what are the different things we could do? Let's look again at evidence. What about contralateral risk-reducing mastectomy? Well, it reduces the incidence of cancer in the contralateral breast, but there is very limited evidence for any improvement in survival, even considering that survival data may be skewed because you're offering it to patients who are younger, healthier, and with less comorbidities. In spite of this, there is really no evidence, no clear evidence for improved survival. What about oophorectomy? Well, it certainly reduces the risk of ovarian cancer. This is a review from a few years ago, but it doesn't seem to change the risk of contralateral breast cancer. There is, because it reduces ovarian cancer, there is a reduction in all-cause mortality, which is most pronounced in patients with a BRCA1 mutation. So the answer to the second question is that additional surgery may be offered, but selectively and really focused on patients who present with early and good prognosis disease. So let's have a look at that patient. If we did upfront surgery for her, we would be considering conservation, chemotherapy, and radiotherapy in that order. But if she has neoadjuvant therapy, we could still stick with breast conservation if she doesn't want to have testing or if she tests negative. Even if she has a mutation identified, it is okay for her to have breast conservation. But there is another route for her. If she has a mutation, she could consider having a mastectomy or even a bilateral mastectomy with or without reconstruction at her choice. It also leads to a possible alteration in her systemic regime, and a little benefit is that radiotherapy might be avoided for this patient if she had a mastectomy. Let's have a look at another patient, and here again, 2-centimeter tumor in the breast, node negative, but this time we have a patient with ER and PR positive, HER2 negative disease, luminal B. We would be cautious about offering neoadjuvant therapy to this patient, but look at her family history. Her mother and her maternal grandmother, both deceased now, both had ovarian cancer. But with this disease, would we really be thinking about delaying her surgery until she had germline testing? No, I don't think we would. This is the sort of patient where we would offer upfront surgery and we would offer her breast conservation. Because also remember that her systemic therapy would remain unaltered, whatever the result of her testing. We could test her while she was having adjuvant therapy, and she might test negative, or there might be a mutation identified. If she did have a mutation, she could still remain with breast conservation, but with some additional surveillance over the next few years. Or else, there could be a different route altogether. There could be further surgical considerations, one of which would be a risk-reducing salpingo-oophorectomy, and the other for the breast. She might be able to avoid radiotherapy, as with the last patient, So she could have unilateral breast surgery, bilateral breast surgery, or with or without reconstruction by testing her during her adjuvant chemotherapy. Look at this patient who we treated in 2016. She came to us with a 36-year-old with a right breast cancer, 2.5 we operated on her. But look at that family history outlined in red there. Her mother had ovarian cancer at the age of 52. 3 maternal aunts had breast cancer in their 40s. This is her histopathology result, 2.4 centimeter grade 3 lesion. Sentinel lymph nodes were negative, ER and PR strong positive, HER2 negative. The KI and the high KI. She declined germline testing. Her brother is a doctor, and between them, she came from Bangladesh. Her brother is a doctor. Between them, they decided that they did not want to go down this route. Let's see what happened in 2018, 2 years later. Her sister, who was then aged about 40, came to us with a new breast cancer, and suddenly the whole situation changed within the family. Both sisters had germline testing. For one of them, the one I'm presenting to you, it was about 2 years after her treatment. She ended up with completion mastectomy, contralateral mastectomy, and risk-reducing salpingo-oophorectomy all at the same sitting, more or less at the same time that her sister decided to have bilateral mastectomy. The decision changed entirely once they actually knew that they carried a mutation. Yet another patient, and I want to show you, this is another interesting one. This is a patient who we treated recently. She presented to us at 52 years with a triple negative breast cancer, having had her first triple negative breast cancer in the contralateral breast at 38 years, and having had a breast conserving surgery in TMH in Mumbai at that time. 2 triple negatives, so she's got bilateral disease and she's got triple negative disease, and we tested her when she came with recurrence with this isolated contralateral breast cancer, which is a small one, no metastatic disease, but her staging did show an additional small ovarian cancer. I want to show you her family history because it's important. If you look at her immediate family, it looks to be irrelevant, but if you look a bit further, with all these intervening relatives being male, there were multiple breast and intra-abdominal cancers in her family. So it's important to take a very clear and extended family history in this kind of a patient. Finally, I want to show you a woman who does not have breast cancer. She's with us at the moment. Earlier this year, 2 of her sisters were diagnosed with breast cancer. Again, this is a patient from Bangladesh. Her older sister had breast cancer with negative for a mutation, and her 39-year-old younger sister also had breast cancer and was found to have a BRCA1 mutation. There are a few other cancers in her paternal family. So it's important to remember that these things all come together. Just because she had one sister who had perhaps a sporadic type of breast cancer does not mean that the family doesn't carry a germline mutation. She has no personal history of breast cancer. She may or may not get it in the future because it's important to remember penetrance, meaning that not every person with a mutation is actually going to get cancer. So the surgical question for a mutation carrier is when to consider prophylactic surgery and what surgery that should be. More evidence. So let's have a look at oophorectomy first. So oophorectomy, particularly in younger people, and especially in BRCA1, I'm more or less on the last couple of slides. BRCA1, there are some improvements in various cancer-related outcomes. However, risk-reducing mastectomy reduces the incidence of breast cancer, but much like doing mastectomy in people with primary breast cancer, there is no survival advantage. However, it does reduce anxiety a lot, and it reduces patients very often want to go ahead with it because of the extreme anxiety that they have related to breast cancer. So this unaffected patient, it's important to remember to advise lifestyle modification to reduce cancer risk. She could go down one of 2 routes depending on what she wants. She could have surveillance both for her breasts and with less evidence possibly for her ovaries. If she wants to have an intervention, it's the other way around. The first intervention that she should have if she wants to go that way should be for her ovaries. She could have an oophorectomy, and depending on what kind of a gene mutation she had, there might be a different age for that. There is also some upcoming evidence that she could have a salpingectomy on its own, or have it alone now, followed by oophorectomy at a later date. If she wants breast intervention, then she can have breast prophylaxis, which could be a bilateral mastectomy done at any age, which could be either conventional or nipple sparing with reconstruction. So finally, in conclusion, gene mutation results do affect surgical decisions, both at the time that patients present with cancer, at the time of recurrence, and in both primary and secondary prevention. It's important to bring these into our treatment algorithms so that we can offer the best options to all our patients. Thank you.
Thank you. Dr. Rosina, any question from the audience?
Yes.
Done in these mutated patients, as compared to mastectomy at 5, 10, and 15 years, the local recurrence was obviously significantly lower in the mastectomy group, without having any influence on the overall survival.
Yeah, that is true. So
that's probably the only way you can explain it, is because they had malignancies elsewhere in the ovaries, probably. So is there a subset of those patients who also underwent a risk reduction salping oophorectomy, and was the outcome equally bad in those?
I showed that there is when we talked about salping oophorectomy, there is some improvement in overall cancer outcomes. But breast conserving surgery is safe. Breast conserving therapy, I should put it, which is breast conserving surgery with appropriate radiotherapy. It is safe if a patient wants to have it, and then she can have surveillance for the other breast. A new cancer in the other breast is usually, for both breasts, new cancers are usually picked up early.
I think it would depend on how you define safe. Having a local recurrence is not really what I would call a safe outcome. Even though it may not translate into a worse survival advantage. A
That
local
is true.
recurrence is not something which one would desire.
Yes, well, it needs to be discussed with patients, and it depends which way they want to go.
Okay, thank you, Rosina. So, I would now request Dr. Rima Pathak. She's consultant radiation oncologist at Tata Memorial Center, Mumbai. Rima is well known to the radiation oncologist. And she will speak on nodal radiation in ultra hypofractionated radiotherapy. Rima, please.
Thank you so for your kind words. Thank you so for your kind words. And the initial few slides I'm going to zip past because my colleagues, both during debate as well as during the panel, introduced you to the ultra hypofractionated radiation therapy. So I do not have any conflicts. So before we start this particular topic, I would just like to, establish a few things. That there's no evidence to suggest that nodal disease requires a different radiation fractionation as compared to the treatment for the primary disease, and that skin over the neck is the same as skin over the breast, and they should not be reacting any different way. Also, I would like to say that conventionally and moderately hypofractionated regimen use the same doses for both regional nodal irradiation as well as the breast and the chest wall. So long as we've established that, we'll move forward. Now, again, this is the schema for UK Fast Forward study. The UK Fast study did not have any nodal irradiation, and we will not go into the details. There were several eligibility and endpoints defined in the study. I will again not go into the details, but just say that operable breast cancers with any type of surgery, any grade, but not requiring regional nodal irradiation were used in the Fast Forward study. However, they did have a nodal sub-study which was opened subsequently. They did look at several endpoints which are listed over there. Now I will delve on this particular slide a bit more stringently, is because they had uniform and stringent radiation planning criteria. They did have uniformity in their quality assurance, and they had to repeat credentialing for each and every site both for QA and QC for imaging, planning, as well as execution purposes. You are familiar with these dose constraints that are put up, and they did have adherence, a very strict adherence to these dose constraints as well. The study population was 4,000 patients with these particular population characteristics: more T1 and T2, less HER2, less TNBCs, fewer patients with LVSI, only few patients having neoadjuvant and adjuvant chemotherapy, and smaller proportion having tumor bed boost. The acute skin toxicity sub-study showed, and this is important because we're talking about toxicity, and this will also, we are going to translate these results to the regional nodal skin also. So here they showed that acute toxicities between the 26 gray arm and the 40 gray arms were fairly similar. And as you can see over here, the toxicity with the fast forward study peaked at 2 weeks and not at RT conclusion. And this is something which is important as practical consideration. They looked at primary and secondary endpoints, and these are recurrence rates. Again, we go back to the rider that we had established before, that the recurrence rate between primary and nodes are going to be similar because the dose response relationship is similar. And here they found that the 5 fraction, either it was 26 or 27 gray in 5 fraction, was similar to the 40 gray arm. And therefore, both of these 5 fraction arms were non-inferior. They looked at subgroups to see if there were any early results showing that some particular subgroup or high-risk subgroups did worse. Here they saw that both of these fractionation regimen were similar in their outcomes for these patients. Looking at PROMs, here again we established that the 26 gray arm was non-inferior to 40 gray arm across all different types of PROM endpoints except induration outside tumor bed. Physician assessments, again, will not go into the detail, but showed exceptional compliance to quality of life and PROMs at 5 years. And we saw that the NTs and PROMs were similar between 26 gray and 40 gray. Cosmetic outcomes again were similar between 26 and 40 gray, and therefore we would establish that across several endpoints that we've defined, 40 gray arm was equivalent to the 26 gray arm. In terms of late toxicity, and this is where everyone would want to ponder, at 5-year endpoint, you would not expect too many late toxicities to have come, but it at least gives you an early start to see if there were any early indications. And here they saw that the rates of late toxicities were also lower. So the conclusion was that both 5 fraction regimen are effective. 26 gray is similar in safety profile as the 40 gray arm. Acute toxicities are low, and possibly late toxicities would remain low. Now, what we would assume now is that the regional disease control will be similar for both 5 fraction regimen for regional nodes as well. Skin and subcutaneous tissue over the neck and chest wall will have similar outcomes with regional nodal irradiation. However, what remains to be seen is pharyngeal, esophageal, tracheal, and brachial plexus toxicities. They need to be evaluated further. We would include these regional nodal target volumes whenever we do regional nodal irradiation. Now, historically, we've seen several problems with hypofractionation, and which is why hypofractionation was not encouraged, because it led to several toxicities as listed over here. Here you can see that 60 gray in 5 fraction was used, similarly 50 gray in 16 fraction, and all of these have shown to have significant high brachial plexopathy. Now, we also had, many of us would be aware of the UK RAGE group. This is the radiotherapy action group exposure. This particular is a set of women who came together, who had undergone radiation therapy for their breast cancer and developed serious late toxicities. Here you can see that the brachial plexopathy developed in the median time to development of brachial plexopathy was 2 years. And we also see that not just brachial plexopathy, several serious side effects were seen in a whole lot of patients who had received radiotherapy previously. What was interesting to see is that most of these toxicities occurred because of change in position of the patient. So previously, now most of the modern radiotherapy ensures that the patient position does not change between the tangents and the regional nodes, whereas this was not the case previously. And it was encouraging to see that in this RAGE exposure report, they found that hypofractionation was not equivalent to higher toxicity. So there was some satisfaction when we saw that. It was important, again, establishing the same thing wherever there was major movement. Most patients developed plexopathy, whereas there was no movement, these rates were lower. Now, why is it important and how does this plexopathy develop? There are several, I will again not go into detail. You have microvascular injury, radiation-induced fibrosis, direct neurological injury, all contributing towards plexopathy. And what does plexopathy do? It gives us chronic handicap. It's usually progressive and frightening, irreversible, has sensory disturbance, gives pain, dysesthesia, paresthesia, and mimics carpal tunnel syndrome, so several times confused with something else. It also can develop motor weakness and complete paralysis, and this is where it hits us hard whenever these patients keep coming for our follow-up. And treatments are, again, very ineffective. There's a long list of treatments, again, put over here, but none of these treatments are going to reverse the plexopathy if discovered late. There are several factors that contribute towards development of brachial plexopathy. Again, these are, machine-related factors, and then you have patient-related factors. Some could be surgical trauma, some could be also the age and comorbidities of the patient. But what is important to see is that a whole lot of things can be modified. A whole lot of things are still in our control. What does the contemporary data show? So the previous data was from 1960s and 70s, and what is our current data? Now, this is extrapolation from treatment of superior sulcus tumors, and extrapolation of treatment of central midline structures with SPRT type doses, because we are talking about using dose fractionation upwards of 5 gray per fraction. So here, the initial results of RTOG 0813 initially showed that there were bizarre side effects like bronchial stenosis, fatal hemoptysis, and central fistula after treatment of central structures in lung cancer. And similar study results from the phase 2 Nordic HYLA study were quite scary, showing that nearly 19% had grade 4 or grade 5 toxicity after treatment in 60 grain, after treatment of 60 grain 8 fractions. So most of these patients died of fatal lung hemorrhage, and what they saw was that the PTV overlapped with the bronchus in these patients. These are important guidelines that allow us to understand what is the dose limiting toxicity and what are the doses that are safe in these kind of organs at risk. So UHFRT and regional nodal irradiation for breast cancers, can we draw parallels for these patients? So there was a nodal sub-study which was again used with the fast forward, and here you can see that in this nodal sub-study, previously, so the endpoints were patient-reported arm and hand swelling at 5 years. There were several secondary endpoints listed. And this was looked at very carefully by using the LQ modeling. As you can see over here, and I might just take a second, on the right is the 107% isodose. So this is the BED and EQD2 of all your hotspots. You've all heard about double trouble, and this you can see it happen using LQ model over here as well. And as you can see, the threshold is at 26 grain 5 fraction. The moment you turn over to 27 grade, it suddenly becomes too hot to handle. The advantage 28 grain 5 fraction has is that it has a cooling period in between where the lethal and potentially lethal damage can get repaired, and which is why the toxicities with this toxic regimen are much lower. They used a whole lot of credentialing, whole lot of quality assurance, and which is why they could float this particular study. As you can see over here, the stringent criteria laid out for them. The randomization criteria changed in between because they found that the 27 gray arm was fairly toxic as compared to the 26 gray arm, and which is why in the nodal sub-study, midway through, they dropped the 27 gray arm altogether and revised it to just comparison between 26 and 40 gray arm. So what are the nodal sub-study results? In terms of lymphedema, you can see that the lymphedema rates were similar. As compared to the 26 gray arm, there was no difference. In terms of the different patient-reported endpoints such as swollen arm, arm and shoulder pain, and all of these particular types of endpoints, you saw that the 26 gray arm was very similar to the 40 gray and 15 fraction arm. And there was no indication to suggest that the arm and shoulder morbidities were any different at 3-year time point. We also heard a whole lot about the interim analysis of the HYPORT study, and this is important because this is Indian population. So in this particular study, they showed that the overwhelming majority achieved strict dose constraints that were laid out by the study. You can see over here, this is very much representative of our normal Indian population of breast cancer. And the HIPOT study results showed that there was no signal to indicate excess toxicity within the test arm. However, odynophagia was not reported in this particular study. We have a whole lot of experience due to the pandemic where we started treating patients in 5 fractions, and we saw that across the type of patients that we usually see in our clinics, toxicities were fewer. As you can see over here, even grade 2 toxicity was less, 6 to 7% in terms of skin toxicity, and in terms of odynophagia, that means difficulty in swallowing, you would have 6 to 15% of patients which peaked at around 2 weeks. None of these patients required hospitalization, not for dermatitis nor for dysphagia. And that is why it is important to understand the safety in Indian patient profile as well. So here I would say that majority of our patients we were treating using simple 3D CRT or field-in-field IMRT. So no special techniques were used. You do not need special equipment. This is possible if you have good quality assurance and good planning team backup. We produced mild toxicities. We have till date not seen a single patient of brachial plexopathy or complaint of having even grade 1 side effects in terms of neurological side effects. So if we do a fact check, is it feasible? Yes, it is. Disease control wise, similar. Acute and late toxicities are similar. PROMs wise, it's similar. It is very well tolerated even in Indian population. Is it generalizable? So this is a point which each of us will have to introspect and think whether your setup is capable of treating patients with ultra hypofractionation. If your setup is doing SBRTs routinely, I guess then that's not a big deal for you. So currently, who can be treated with ultra hypofractionation, especially with regional nodal irradiation? So because we have published and unpublished data of safety among even Indian population with low toxicities, I would think that at least elderly, where you have a choice to be made whether a patient will receive radiation versus not receive radiation, it is safe to say that at least 5 fractions of treatment will be better than not giving radiation whatsoever. So patients who have non-compliance factors, functional limitation, who can't travel the distance, have several comorbidities limiting them to come to your therapy center for 3 consecutive weeks, you could choose these patients for ultra hypofractionation. We have real world data from our setup, and we are trying to collect data from other centers who have started using ultra hypofractionation during the pandemic. And this particular data set will be very valuable to see whether this is generalizable even in our setup. Who can treat? Like I said, centers who have strict quality assurance of machine contouring, planning and execution, and those that are able to use monoisocentric technique can go ahead and treat these patients. I would like to acknowledge a whole lot of people who have helped us adopt this particular, and the whole DMG and the department has helped us take it through. Thank you so much.
Thank you. Any question from the audience? 1 or 2?
I have a question, Rima.
Yes, sir.
You said brachial plexopathy is a serious concern. Yes, it was a serious concern previously when he used to irritate the axilla, but now it has gone down. Plexopathy. So is it related to the type of study, either a fast or you complete it in 5 fractions? Does it?
So again, if you see several times when you increase the dose per fraction, you may end up seeing bizarre toxicities that you had not imagined before with conventional fractionation, and that is what I showed in the RAGE group report that was presented. So several times you would require some long-term data before you can adopt. However, what I can safely say today is because of the LQ modeling, and even if we consider the time factor, the grade 3 and 4 toxicities are very less likely because of the total dose reduction that we have in this particular regimen. Like 26 grain 5 fraction is not supposed to technically give you those kind of biological side effects that we are talking about. However, in future, these patients tend to live longer, 15 years from now, 20 years from now. Will they have strictures or not? I don't know. And only time can tell whether the hypofractionation affects these organs in certain adverse manner.
Even if we do not irritate the axilla?
No. If we don't irradiate the axilla, also you will have the brachial plexus in your supraclavicular portal. So while we are not treating the axilla, supraclav, and I haven't shown you the report over here, but majority of the patients who did have plexopathy had the supraclav irradiation and not the axillary irradiation. So it's the supraclavicular part of your brachial plexus which is more susceptible because of the superficial depth. Yes. So no, we don't contour the trachea and the bronchus, but what we try and do is angle our anterior fields in such a manner that majority of the volume is outside the treatment portal.
And in your ultra hypofractionation, are you radiating the nodes?
Yes, we are.
Supraclav?
Yes, we are. So right now, like I even mentioned during the panel, is that the practice that I have shown is during the pandemic where we were treating all patients using hypofractionation or ultra hypofractionation.
Right.
Routinely now, only node negative patients are being offered the 5 fraction treatment, or elderly patients where we don't have any other option.
Okay, so there you're giving ultra hypofractionation to
and
the nodes.
like I had shown over here, the data here I have shown is 70% of them required supraclavicular radiation and 10% required IMC radiation as well.
Okay, thank you.
Thanks, Rima, for the nice talk. So for that supraclavicular radiation, what is the technique you are using? Is it a direct fill or an IMRT?
It's a direct field.
Direct.
We are not using IMRT for anything except if it's a deep tumor bed.
What is your take on like contouring the brachial plexus and doing an IMRT for the supraclav if you are using ultra hyperfractionation?
So again, if you see, we use the same plan as we would have done for 40 grain 15 fractions. Our plans are very interchangeable. And the dose to the brachial plexus, the max dose to the brachial plexus comes down to around 30 gray. So 30 gray, sorry, not 30 gray, 20 gray. So 20 gray in 5 fraction is known to be safe since time immemorial because it's our palliative fractionation. And we don't, that is why contour the brachial plexus for all of that.
That's a good information.
Yeah.
Thank you, Dr. Rima, and we are concluding the session now.
Thank you, respected chairpersons and speakers, for the very informative talks. Now, moving forward to the last debate of the day, adjuvant trastuzumab and pertuzumab is standard of care in HER2-positive breast cancer. I would like to invite on stage Dr. Shahina Dawood to kindly preside over the debate.
So thank you. So I believe the debate is adjuvant trastuzumab and pertuzumab is a standard of care in HER2-positive breast cancer. I'm wondering if this is still a debate, but it'll be interesting to see how the two speakers actually debated. So for the motion, we'll first call Dr. Amit Dewari. Each speaker has got 10 minutes or less. It's better if it's less. And then you have 4 minutes for rebuttal.
So thank you, organizer. Thank you, madam, for inviting me. Even I thought so. That is it a debate? I thought before I start, I must pay a tribute to the organizer. Thank you, my friend, Dr. Sainpal, Dr. Prasenjit, Dr. Chatterjee for calling me. There's a very famous, Hindi movie called Akhir Kaun, or something like that, which was a Rajesh Khanna starrer with Smita Patil, and there was a very famous song there, which says that जब अपने ही गिराते हैं नशे मन पे बिजलियां, and they give you a wrong topic to debate about whether you should be going on and off. I told them very important topics, but they did not take it. This is very important debate with my own brother Dr. Jaideep. But let's put it for the sake of debate, how we should proceed. So is adjuvant trastuzumab plus pertuzumab is a standard of care in HER2 positive breast cancer? Answer to this is yes. You can always argue about the level of evidences, which are whether it's for all or for majority of what I'm talking about. We can debate about that. That should have been probably the real topic, but then nevertheless, so the answer to this is yes. Is it for all patients who are HER2 positive? I would say no. It is for selected patients, those who are not positive and those who are high risk, non-negative HER2 positive cases. But then, you all know that this is majority of our patients who we do treat in our clinic. Is there an good evidence to support you whether you should be doing this or not? judge that whether it is safe to do or not. Looks like very safe. The answer to this is yes. And I will shortly come to this why I said so. And are there guidelines to support or endorse us what I said? Yes or no? Looks like yes. And there are guidelines to endorse you about the same. So how there are two subcategories, ladies and gentlemen. We should be discussing with all of you. When the surgeon has already decided to operate, and you get the case when the surgery has been done, and they are HER2/neu positive. Let's discuss this first subset first. So this was a affinity trial, international randomized, double-blind, placebo-controlled phase 3 trial. Good number of patients, 4,800, approximately 5,000 patients there. Have been already operated upon. Those who are enrolled, they must meet some criteria. They should have been not positive disease. If they were not positive disease, there was no discussion on tumor size. If there's a more negative, then you must look at the tumor size. They should have been more than 1 centimeter in size. Or if they were say more than 0.5 centimeter in size, they must fulfill certain criteria. Like they should be female, less than 35 years of age, ER/PR negative, and high grade of tumor. And what they wanted to analyze, primary endpoint of this trial was IDFS. That was the primary endpoint, and there were a couple of secondary endpoints. But then, since we have been given 7 or 8 minutes by the judge and by the organizers, we'll not go to the secondary endpoint. So, as you see, you need a very good microscopic or good vision eye to see the difference between two of them. And I hope, like my judges tonight or today evening, still find the difference. So this trial showed that those who were treated with, those who were given with chemo, trastuzumab, pertuzumab, versus only, trastuzumab, that subgroup of the patient, this trial was not a negative trial. Ladies and gentlemen, let's focus very, very short. Of the patient had lesser recurrence or lesser IDFS or better say IDFS advantage in intention to treat population. Now, these are the predefined subgroup analysis of this affinity trial. And that told you that, in the certain subgroup of the patient, like suppose those who were not positive disease in that subcategory at the end of 6-year time, the IDFS was quite better and it favored pertuzumab plus trastuzumab, and the difference was approximately 4%, or say, a little more than 4%. It was actually 4.5%. I don't know, whenever the medical oncologists say that 4.5%, it seems less. But Jaideep, I'm pretty sure he will come next and say that, all the plans of trastuzumab, have been relative, improvement of 30%, 50%. Done. That's really quick. So in no positive disease, it was better. Now, this was very surprising to me too. I thought that HER2/neu positive disease should have done better, but then HER2/neu positive disease seemed to be doing better. Now, when we do discuss the safety prophylaxis, is it difficult to do? Answer is no, because the difference in grade 3 or higher side effects were more or less similar. So it was slightly high, 64% versus 57% in these two arms. Now we come to the another subcategory, where, these are very rare in the first subcategory, which I discussed with all of you, ladies and gentlemen, because most of the cases, surgery and we medical oncologists get a second chance already, given chemotherapy. This is a rare scenario, but now if they have been already given chemotherapy and then operated, and if there is no residual disease, Catherine is not guided. So TBI is not an option. So in this category of patient, it seems like that pertuzumab plus trastuzumab should be continued beyond if there is no residual disease. And I must say that in neoadjuvant category, it seems like pertuzumab plus trastuzumab is a better drug. There are phase 2 trials only like Refimat, Osphene, Xeloda, which told you that there is a high PCR. So what you will do, what I will do, treat them with pertuzumab plus trastuzumab, and if there is a PCR, what I do, I do continue pertuzumab plus trastuzumab beyond this. This I already discussed with you, and I know that Wayne already has, time, so I will not discuss this with you. So let's go to the conclusion of my, debate. Is KP standard of care beyond adjuvant new positive cases is standard care? Yes. Next time to try and debate against TB, against what is the level of drug evidence. What happens to those who have been already given neoadjuvant chemotherapy and there is no residual disease? What they would more continue rather than only trastuzumab? Safe to do, as I told you. Safe to do. For all, I would say no. But then there are the cases where they are in a very minority of cases where they are, say, early stage or no high risk, that does endorse it. Yes. NCCN endorses it. I would also say that that also says that okay, they do it. They do antibodies, but they do say that they are already, they have endorsed it. To conclude this, I will say that this happens when there are failures in good management. Thank you very much. Jai Hind.
Dr. Joydeep Ghosh is next. He's a medical oncologist at Tata Medical Center in Kolkata, and he's going to give devotion against this particular question. And you have 8 minutes. He took 8 minutes and 40 seconds.
Okay. So good evening all. I shall be debating against the motion, and there are a lot of points which will ultimately prove that Dr. Amit Gori is wrong. Coming to the trial straight away. Well, the assumption in calculating the sample size, I've just quoted the trial's exact language. We assumed at the 3-year invasive disease-free survival of 91.8% with pertuzumab and 89.2% with placebo. Please mind you, this assumption was based on the BCIRG study, which was a 2011 study. I know pertuzumab trial was designed earlier, so we did not have the data, but is this assumption applicable in today's world? I have big doubts. The learned audience understands that in an adjuvant setting, even a 2 to 3% difference or overestimation or underestimation of the perceived difference of the control arm can lead to significant, statistically significant differences in the outcomes or the results. So even a 2 to 3% mistake in calculating the sample size or actually calculating the perceived benefit can lead to a disturbed sample size, can lead to affecting the power of the study. This is the first point. Secondly, coming to the results, 94% versus 93.2%. Actual difference was 0.9% in the first analysis, but it increased to 2.3. That happens in every trials. 0.9, fantastic figure for a trial to be positive. And I'll come to the terms. It's like trying to find out the difference between these two persons. Huh? Isn't it? Okay. Coming to the node negative, almost 35% of the patients in this trial was node negative. And we do have node negative patients coming up because they come to us at a much earlier stage now than it was previously. Very different different curves, you know, just like the difference between these two persons. Okay. Now coming to an important aspect. Now when we are using or trying to promote a new drug, we need to see certain advantages that it gives us over and above the already established therapy. So if pertuzumab is a new addition to me, I would expect that pertuzumab gives me some benefit in the CNS, because we all know that in HER2 positive, this is one of the important sites to reckon. Now what is the difference in the CNS reckons? 1.9 versus 1.8%. There is no effect of pertuzumab on the CNS recurrence in this trial. Menopausal status. Look at the subgroup. A large chunk of patients were premenopausal in this trial. Look at the location of the diamond in the figure. There is no difference whether you use pertuzumab or pertuzumab. No matter how the premenopausal patient comes, you get pertuzumab, such an expensive drug. Look at the overall survival. Now, this overall survival curve was not given in the original text. I had to pick it up from the supplementary article associated with the text. This is the difference in the overall survival. Even a microscope will not be able to find out the difference between the lines. Okay. Many authors have told that maybe waiting for a later date would bring out the actual overall survival. Waiting for what? Look at the timelines. Even the recent analysis has not shown any noise benefit. So what are we waiting for? Till the end of the world to look for a noise difference with adjuvant pertuzumab? Mind you, the previous trastuzumab trials, the events happened much earlier. This is HER2 positive. We are not talking BR positive cancers. We are talking HER2 positive cancers with events are happening much earlier. I've given an example on the right side. So any events on the left side? Nothing. Till eternity, no events. No difference in events in the OS curves. And that's it. Now coming to toxicities. Dr. Nikolai said that toxicities are fantastic. There is no problem. There is no difference. 18% versus 6% difference in diarrhea. Fatal adverse events, 15 patients versus 7 patients. Don't look at the percentages, look at the numbers. Primary cardiac event, 15 patients versus 7 patients. And there will be a significant chunk of these 15 patients who will be cardiac-wise paralyzed for the rest of their lives. Possible, quite possible. Now what about the 6 months? We all know this is the recent meta-analysis from Dr. Sudhir Gupta published in JAMA, which clearly shows that 6 months is non-inferior to 1 year of trastuzumab. Okay, and this was the study conclusion. Do we have a data of B plus H given for 6 months? No, we don't. Now, what about those who receive neoadjuvant chemotherapy? Now, we have heard from many speakers that if it's a HER2 positive more than 2 centimeter, which is most likely the majority of the patients that we see, we are going to give neoadjuvant chemotherapy. And it will preferably be a 4-drug combination, TCHB, fine, to achieve the maximum PAT-CR. Now, come here. After they achieve a PAT-CR, complete 1 year of dual blockade or complete 1 year of trastuzumab. Both of them is 1A level of evidence. So if I'm a multimillionaire patient of Dr. Amit Tiwari, I've been treated with TCHB for 6 cycles, I've achieved a PAT-CR. What do I do now? Will Dr. Tiwari give me T plus H? If yes, then on what basis? There is no basis. It's just that I feel that you should continue the tablet. Show me the evidence that the tablet has improved the long-term EFS or the DFS in patients who have achieved a PAT-CR compared to a single. Coming to the ESMO MCP score. Neratinib, we all know, is a drug which has been shown to increase the maintenance, increase the DFS for a few percentage points. Even the ESMO MCP score for neratinib is A, but for pertuzumab it is B. Still, we are harping on pertuzumab. Nobody talks about neratinib. Okay. This is the editorial that came up along with this article by Dr. Miller. I'll just read out the lines. To be clear, Affinity was a positive study. I agree, it was a positive study. And to be equally clear, as compared with the results of studies of pertuzumab in the metastatic setting and the neoadjuvant setting, Affinity is a disappointment in the adjuvant setting. It seems unlikely that the longer follow-up will dramatically change the magnitude of the Affinity results. Another important point, the cardiac toxicity effects during anthracycline therapy that precluded the administration of any further HER2-directed treatment were included in the analysis of the placebo group, but excluded from the analysis of the trastuzumab group. I am not saying this. This is Dr. Miller's words. So, if we assume in the worst case scenario that all the 38 patients whose toxic effects were discounted had a primary cardiac event, the risk of cardiac toxicity with the addition of pertuzumab will be 2.3%. That's significantly higher than what we know till now as of with trastuzumab alone. So, are we trying to hide the cardiac toxicity data? I think we are. Even more, the toxic effects are too great for too many to benefit too few. Cost, we all know what is the cost of pertuzumab. It leads to an additional burden of 18 lakhs for the best patient assistance program of the original molecule. Is it cost effective? Yes, there is a fantastic study which has shown that it is cost effective. It was published in a very good journal. The conclusion was P plus H is cost effective as per US standards. Mind you, in the acknowledgement, the research was supported by Genentech, which is actually the sponsor of the Affinity study. If you think you are going to come up with a study with Affinity, will show that it's not possible. It's impossible. So what did we learn? Failed drug as far as clinical relevance is concerned. The increased side effects are there. No diarrhea, no cardiotoxicity. The benefit of adding pertuzumab is extremely low, and there is zero survival benefit. We cannot wait till eternity. Nothing will happen till eternity. Whatever has happened has already happened. The role of adding pertuzumab is not established when we have a bad CR with NSCT. The ESMO MRBS score has a lesser score compared to neratinib. So we have not accepted neratinib. How can we accept pertuzumab? And there is no data of its efficacy in the 6-month usage, which I think for our country is the way forward. And there is no data on the improvement of the CNS recurrence, which for all clinicians is something that is very, very important in HER2-positive cancers. So to conclude, adjuvant pertuzumab is not at all a good addition to our treatment armamentarium. Just adding drugs does not help. You need better trial designs to select out patients who is going to benefit from a particular drug. In 2022, are you really okay selecting such an expensive drug based on only one clinical criteria that is more positive, at least sample? And the more robust escalation and de-escalation strategies are the need of the hour, adaptive Bayesian designs of the need of the hour, and you cannot have one size fits all for an expensive therapy standing in 2022 and looking forward. So I'm sorry, Dr. Dwari, you are a big failure as far as pertuzumab is concerned. Thank you.
Thank you. Dr. Jyoti, maybe you want to come here? Dr. Amit, do you want to rebut? You have 2 minutes. 2 minutes to rebut, not more. There are 2 minutes to rebut.
So, you know when the opposite speaker says that you treat multi-millionaire or billionaire, I don't know what is the right English because I was from Indian medium, you know that already you have done your job. Your heart theory, you have done it really great. Say that, you cannot say that this is a positive trial for 4,800 patient, then you do a better trial than that at TMC. I will seek forward to it. Now next is that subgroup analysis. If you don't believe that those who are not positive will also benefited, again there's a big question mark and a very respond about it. Now we know that you are not happy that when I said that side effects were not bad, it was slightly worse, 64% versus 57%. And when you spoke about earlier, we were big problem, let's resume our turning point, Jyoti, and we will debate about this again, about it. trastuzumab plus trastuzumab, I will be Seki like you are. I do agree, and that's why I said at the beginning of trial that what you do when you have to debate against a genius guy like Joydeep. Should you say that okay, should I quit or I should accuse them? So I better accuse them rather than I quit. Now, so there is no problem in efficacy. There is no problem in the trial design. I don't see that. Toxicity is not a problem. Looks like, when you don't believe the guidelines, what they say, I don't say that this is grade 1 or category 1 evidence, according to NCCN, but then when you look at it, so when you look at it, looks like a good, attractive option, not for all, I do agree with you, but then for majority, if there is no concern of money, I live in the same country that you live, I live in the same space where you live, I say not for all. So organizers, please do take big care of that when you put against such a robust candidate like Johnny. Give me better topic or something better to speak about. Thank you very much.
So, Dr. Jody, do you want to rebut? Yes? Or have you been, asked?
I personally feel that if affinity is redesigned in 2022 and redone with the same number of patients, it will be an effective study.
So I think as you can go back to Sujita. I think as the judge, I think I'm supposed to give a verdict, right? All right. My verdict is that everyone has failed today with this topic. The first person that failed is Dr. Prasanthi. You put this topic on, and you failed in that debate as well. This topic of adjuvant trastuzumab and pertuzumab is a standard of care in HER2-positive breast cancer. Is a good topic, but it has to be put in context. I see Dr. Badwe there. I have to pick on you. It's been so long since I've seen you. Dr. Badwe, as a surgeon, do you think that anyone with a clinical T1C and above HER2-positive breast cancer, should they be going for surgery or should they be going for neoadjuvant therapy? Dr. Badwe.
I am a strong believer that all of breast cancer. And I will give
in HER2 positive, now with the evidence of the Catherine trial, it's, at least in my mind, and I would have loved debating with you, Dr. Badwe, we have evidence that shows that if they have residual disease, they're candidates for TDM1, which improves outcome even if they're operable. So maybe I can change your mind one day, Dr. Badwe.
Okay. We will debate this separately.
We will debate this separately. Number two, I think the affinity trial cannot be debated in isolation. We all know that this trial, unfortunately, was not designed in an appropriate way. We know now that HER2-positive disease, neoadjuvant is the way to go, and those patients with a clinical T1C have de-escalated therapy. So if we take the whole cohort of patients with HER2-positive disease and we give them neoadjuvant, the more appropriate question would be, in the neoadjuvant setting, does everyone require pertuzumab and trastuzumab? And if they are getting neoadjuvant pertuzumab, trastuzumab, when they achieve a pathological complete response, does everyone require pertuzumab and trastuzumab in the adjuvant setting? And that is more than half, that is 70% of the HER2, of the hormone receptor negative, HER2 positive, and about 50% of the hormone receptor positive, HER2 negative. And that would have been the more appropriate question to debate. So let me put the debate back at you. So for the against, Dr. Jody, if a patient achieves a pathological complete response and receives neoadjuvant pertuzumab, trastuzumab, should they all get adjuvant pertuzumab, trastuzumab? Why not? There's a mic, I think, behind you. Yeah, but
I feel that for that particular patient, I would rather stop the treatment at 6 months of trastuzumab, which is shown because the non-inferiority trials as well as the meta-analysis have included patients who have received neoadjuvant therapy. So I would rather stop it at 6 months and then keep it.
And give them nothing. Is that what you're saying? Give them nothing. Well, the 6 month trials actually show that those patients who got either de-escalated therapy or who had neoadjuvant therapy, those are the ones that benefited from using anti-HER2 therapy in the adjuvant in long-term.
Yeah, but that was a subset analysis.
It was a subset analysis, but it was an analysis. That's the only data that we have. What about you, Dr.
So I fully agree with what you said that they have achieved already PCR. They have been treated with pertuzumab plus trastuzumab. They should be continued for 1 year more of pertuzumab plus trastuzumab rather than stopping them. As he said 6 months of just trastuzumab.
Then I would like to ask him one question. Suppose you are in the steering committee of designing a future trial and you are asked to design a de-escalation study. If for patients who have received neoadjuvant PCHP, how would you design then? What patient selection criteria would you select? Or you think that de-escalation should not be done?
No, of course it should be done, but not the way you are saying that. If they have been, you can't put the answer to a question which you don't know what that will be in future. So if you ask me, what should I be doing if there is a future design like that, that's a very separate question. But today, I feel you have to answer this today. 6 o'clock, say that, I will do my questions here for 1 year rather than you're thinking that what I will do if I'm in the steering committee, like, if you might be there, I will not be there.
So in the absence of data, you look for the data that you have. And you have 2 or 3 clinical trials now. One is the TRAIN-2 trial that used neoadjuvant pertuzumab, trastuzumab, and adjuvant trastuzumab alone. And then you have the Christine trial. They actually have neoadjuvant as well as adjuvant. And when you look at the PCR groups of these patients, and of course cross-trial comparison not accurate, 4% difference when you're continuing pertuzumab into the adjuvant setting. But I hear both of you, and I hear I've passed, and I won. Thank you very much.
Thanks, Dr. Saina. We having the session. We all are waiting since morning. So we are much privileged and honored to have with us Padam Shri Professor Rajendra Barve, who is the director of Tata Memorial Center, and we are really honored to have him as the chief guest of this meeting today. Everyone was in awe when they learned that Professor Barve is really coming to Kolkata to attend this meeting today evening, and the moment has come. So now I request Professor Barve to please come on stage to deliver his lecture.
By the time I get my slides, let me start asking Shahina that we begin this debate next time. She's run away. She knew that she was going to lose. That there is the evidence that anything neoadjuvant versus adjuvant makes a difference in survival. If that difference is not there, then we are getting into subsets within a kind of way of treating which has been shown not to be effective. I mean, you name neoadjuvant chemotherapy. Where is the evidence that neoadjuvant chemotherapy saves lives compared to post-op adjuvant chemotherapy? But we today in US, all T2 patients will receive neoadjuvant chemotherapy. On what basis? I mean, an ineffective way of treating we adopt because there is a this also might be supported by industry and I'll be thrown out. Next time I may not be there. Okay. I'm going to just take you through a quick change as to how what we saw the graphs in what kind of graphs and how have we changed. And if these are the kinds of differences that we achieve by the present set of our tenets, do we need to say that these are ineffective interventions or do we need to say that our tenets were wrong? So let me take you through quickly. I have multitudes of operable breast cancer patients, M0 with all the investigations, and I treat
and you all treat with adjuvant treatment. Post that, within the first 3 years, anywhere, depending upon T1 to T3 patients, 30 to 50, 60% patients will come back with recurrence within a short duration of time. And we believe that micrometastases predate surgery. So if a medical oncologist or a radiation oncologist or a surgeon standing up saying that my failures are not mine, they are failures of micrometastases, and we also qualify that they are unaffected by surgery cannot be measured by any test. So you don't try even to test that hypothesis because they're not measurable. Your PET scan will not pick up. So nothing visible, I do something and something becomes visible. How should we have looked at it? That either there are micrometastases and those micrometastases can't be tested. That hypothesis or postulate cannot be proven or tested. Or I am the one responsible for creating that micrometastasis. Did we look at that at all? We never looked at it. Let's see what all things. Assuming that the first one, micrometastases, were really true, we looked at beating micrometastases, shifting to the left, early detection, and above 50, 30% reduction with CBE or mammography, and all that is only above 50, nothing below 50. You might want to debate subsequently with a one-on-one age trial. And adjuvant therapies, various adjuvant therapies have given us about 30% or so reduction in recurrence. But we were never able to eradicate those metastases. That did not happen. Should we revisit this? So maybe some metastases were treated like this and some were there earlier and some reproduced. So is it possible that we ourselves would have produced micrometastasis? And let's have a quick review of Fisher hypothesis and I'll give you some more. So who thought of this? Fisher gave us micrometastases and Fisher himself immediately in 1982 ran some experiments to understand that he created a primary tumor first, allowed it to grow, and then created another small fat pad deposit to say that this is the micrometastasis which has happened after the metastasis, the primary has happened, and then he removed the primary. And immediately after removal, there was not only progression of the secondary, but there were many other metastases that appeared some elsewhere in mice. So obviously there was something that he found in animal experiment, but this was never to be seen. So and when he treated with chemotherapy, there was a drop in the thymidine labeling index, but immediately after surgery, that is time 0, there was a rapid increase in the thymidine labeling index of the residual tumor. So obviously there is something that is happening which is similar to no surgery. This graph, the slope of this graph and that graph is almost similar. What didn't happen such rise was tamoxifen and LHRH. Both these did not show that rapid rise in thymidine labeling index after the event of surgery. Yet, neoadjuvant chemotherapy became a standard of care in all studies. But let's look at the impact of events at the time of surgery. And it will be unethical to do surgery versus not. That is not possible, but we did do that in those who presented with metastatic disease, and I tell you what happened. The second best opportunity is within the tenets of screening trial, and I'll explain in short. In all screening trials, the assumption is that there are X number of early tumors on both sides, screen and control, and Y number of late tumors on both sides. In the screened arm, all are treated, and in control arm, only Y are treated and X are allowed to grow to Y level and treated when they become at the level of Y. So what are we looking at early years? All treated versus some treated. And late years, majority treated early versus majority treated late, which is what the screening comparison is, early treatment versus late treatment. Now, conventionally, what should happen in by Fisher paradigm? There should be equal mortality because surgery does not affect. Early mortality should be equal, and late should be saving of lives. But by the other hypothesis that if surgeons are doing something not right, then there would be excess mortality in the early years. Whereas late comparison, both hypotheses say that there should be lives saved. But is that the reality? This is the data of below 50, above 50, stratified, and anything more than one number is excess mortality in the screened arm. So above 50 for the first year, there is excess mortality. But for below 50, for the first 5 years, when I don't include Canadian trial has been kind of criticized, although that's the one of the best trials, but let's forget about it. Without and with, not much of difference. First 5 to 6 years of excess mortality in the screened arm, irrespective of whether you include Canadian trial or you don't include Canadian trial. So suffice to say that almost all breast cancer screening trials have early excess mortality. Our own physical examination versus not also has excess mortality in the first 5 years. And then there is a shift or a crossover. Similarly, there are 6 trials of lung cancer, early excess mortality. Our own cervical cancer data, I will show you that there is an early excess mortality, and prostate cancer, there is only excess mortality. So nobody does screening. So that's the prostate cancer data. I wonder, where is it that there is saving of lives? Screening has always had excess deaths all through the prostate cancer screening data. That's our own cervical cancer as well as breast cancer. That graphs are similar. That earlier there is excess mortality in the screened arm, then there is crossover, and then there is saving of lives by using VRA and physical examination for breast. Our own trial of metastatic breast cancer, wherein we did surgery versus not, something that can't be done in early breast cancer, but surgery done versus not, what happens to the distant metastases. That was the stratification. I will not go into the details, but local progression free, huge difference, great, better control by surgery. I want you to look at the colors of the graphs. The top graph is surgery done, green, and blue is the no surgery arm, and that's the difference in local control. And see the graph going the other way around. In those who had surgery, had rapid progression of distant metastases, appearance of new metastases. Suffice to say that surgery does change the behavior of micrometastases if they exist, or create micrometastases. Can we prevent it? This had an editorial also with it in Lancet Oncology of surgery versus not. But that was the first human experiment where the original Fisher experiment was proven without doubt, beyond doubt. There are 3 more trials that have happened of surgery in metastatic breast cancer. All 3 go in the same direction, except the 4th one, which is the Turkish trial. I want you to see these graphs. These are graphs of primary progesterone therapy. Nobody practices it. I don't know why, because there is no industry supporting it. And it's not 2%. It's not 1%. We are looking at a 10% difference in disease-free survival and a 10% or maybe 9% difference in overall survival. Lives saved. Our problem is that unless some industry person comes and tells us that this is what is to be given. And the second problem with progesterone is that it's a cheap treatment. How can we save lives with cheap treatment? We have to save lives with lot more cost, so that it can be given only to the elites of the society. The others are not. They don't deserve to live. Isn't that the case? But that's the trial that earlier did, indicating that tweaking events at the time of surgery does make a difference in long-term outcome. And how do you explain this? How do we explain this? Why should this happen? Is there a biological underpinning? And the second study, I'm going to share this before publication. We did an experiment wherein I did a biopsy, a core biopsy before starting surgery under anesthesia. Then a second biopsy was performed when 50% of the surface of the tumor was denuded in doing breast conservation from the other surface of the tumor. So When 50% of interruption of blood supply to the tumor, I have done a second biopsy. And a third biopsy when the whole tumor is in my hand. First tumor is normoxic, the last tumor is anoxic, and the middle tumor is hypoxic. 3 biopsies of the same tumor, expression profile on NGS platform. What do I expect? The expectation was very simple, that if I am walking on the streets of Kolkata during the daylight and I have nothing else invading my privacy at that time, there should be no reason why my survival instinct should be up. I am walking peacefully. Suddenly I find that there are 5 goons in front of me. What will be my reaction? Fight. Little bit of fright. And if I find that this is a losing battle, flight. I will try and run away. The tumor does exactly the same. Between the first, this is not more 32 now, we have 90 triplets. So this is what I would expect. If I am overpowered, God forbid that should not happen, but if I am overpowered, I will stop reacting. So between the first and the last tumor, the difference between expression profile of mRNA was about 30 genes. 30 genes were different. And whole of our understanding of tumor biology is based on sample A or sample C. We have never looked at the sample B. Sample B had somewhere close to about 800 genes, which were different than A and C. 800. Just imagine. Tempest. It was almost a fight that was going on there. And what was abnormal? I want you to focus on to this. TNF signaling, epithelial mesenchymal transition, estrogen response rate, coagulation, estrogen response late and early both, the CRAS genes, motility genes. What is epithelial mesenchymal transition? That's the strongest predictor of distant metastases. Imagine that all upgraded during the first 10 minutes. Between the first and the second biopsy, it's not even, sometimes when I am doing surgery, it is about 3-4 minutes. In 3-4 minutes, 800 genes have gone up. How does it happen? I want you to imagine as to what's the mechanism. Is it that some substance are secreted? Will it take some time in diffusion? In 3 minutes it will happen? Or is it comparable to I touch a hot object and my hand is back? What is that? Nerve transmission. How does that happen? That happens by depolarization like a current. And that transmission happens through voltage gated channels. So when we studied this, our first 12 patients triplet was available in 2011. Imagine in 2011, what we were looking at, can we paralyze these voltage gated channels? And the best medicine that we ever have available across the counter was local anesthetic lidocaine. So that's how we started off with the next trial, which I presented at ESMO. Peritumoral injection. Under anesthesia, I inject all surfaces of the primary tumor, one pole to the other pole, as if I'm looking at an umbrella coming from both sides, covering the primary tumor, all surfaces. The efficacy parameter that you have injected adequately is that in a breast conservation, you cannot utilize diathermy because of the amount of water content of the tissue. If you can use diathermy there, you have injected inadequate amount of local anesthetic. Do that, and I'll not go into the background because I've already explained what the background is, but we know that VGSC or voltage gated sodium channels are blocked by lidocaine. That's how it stops transmission of pain stimuli. And the downstream effect within a cell of VGSC depolarization is EMT, proliferation, invasion, and motility. All that we are looking for metastatic potential. That's how we did. These are 1600 patients, much less than 4800 of pertuzumab study, unfortunately. 1:1 randomization, and I'm reporting on 1583 patients out of these 1600 because there were some centers where the decision whether we should do it or not was based on frozen section. And in frozen section, the tumors, it was not a cancer. But they had already randomized it to either one of these arms. So that's why these a few patients are excluded. But the distribution of menopausal status, clinical tumor size, pathological tumor size. I want you to document in your mind what is the average tumor size. That's 3 centimeters. We're looking at what we commonly see. A 3 centimeter tumor, 2.9 was the precise, and they're exactly similar on both sides. That's the difference in survival. The left-sided graph is disease-free survival, right-sided graph at 7 years, exactly at 6 years, exactly same as pertuzumab. Graph is separated, that's because the y-axis is truncated. But please understand that there is a difference, statistically significant difference, which is about 26% reduction, relative reduction in disease-free survival and 29% reduction in overall survival by this simple method. I then looked at any subset, any different at all, except very low-grade tumors, smaller in number, much smaller in number compared to the others. Everything else is on the left side. Everything else. Not a single subset was not affected. All of them were benefiting all through the treatment of breast cancer. Post-op treatment was almost identical. Suffice to say that here is a trial that has shown a disease-free survival benefit, an overall survival benefit at a cost which is less than $1. Not 18 lakhs of rupees, with a debatable difference. I sincerely hope that if this were to be even implemented across India, we would have somewhere close to about 30,000 lives being saved annually. That's the data from operable breast cancer, because that's where we are. The next trial, in my opinion, should be that if there are individuals who are T3, T4, women who badly want to have conservation, we have given neoadjuvant chemotherapy for residual tumor. If I were to inject local anesthetic, can I make the same difference at all? Just to see that the medical oncology should also be in business. Well, we have kind of oscillated from saying that disease is systemic. Gallen mentioned. There is a very elegant study by Tizzer in 1904 looking at surgery as an event which might increase dissemination, but not so much popularized. Halsted, again saying that it was a local disease. So local treatment, from systemic we came on to local. All of us failed, all surgeons failed, 50%, 60% failures. We needed justification for failures. So a crutch was given to us saying that you are not at fault. It's the micrometastases. Predated, pre-existed, can't be tested, can't be measured. So we were happy that we continued operating, and a breed of individuals through industry came in to say that they can now treat micrometastases. Somewhere in 90s, the progesterone matter came in, and we are now debating. We also say that it may be systemic, but for sentinel node biopsy, it is local and sequential. For rest of it, it is systemic. I would still like to do, so it all depends on what's the amount of money that the industry puts in and how much the shareholder gets in, rather than what our patients can get. I showed you the data of perioperative progesterone, positive, perioperative local anesthetic, positive. Maybe, is it organ agnostic? If it is not organ agnostic, then can I do this in pancreas? Injecting local anesthetic around will be hazardous. So when we first looked at in 2010, looking for what suppresses voltage gated channels, the effect of local anesthetic, if it is 10%, then cannabis has 200% effect on these VGSCs, the voltage gated channels. It has taken approximately 10 years for us to get regulatory clearances. 3 months ago, we got regulatory clearance, and we have begun the cannabis study. Thank you very much. Are there any questions, or? I don't mind if there are any. My only last thing would be that these trials stand to benefit only the patients and nobody else. And if we as individuals are patient centric, then it stands to benefit us. But no shareholder will be benefited out of that.
Thank you, Dr. Balde. I learn something new every time I listen to you. In fact, I don't mean to praise you too much because you've been praised a lot in the last few weeks, and I can see the head swelling up a little bit. So, but Martine Picard did a meeting with us last week on ESMO, and she was wondering why your talk wasn't in the presidential symposium. So when she said that, we were all very, very thrilled and very, very happy. Besides that, I just wanted to ask maybe two questions. One, in the progesterone trial, was there any difference between the ER positive and the ER negative, or was it seen amongst all comers?
It was seen amongst all. And it was studied subsequently in cell and it showed exactly similar ER, and that was manifested through some canonical pathways that don't need the surface receptor.
Okay, that's one. Second, have you ever thought of combining both these approaches? That is, giving progesterone first and then injecting the anesthetic?
Paper in writing at the moment.
Okay. And do you think that has a synergistic effect?
1600 patients trial has 1100 patients from Tata Hospital.
Right.
500 patients from outside Tata Hospital, 11 centers. I'm immensely grateful to those 11 centers for the contribution. But in those 11 centers, preoperative progesterone was not a standard of care.
Right.
In 1100 patients in Tata Hospital, the primary progesterone was a norm.
Given.
So everybody has received, and at the moment the analysis does show that there is an absolute benefit of 11% by local anesthetic plus progesterone. But mind you, the control also received progesterone in Tata Hospital.
Yeah, Dr. Bhagwe, I am a surgeon. So I am interested to know, can you suggest where the doctor should be having the localization?
Except the surgery was just by the general anesthesia and then
if I can put the localization in the skin, so my purpose is served. Isn't it? All around this, you are blocking all the nerves, and by the skin, you are blocking the somatic nerves. Not just somatic nerves. By blocking the skin, we do local anesthesia, by the local surgery.
Yes.
If you surround the localizer surrounding the tumor, your purpose is served. Why we need to go for a general anesthesia and doing it under after lidocaine?
If you want to do it, that's okay. I have no problem if you do it only local anesthesia.
But I mean, your study shows that if you can block the channels, then you can achieve better results.
Yes.
So if what lumpectomy is in lumpectomy, we are doing 3 cm, 2 cm, like per centimeter lumpectomy can be. So if you can put local anesthesia, that's the harm. I think we should take a practice and put the lumpectomy local anesthesia.
Mind you, it is not very comfortable for the patient to undergo this procedure, especially a wide incision. If you're doing a diagnostic procedure, it's okay. But I don't think anybody does a diagnostic incision by saying if there is suspected cancer.
One question. What is saying that after surgery the disease spreads? Do you think this concept is being modified through your research?
In my opinion, we have to find the reason for our failure. If 40, 50, 30, 40, whatever the percentage of patients after primary surgery come back with recurrence, we need to find the reasons. And if we can treat ourselves, nothing like it. It is easy to say that somebody else is faulted and let somebody else treat it. That's not right. Our faults, our corrections. The gentleman is there holding them, please.
Sir, congratulations for this study. Sir, what was the percentage of node positive patients in this?
Node positive were 36%.
And sir, why do you think that you did not plan local infiltration of the nodes also and just the tumor?
The difference between node positive and node negative is not different at all. It's almost similar. And unless there is perinodal infiltration, I guess node is quite a strong barrier. In the treatment arm, there is no difference between node positive and node negative patient survival. So there is a strong barrier there. But I'm sure if there is a perinodal infiltration, then the tumor has access to circulation outside the primary node. And it should be, I presented this data at Tata Hospital at Thursday morning meeting, and the same question was asked, why not have? But as a early breast cancer patient, the perinodal extension would be a very small percentage. But it's worth looking for a study to that effect.
So do you think that your study would lead the way to intratumoral pertuzumab later on?
I wish pertuzumab actually suspends all the metastatic activity of the tumor. I am not trying to kill the tumor. Please understand. The killing is done by the surgeon. And I must allude to another study. There was a very elegant Oxford study on spontaneous abortions versus induced abortions. And the number of spontaneous abortions wherein the metaphysical study, or not metaphysical study, the gene, when they map those genes, what is that process called? Not NGS. NGS is now. Yeah, I mean, we do the chromosome planning, study. It's okay, yes, I'm so sorry. I'm going old. So when they did a karyotyping, it was found that the karyotype was not viable in spontaneous abortions in 90% of them. And in 10% when it happened late, it was because of incompetence of the os. Whereas in induced abortions, somewhere close to about 80% were viable chromosomes, karyotyping. What does that mean? The body has incapability to correct chromosomal abnormalities which are non-viable. And cancer is one chromosomal abnormality that is not viable. It grows for its own existence, not realizing that if it kills the host, it will kill itself.
Just in the analysis of the results, was it adjusted for other factors which have a confounding effect? Like
so in a randomized trial, I showed you the earlier tables wherein all the factors were identical on both sides. Node positivity, T size, grade, ERPR, HER2, you name the prognostic factor, they were similar on both sides.
It was in the design.
Yes. Although we have done a Cox proportional hazard model, and that still shows local anesthetic to be far protective than otherwise.
Good evening, sir. It's always a pleasure listening to you. Sir, a technical question. As a surgeon, when we are infiltrating these local anesthetic, there's always a concern about the cardiac toxicity, and I'm sure it was taken care of. So could you, sir, tell us how much is safe? I mean, just grossly speaking. And somewhere on the WhatsApp platform, you said it would be very fast. And so if you could just talk about that, a lot of surgeons would take home some message.
Absolutely. So the normal dose of 0.5%, what you have in a bottle is 2%. So you need to dilute it 4 times. And then it becomes 0.5%. Now that 0.5%, if you eat the toxic dose, if left in body, you have injected and you leave it in body, then the toxic dose is 4.5 milligram per kilogram body weight. Now, assuming it's about 50 kilograms of or 60 kilograms of individual, you will be able to inject about 60 ml of all round. So 6 syringes of 10 ml, which should be good enough. But please understand, the 60 ml toxicity is if it is left in body forever. If you're doing conservation, in 20 minutes time, the tumor is out. So even if you inject, say, 120 ml, and we have done that. For larger tumors, we have injected about 100 ml, 120 ml, and removed in the next 20 minutes. In these 1600 patients, half of them received it there has been not a single cardiotoxicity or no toxicity at all. So you are injecting within 1 centimeter, but by the time it diffuses, it is almost up to about 2.5 centimeter that you still feel that there is some water there. I mean, if you have injected within a half a centimeter from the tumor, you will have about, if it is going to seep on one side, about 2 centimeter, it will seep 2 centimeters on the other side too. Absolutely. Very close to the tumor.
Sir, one related question to this particular question itself. Will injecting the lignocaine and then resecting actually increase your resection volume? Because no tumor on margin is what is accepted currently. But
Yes.
here we are aiming to give it at least another 1.5 centimeter. And we are trying to remove all that what we have injected.
No, we are not. We are not trying to remove. No. We, I mean, majority of the people in Tata Hospital use knife today because cautery doesn't work with so much of local anesthetic. So if it is knife, we are doing the conventional one, 1 centimeter margin.
But do you still not think that the volume of resection will be larger as compared to what you would have done without the injection?
Our margin negativity has not changed for the last 15 years. So we are okay. We have not changed much.
Sir, one question, sir. Thank you for your beautiful presentation and novel mechanism. So my question is, you have shown efficacy with progesterone also, and you have now shown efficacy with lignocaine. So my question is, what are you routinely using now? Are you prescribing both these to routinely all your patients? Or
Everybody who comes for primary surgery gets progesterone day 1 to day 4 prior to surgery. So if they come in for tomorrow surgery, they will receive it today, and a local anesthetic on table.
So both are being used in
Yes.
all cases.
All cases.
Thank you.
And please understand, for an average tumor size of 3 centimeter, we have a 91% survival rate. I would love to see this kind of survival for a 3 centimeter tumor. The average tumor size in your pertuzumab and trastuzumab, wherein the survival is of the same magnitude, 91, 92, the average tumor size is less than 2 centimeters.
Sir, I have a very simple question. I always have heard about something called barber's phenomena, where when you go to a barber, they say that whether you need haircut or not, they will cut your hair. So it seems that wherever I have discussed with many experts, they say that this looks like only modality which is going to help. So do you think that you have done brilliant trials two times in very recent past? Do you think that there is any role of radiation oncologist, or do we medical oncologists exist or not?
No, say that again. I'm slightly foxed.
No, sir, I said, sir, that do you think that the cancer will be a multimodality disease, or this will be unimodality disease, where you think that surgeons or only medical oncologist or radiation oncologist will take care of the disease?
I think all of it, none of us can do it single-handed. That's for sure. If we can, each one of us improve on our failures, that much better we can be. There is a huge industry that is supporting you to improve your outcomes. There isn't such industry for us. But I must say, the way we've done this study, there is a similar study done by a very eminent radiation oncologist. The name is Norman Coleman from NCI. The gentleman did for breast cancer tumors before radiation began, during radiation, in some protocol where the preoperative radiochemo was the treatment, and found exactly similar kind of things in the middle sample. So please understand, this is not a kind of a sitting duck for any of us to shoot down. It has its capability and its own survival instinct. whether I use surgery, whether I use chemotherapy, or whether I use radiation therapy, the tumor is going to react and try to overcome these difficulties, which is the survival instinct of that cell. And the cell has exactly the same mind as the host. So each one of us can add small little things to it and see if this improves.
Together we exist, with or without industry. That's what you want to say, sir?
If I were to give an example, I mean, if you are asking for it, so there is an excellent meta-analysis, a Cochrane review on neoadjuvant chemotherapy versus post-operative adjuvant chemotherapy, and there is a subset analysis of those who did not have surgery. In them, the local recurrence rate was 54%, and the distant recurrence rate was equally horrendous. So surgeons are also, in their own right, equally important.
So, we do medical oncologists or radiation oncologists also are there, little bit or not, sir. That's what was my question.
No. There is randomized evidence to say radiation versus no radiation helps. So, chemotherapy versus no chemotherapy helps. So your existence is super.
So we have the last.
We're just trying to
from
struggle
Dr. Arnab
for our own existence.
Yeah, we can't take any more question. The last question from Dr. Arnab.
Wonderful presentation, Dr. Badve. Two questions actually. I think I missed out. Maybe my understanding was wrong. But for is it only for breast conservation or is it for mastectomy as well when you inject the local anesthetic?
So 40% had a mastectomy, and the difference in outcome was exactly the same with conservation or mastectomy. So it is there in both.
The second question is obviously you've got a long-term data now from progesterone. So are you looking at putting it in the NCCN guideline? It's not you who's going to put it anyway, but are they trying to involve that in the guideline in NCCN or ESMO, which will be obviously universally accepted?
So the day local anesthetic paper comes in on print, we will have both those included in our guidelines. We have to. Unless we acknowledge what we are doing, I think it will not be possible. That's an excellent suggestion you made. Thank you so much for that.
Sir, one small question at that. If this hypothesis is true, then the speed of surgery
You
would
still have doubt? Yeah, I mean, you don't have a doubt for pertuzumab when there is no doubt for pertuzumab also. And you have a doubt for a randomized 1600 patients.
No. I'm saying, sir, if the tumor is reacting to removal, then the speed of surgery would matter.
It
So
should.
then probably the duration of surgery while doing a lumpectomy should come into the.
Okay. So there is no great evidence for that in literature, but if you search in Google in PubMed, duration of surgery for lung, for stomach, for pancreas, for liver resection, duration of surgery is one of the strongest determinants of outcome.
Thank you. It was an excellent session, and we have n number of questions. And Dr. Badve was patient enough to respond to everybody. Now there is an international speaker waiting for the next session online, so we'll start it without delay.
Thank you, sir, for the very thought-provoking and interesting lecture. Now, going forward for the next session, I would like to invite our experts on stage. Dr. Rajendra Baral, Senior Consultant in Clinical Oncology at Narvik International Hospital, Kathmandu, Nepal. Dr. Yatak Dolopadhyay, Associate Professor in Radiation Oncology, Burdwan Medical College. And Dr. Prabir Vijay Kaur, Senior Consultant in Surgical Oncology, AMRI Hospitals, Kolkata.
Good afternoon, everybody. Thanks to the organizers for giving us this opportunity. In this session, our first speaker will be Dr. Duncan Whitley. Unfortunately, he is not here physically. This session will be online. He is a consultant clinical oncologist in NHS UK, and he is an important member of Fast Forward Trial. And he is a member of NCRI Breast Cancer Studies Group, clinical lead for NCRI Cancer Research, clinical director of research and innovation in Cornwall. And his topic is, should 5 fractions of radiotherapy be the standard of care in adjuvant treatment? Yes, sir, go ahead. Yes, sir. Yes, sir. We can hear.
presentation, always excellent. We all lovely enjoyed the session. In today's context, globally, I think, I may be right, I may be wrong, the most concerned cancer is breast cancer. Lot of studies have been done, lots of trials have been done, and still lots of publications have to become. And no doubt, as mentioned by Amit, this is a multi-modality treatment. So, role of radiation oncologist, medical oncologist, surgeons, even pathologist and radiologist, they are the backbone of any oncological field. So, this is a teamwork. So, for this second session now, let me invite Dr. Indranil Bose, who is eminent medical oncologist, senior consultant from Apollo Multispeciality Hospitals, for to conduct a panel discussion on neoadjuvant therapy in breast cancer.
Good evening, all. Thank you to the organizers for organizing this meeting and inviting us for this panel discussion. I would like to welcome my panelists, Dr. Chandrani Mullik, Dr. Suman Mullik, Dr. Amitabh Ray, Dr. Ashutosh Daga, Dr. Kaustubh Majumdar, Dr. Tanmay Mondol, Dr. Animesh Shaha, Dr. Pradeep Mondol, Dr. Sani Khanna, Dr. Dhritiman Moitro, and Dr. Tapos Kaur. So quite an eminent panel to have today evening. So we'll discuss two cases. The first patient, 45-year-old lady in good general health. She found a left-sided breast mass 2 weeks ago, and examination confirms a firm non-fixed mass, no skin changes, mammogram 3 by 2 centimeter, irregular shaped solid mass at 2 o'clock. Ultrasound reveals 2 centimeter axillary node with thickened cortex and loss of fatty hilum. A core needle biopsy of the breast mass is done, which reveals invasive ductal carcinoma grade 3. Tumor is ERPR negative, HER2 negative by FISH, HER2 positive by FISH. It was 2+ by IHC. And the lymph node biopsy also reveals metastatic carcinoma. Echo shows a good LVF. So any other investigation at this point? We'll start with Dr. Tanmay on the left side.
So it's a early breast cancer as per the nodal and the tumor size of 3 centimeter looks like. So we just did a staging of with a USG abdomen and CT thorax with a bone scan at least for staging purpose, and then we go ahead with the further.
So for staging, you are happy with USG abdomen, CT thorax, and bone scan?
As it's an early breast cancer, USG abdomen is still fine.
Any difference of opinion? Any other panelist?
You can go for a whole body PET CT scan.
How many are for PET scan in the panel? Okay, in lieu of PET scan, how many are in favor of CT thorax abdomen and bone scan? So majority of the panel agrees that this patient, the node positive HER2, they will go for cross-sectional imaging as well as bone scan or a PET scan. So yes, there is a lot of evidence that from at least stage 2B, the role of imaging is there. 2A maybe not so much. This is T2N1, so possibly yes, we in HER2 positive, we need better staging because you can miss metastasis in up to 15% in this patient. So surgery without NSCT or NSCT followed by surgery. Dr. Pradeep.
So it is a node positive disease and it is HER2 positive. So I would like to give NSCT followed by surgery. Because all the data, I will not go into the details of that, what is the benefit of NSCT like that. But in HER2 positive disease, we have the data of in adjuvant setting if patient is not even in PET paths. Yeah, so that's why I will want to give NST followed by surgery is HER2 positive.
Surgeons?
NSCT followed by surgery.
So all surgeons in the panel agree that NSCT followed by surgery. Dr. Badwe, I think you are not listening to this. T2N1 HER2 positive, non-metastatic. Upfront surgery or NSCT? But sir, all the data of neoadjuvant versus adjuvant was in the older era when only was AC, maybe some Texan. So, but no, but in that time the targeted therapy was not there. So what now if you give targeted therapy, 60% patient tumor wiped out. Still you don't want to give chemotherapy.
I want to know whether surrogate marker of complete response, should that allow us to change the treatment in total? Are you willing to say that only for surrogate marker? What has changed? Killing a cell by targeted therapy, is it any different than killing a cell by chemotherapy? In adjuvant setting, targeted versus not is what is the difference? 5%, 6%, 7%? How different is it than chemotherapy? How different is it compared to oophorectomy trials?
Right.
So, in my opinion, complete response was seen even after oophorectomy. But it was never the way of treating. See, my contention is that if there is a survival benefit by one way of treating neoadjuvant, then I'm ready to change my treatment. But if there is no such difference, by just saying that instead of using a steel bullet, I am using a gold bullet, and my difference is should be accepted. Is that an argument at all?
I understand your argument, but unfortunately, I don't think this kind of trials will be done anymore in current era, neoadjuvant versus adjuvant, because the data has been skewed like that. So, why neoadjuvant chemotherapy in this patient, Dr. Tapus?
We can plan our surgery because we can go for a breast conservation surgery, and since it's a node positive patient also, so if we give neoadjuvant therapy, it increases the chances of survival, overall survival, and it helps in shrinking the tumor also.
Right. Dr. Dhitiman?
And residual disease accordingly tailor the adjuvant treatment based on the response with the neoadjuvant regimen.
Dr. Animesh?
Yeah, basically, the aim will be to get a PATH CR, because we know the PATH CR is a surrogate marker for the ultimate outcome, that's overall survival. I don't think this, if the 3 centimeter tumor is there, it will hinder any breast conservation. So we are not aiming for downstaging or breast conservation here. So it's here basically we are for response, PATH CR, and selecting a patient of understanding the biology of the disease and selecting the subsequent treatment after surgery.
Yeah, so it seems there are two worlds here. One is the world of our panel and one is the world of Budweiser. So they are totally going in two different directions. So any other procedure before NSAT? Dr. Sunny?
We will do a USG guided clipping of the tumor and also the nodes.
Tumor as well as the nodes?
Yes, sir, both of them. Ideally, it should be done after one cycle of the chemotherapy to see how the response is after the first cycle, whether it's a patchy response or the concentric response. But most of the time we do it in starting of the chemotherapy cycle.
Yeah. So other surgeons also agree with this. Okay. And nodes also, you advocate clipping of nodes. What about SLNB upfront before anesthetic? No, in this patient, there is no role of SLNB as such as before. But suppose it was a clinically node negative and you are planning for NSCT, would you do a SLNB upfront or after neoadjuvant chemotherapy? Dr. Sani?
I think so prior to giving chemotherapy, we should do a sentinel.
Suppose
If we're clipping the node, I think after neoadjuvant only we should go for the sentinel.
ideally you should not go for SLNB before neoadjuvant chemotherapy, because if you are doing SLNB, you are taking out one node or maybe few nodes, so you will never know the pathological CR outcome after surgery. So that will hamper or the decision making for the medical oncologist. So if in CN0, you should go for SLNB after neoadjuvant chemotherapy. So now you have chosen to give this patient neoadjuvant chemotherapy. So which regimen, Dr. Chandani?
CHP finances permit, otherwise TCH.
Any reason why not the others?
Why not the others? Okay.
The AC followed by THB, another common regimen. It depends. It's as per your preference only, but I just want to know the reason. Ashutosh?
So my preference wise will be TCHP, and in this particular case, because it's a T2N1 disease and it fits the criteria of BCIRG criteria, so I will go for a THP if the patient is not affording for pertuzumab.
Okay. Anupam? Very Costa?
So TCHP would be the ideal thing here, because we do not add any other cardiotoxicity here, because the patient will will survive. T2N1 HER2 positive, we have a more targeted therapy here, so we'll not adding anthracycline here because of the reduced cardiotoxicity, and FEC obviously not absolutely because of the neutropenia and everything. And TCP 4 cycle, and again AC, your C point is TCP and AC. There is also the doxorubicin, so we will not add doxorubicin here. But
So if patient can take pertuzumab, we can use TCHP, but if not, probably anthracycline incorporation is better. So this patient underwent USG guided clip placement in the primary tumor only, not the node.
I'm sorry, sir. So actually, what I was talking was TCH. So I think it's not in the option, but I think TCH is also a fair option for this patient based on the BCIG criteria.
Yeah. So BCS followed by ALND was done, which reveals 0.5 centimeter residual invasive carcinoma, no lymph nodes. So what is the role of retesting receptors at this point? Dr. Amitabh Ray, you have been quiet so far.
Yeah, sorry for joining late. I don't think there's a role of doing anything as far as receptor testing is concerned at this point. Yeah. Should I?
Next question. Carry on.
Okay, definitely, Arti. Absolutely no question in my mind. Although, having said that, there are studies ongoing to test whether PAT-CR post-chemotherapy, neoadjuvant therapy, produces the same quantum of benefit that would have happened if that was not done prior to surgery, and you had a gross tumor to decide on the indications of adjuvant therapy. That's an unanswered question. As of today, yes, definitely radiotherapy.
Yeah. So suppose it was node negative clinically, or an ultrasound wise node negative, and you have given neoadjuvant, now nodes are negative on histopath, then also you will go for radiation?
So if you've done a mastectomy, probably no. If you have done a BCS, definitely yes.
positive from the beginning, na. So neoadjuvant, we have to decide the radiotherapy according to the initial clinical staging. So it is a N1 per se. So you
This
have to
patient
give
was not positive. I am asking if it was not negative at the beginning, then will you give radiation or not?
Yeah, I think if the patient is already getting neoadjuvant chemotherapy, they should be treated with both surgery adjuvant therapy.
Exactly. So any kind of neoadjuvant therapy, the teaching is that you have to go for a radiotherapy, whether it's a mastectomy or BCA. Breast
BCS
conservation, you
anyway-
have to go.
BCS
And
anyway
if it is
were
in,
doing
I mean, these things.
radiation. I think there are two schools of thought on that. One, as Dr. Animesh told, that because we don't know the exact histopathological stage at the beginning, you give radiation to all. But some people also advocate you decide by if you clinically notes are negative, you may not give after mastectomy. What about nodal irradiation?
In this particular patient, you mean, with a clinical node positive, yes. Supraclavicular definitely, and internal mammary, yes. For me, maybe no for a lot of others, because there seems to be a survival benefit when you do the IMC. Axilla, definitely no. Unless you have an SLNB which showed a nodal positivity, don't do a completion axillary lymph node dissection. We would avoid the axilla completely. But the supraclav and the internal mammary, definitely yes.
Animesh?
External extension is there to add in axilla.
So I would, the patient had undergone BCS, so I'll treat the whole breast with SCF followed by tumor bed boost. I will not treat axilla. And in this particular patient, I will not treat IMN electively unless there is gross node on pre-op imaging or unless there is central corporate tumor or the high risk features. So in this particular patient, I will not treat IMN.
What about adjuvant systemic therapy, Dr. Chandani?
In this case, the TDM1 will be the first choice.
Dr. Tanmay, same. Pradeep, Ashutosh, same. So, all of the panelists would agree that TDM1 adjuvant therapy is indicated in this patient, but not retesting of any receptors. So, going to the second case, this is a 43-year-old lady diagnosed with IDC of left breast, 3 centimeter tumor clinically, and all ultrasound also. There is no lymph node, no distant mets on PET-CT. Why PET-CT was done, that is again doubtful. This is T2N0, but maybe triple negative, that's why somebody did. Invasive biopsy was done, invasive carcinoma, grade 3, ER negative, PR negative, HER2 negative. Family history of ovarian cancer is there in multiple relatives. So will you advise neoadjuvant systemic therapy in this patient? We'll start with the surgeons.
It's a triple negative disease, so and also the tumor size is more than 2 centimeters. So
All surgeons agree. So 3 centimeter triple negative, not negative, but still surgeons would agree that neoadjuvant chemotherapy is indicated. What regimen? Yes, Dr. Pradeep.
So according to the recent guidelines, so my choice will be that Peglycarbo and pembrolizumab will be the best regimen. But it's not.
Paclitaxel and pembrolizumab, so no anthracycline.
Uh-huh.
No anthracycline, paclitaxel and pembrolizumab.
So it's not an high risk disease. So for this patient,
Not an
it's
high
a
risk.
T2 disease.
All agree that this is not an high risk.
Strong family history.
No, not related to family history, but 3 centimeter triple negative. Is it high risk or not? I don't think we can call it low risk. So anthracyclines. Yeah.
So that otherwise,
Any other opinion?
For adding carboplatin, I think if there is not very good response to the, if I start usually they see not a very good response, then I think of adding with the Dexol. Otherwise, adding only carboplatin on the basis of just going by the guidelines, I think is not a reasonable. We might be over treating the
So
patient.
what is your sequence? Anthracycline first
They
or
start with the
taxane?
anthracycline dose, then 4 cycles response. If the response is not that good, then might I think the carboplatin might be a reasonable option rather than for everyone.
Anybody using a different sequence, taxane followed by anthra?
Yeah, I think, sir, we've got enough evidence now in the form of systematic review and meta-analysis that adding carboplatin or platinum in triple negative breast cancer improves response rate significantly and improves event-free survival. Although we haven't got data to suggest that it improves overall survival, but adding platinum to the taxane and anthracycline backbone improves overall event-free survival and response rate. So having said that, AC and taxane will be our backbone, and we can definitely add platinum with the taxane part. It's up to individual decision whether to add the Paclitaxel carbo at the upfront or AC upfront. But I personally prefer using Paclitaxel carbo first, then AC or DC.
Any other medical oncologist or
Question AC, we are adding later. That main reason is cardiotoxicity, isn't it? What is the main reason for that? What else other benefits we are having?
few data earlier showed that this sequence is better, but it was refuted by some other studies also. So I don't know the so any sequence is appropriate, but if you are using pembrolizumab, it is better you stick to the study like that, Paclitaxel and the carboplatin and Paclitaxel schedule as well. It is Paclitaxel is weekly, and because pembrolizumab is 3 weekly, the anthracycline cyclophosphamide is also 3 weekly. It is not dose dense. That is how the study was done. This we have discussed already. The approval of pembrolizumab, and this is the difference. The response rates were the complete response rates were much higher, as also the EFS, but we don't know the OS as such. Now, suppose you are using pembrolizumab and the patient achieves pathological CR, then will you continue pembrolizumab in the adjuvant setting as well? In the study, it was given for total of 1 year or not.
Yes, even if patient is having pathological CR, we have to continue according to this. Continue pembrolizumab.
To Tanmay? The study was done like that, but if you look carefully, the pathological, those who achieve pathological CR, irrespective of the treatment, they had a very good EFS. So even the non-pembro group, they are having very good EFS if they have achieved that CR. So probably the adjuvant pembrolizumab is not that important, but we can't say from this trial. So this patient again clip placement. So this is very important for all the juniors out there. When you are using a regimen with a high path CR rate in a population likely to achieve high path CR, please ensure this clip placement, because otherwise the surgeon may not be able to do a breast conservation later on. So 4 anthracycline and 4 taxane was only given to this patient, dose dense. BCS and ALND was done. It was non-path CR. Now to the surgeons, one question. Suppose this patient, you have noted the family history. What about mastectomy versus BCS? Even if it is BRCA germline positive. All surgeons agree?
Mastectomy, like if you do a prophylactic mastectomy in 100 patients in this scenario, you're just taking out that area which is affected, along with that you're removing other parts also which are not affected, thinking that she might develop a second primary in the future. It's an overkill.
I would like to
In all
slightly
probability,
disagree,
she won't.
because
please.
we have such oncoplastic teams, so we can go for a nipple sparing or skin sparing mastectomy without
can.
fluorescence.
So suppose this patient comes with a report of germline BRCA positive.
No, mastectomy does not.
We'll go for a
Will you
mastectomy with
counsel
resistance.
for bilateral mastectomy at the onset?
No, you discuss the options with the patient, but it has been seen that a patient who already has a cancer in this setting, you can even do BCS and keep the patient on follow-up. I mean, BCS is not a contraindication if the patient is BRCA positive.
Yeah. And the other breast also, you can just keep it under monitoring, because these are known patient of breast cancer, the opposite mastectomy has not improved the survival in positive, because this cancer will dictate the prognosis, not the new primary. So next step, Dr. Amitav Ray, again back to you.
So you want me to talk about radiation, is it? Yeah, so yeah, it's indicated. I mean, you want to qualify for that? Yes. I mean, we've done a BCS here, so the role of radiation is still there.
And nodes?
This was a node negative
This
patient.
was node negative.
So only the breast, yes.
Only the breast.
Breast with boost, yes. That's it.
Any difference?
Like I disagree, because our practice is all patients who are undergoing neoadjuvant therapy.
Yeah, you have told that.
Got know the operative staging and I treat SCM neoadjuvant therapy.
Any systemic therapy?
We are going to treat the suplacab also here. Yeah, but upfront test is there, no?
or not, the patient, if the patient is having neoadjuvant therapy, that is an indication of post-op treatment on the same.
Why you are not treating the axilla?
I suppose the surgeon have clearly detected the axilla adequate.
This was node negative at the beginning and after chemo also. So, Dr. Ashutosh, systemic therapy.
So, no paths here. So, I like to give adjoint capecitabine in this patient, and I like to give for a year, because there is some data that 1 year versus 6 months, 1 year is better than the 6 months if the patient is tolerated.
Which data is this?
From the Chinese data, sir.
But they actually had given adjuvant metronomic.
Data is 6 months, but from the Chinese data that we have, the 1 month,
They
1 year was
adjuvant. It was more of an adjuvant trial, so not post neoadjuvant. I think it was on some metronomic dose for 1 year. So yes, some data is there. Do you start it along with radiation or not, Dr. Chandra?
After radiation.
After radiation or?
Yes.
Yeah. So in the CREATEC study, it was given after completion of radiation, but some people have given lower dose. In general practice, no data for that, lower dose capecitabine along with radiation, and then follow it up with the next part. So I think we can conclude here. The key messages being that NSCT can definitely improve the outcome of operable breast cancer in multiple ways, especially for HER2 positive and TNBC, because we can select out the post-adjuvant therapy, post-neoadjuvant therapy, or post-surgical therapy in this patient in a better way if we have given neoadjuvant therapy. Because, for example, TDM1, if you give in the adjuvant setting after upfront surgery, there is no benefit. But if you give it to selected patients based on non-path CR after neoadjuvant chemotherapy, then there is benefit. So same thing works differently in adjuvant and post-neoadjuvant setting. And same for capecitabine. We don't have any great data for adjuvant capecitabine. In fact, it failed in various studies of AC taxane followed by capecitabine like that. Adjuvant, it doesn't work, but it works in this group after neoadjuvant therapy. So for that, it's very important to do TrueCut biopsy upfront and receptor status, because many times it is surgery is done after FNSC or TrueCut biopsy without ISC. Then you will miss this information, and the neoadjuvant chemotherapy opportunity will be missed. And obviously, we need good communication between all the members of the team to achieve the desired outcome, because between surgeon, radiologist for the marking and all, and medical oncologist. And this we have already discussed, tailoring the post-NSCT and surgery treatment based on response to NSCT. So I think that's all from our side. Thank you. Thank you to all the panelists.
Thank you, Dr. Ghosh, and all the panelists for the nice discussion. We are going ahead with the international we will be continuing with the international seminar, international speaker, Dr. Whitley, on radiotherapy. Kindly stay And if there is any technical error, then we might have to abandon that.
Yes. Hello. 15 minutes. Oh, it was slide 2. Yeah. No, we could not say anything beyond this. Yes.
whether they had lymphedema or not. So 7%, 10% in the 50 gram, only 100 patients or less in 27 grey arm. So, but these are descriptive analyses. When you break down the arm, shoulder pain, difficulty raising arm, shoulder stiffness, and a 26 grey arm and a 40 grey arm, the figures are roughly the same. So, when the patients to assessed on 3 years, and definitive assessment of non-inferiority of weight, 5 years, the other 2 years to wait, and the efficacy, we don't expect the radiotherapy to battle the breast, but there'll be been very widely adopted almost overnight due to COVID, but it's because of COVID, but because of the results in data the last 10 years in various subgroups studies, there were other data later. It's just where people took part in this, UK centres and huge groups, and we were under the watchful eye of Professor John Arnold, who we thank a lot. So hopefully you could hear me there, and sorry I got cut out first time round. Hopefully I kept my time short. Or when you
Sir, we can't hear you, sir.
You can't hear me.
Now we can hear. Sir. Hello. Hello. Can you switch off your video, sir? Hello. Sir,
So I think we have to stop this virtual program. Now we have one discussion on talk. This is a talk by Dr. Shona Nag on optimal management strategy in HER2 positive CNS metastasis. Yeah, Dr. Nag, please. Dr. Shona Nag is the medical oncologist and director of oncology, Sahyadri Hospital, Pune.
Yeah, so good evening, everyone. And I've been patiently awaiting my turn, and I've learned a lot of radiotherapy in the meantime. So thank you, Dr. Prasenjit, for inviting me. And my mandate is to talk about optimal management strategies in HER2 positive CNS metastasis. So brain metastases are a frequent site of dissemination in breast cancer. Half of patients with HER2 positive disease will get this. 25 to 45% of patients with TNBC and 10 to 15% of patients with ER positive disease. There have been a number of advances over the past 2 decades, improvements in surgical techniques, demonstration of SRS benefit over WBRT in patients with limited disease or after surgery, reduction of morbidity with whole brain using hippocampal avoidance and memantine, and development of CNS active systemic therapies for HER2 targeted disease, which I will be talking about. So Survival after a diagnosis of brain mets is most favorable in patients with HER2 positive breast cancer. And you have here a very nice online tool to calculate the GPA or graded prognostic assessment. And here, over 2,400 patients with breast cancer and brain mets, which were diagnosed over a period of 10 years, were included. And you can see that the median survival is best for the HER2 positive group, ranging from 24 to 36 months, where it is very poor for triple negative, less than 6 months. It's very important to also notice that we've made a lot of advances, and we've talked a lot about this today. Advances in systemic therapy for early breast cancer have taken place, but they've not really impacted the CNS recurrences as first event. And CNS relapse really continues to be a huge clinical problem. Our patients with HER2 positive disease are living longer. The brain is a sanctuary site, and there is CNS tropism for HER2 positive breast cancer cells. So whether it's the Catherine data, whether it is the HERA trial, we have data to show that CNS mets are something we still cannot prevent. So let's talk about systemic therapy for HER2 positive brain metastasis. We have a host of agents. We have the TKIs, lapatinib, neratinib, and tucatinib, and we have the monoclonal antibodies and antibody drug conjugates. So let's go back to the older data. Lapatinib is a drug which is freely available in India. We have a lot of generics now available. So looking at the data for lapatinib and capecitabine, in pre-treated patients who had received brain radiation, the overall response rates varied from 20 to 38%. And then there was the landscape study published in Lancet. And here patients were not treated previously. And here in the upfront setting, the combination gave a response rate of as high as 66%, with a progression-free survival of 5.5 months, which is pretty good. The pooled meta-analysis also showed less responses for pre-treated patients and better for combination, and a median PFS of 4 months and overall survival of 11 months. What about neratinib? So if you look at the NALA registration study, it excluded patients with brain mets. But the TBCRC study looked at the combination of neratinib with capecitabine. And if you look at the cohort 3A and 3B, in 3A, patients had no prior lapatinib and had good CNS overall responses with a progression-free survival of over 5 months, and those who were pre-treated did a little worse. The real drug that one needs to really talk about and think about is tucatinib. We don't have it available in India. Hopefully it will come soon. This is different from the other TKIs because it's a selective HER2 inhibitor with very little EGFR activity. It has shown activity in preclinical models, and it crosses the blood-brain barrier. So this was the HER2 CLIMB study, which is really an amazing study. It included patients who'd been treated previously with TRAS, PERT, and TDM1. Patients had a brain MRI at baseline. It was one of the first studies to include purposely and a reasonable number of patients with brain metastasis. These were either previously treated and stable, or they were untreated brain mets not needing immediate local therapy, or they were previously treated progressive brain mets not needing immediate therapy. So there were a cohort of brain metastasis patients. Patients were randomized to trastuzumab, capecitabine with or without tucatinib. Almost 48% of patients had brain mets and 60% had ER-positive disease. Let's put the results into context. This was a very nice publication in NEJM in 2020. And if you look, they had CNS PFS as a secondary endpoint. 291 patients out of almost 600 patients had brain mets. There was a benefit of 5.7 months in progression-free survival in these patients and a 6-month benefit in overall survival. What about patients with active brain metastasis? 174. Again, a 5-month PFS benefit and a 9-month overall survival benefit. Those with stable brain mets had an 8-month benefit in PFS and a 3-month benefit in overall survival. The intracranial responses were much better, as was the duration of intracranial response. And this is the most recent data for the overall survival in patients with breast cancer brain metastasis. It improved from 12.5 to 21.6 months with tucatinib. That is a 9.1 month absolute improvement. What about other strategies? So some investigators have used high-dose trastuzumab along with PERT, and here it has been given as 6 mg per kg once a week, which is a pretty large dose. The overall response rates were very modest at 11%, but there was a clinical benefit rate of 68% at 4 months and 51% at 6 months. Does TDM1, an antibody drug conjugate, again, which is available freely in India, and we have a biosimilar as well, does it cross and is it active for brain metastasis? Yes. So these are patients from the ESME data set. And in the 126 patients with measurable disease, the best response was 21% and a good clinical benefit rate. And a partial response was seen in patients in 32% who'd received radiotherapy more than or equal to 30 days, and 49% response rate in patients who had not received radiotherapy. So it is a decent drug. And the new kid on the block and the drug that everybody is talking about, soon to be available in India next year, first quarter, is Enhertu or trastuzumab deruxtecan. So if you look at this drug and you look at the CNS subset in the Destiny Breast 3 study, which randomized patients to deruxtecan versus TDM1 in the first line setting, you can see that the progression-free survival improved with deruxtecan to 15 months versus 3 months. The 12-month PFS rate was 72% versus 20%, giving you a very good hazard ratio of 0.25. So clearly, this drug is doing something in the CNS. And there have been a number of groups which have studied TDXT. You have the Tuxedo study, Debra study, and a multi-institutional study. And all have shown response rates of between 50 to 70% in patients with active brain metastasis. So this is a study which is actually randomizing patients and dividing them into 2 cohorts after including patients with brain metastasis at baseline, and then seeing the activity of the drug in terms of PFS and OS. So these are the combinations. We've switched our attention from just using one to using a combination. The results of the first 2 trials that are mentioned here are already ready and will be presented hopefully this year or next year. And the HER2, so there is TDM1 with tucatinib, TDXT with tucatinib. These are all in the metastatic first line setting and second line setting, except for the COMPASS trial that you see last, which follows the Catherine design, but in addition to TDM1 for residual disease, also randomizes patients to tucatinib yes or tucatinib no. So this should be really interesting to see if we can prevent the CNS events in these patients. What about leptomeningeal disease? It remains a poor prognosis. This is extensive data again, the French ESME database. Over 22,000 patients with metastatic breast have been included. 312 received intrathecal therapy. And as you can see, the overall survival is pretty dismal. It is less than 6 months across all the subtypes. So what about this wonderful drug tucatinib, capecitabine, trastuzumab combination for leptomeningeal disease? The TBCRC again has a trial, and the median overall survival you can see in the red line, this is a phase 2 study, is 10 months, and the median time to CNS progression is 6.9 months, which I think is pretty good for this clinical subset. Intrathecal trastuzumab has been used, I have been using it in practice as well. We have US and French studies. They use 2 different doses. These are very, very small numbers, but you can see that there is partial response of 19 to 20%, and the overall survival varies from 8 to 10 months across both these studies. Does trastuzumab deruxtecan work for leptomeningeal disease? Yes, there is a hint that it does. And these are just very, very small studies which show that some patients have been on some patients have been on deruxtecan for over a year, and some are still ongoing with a survival of about 8 months. So how do you choose between HER2-directed regimens? Tucatinib, capecitabine, trastuzumab perhaps is the most active in the brain. And if you're choosing to treat someone, this is what you would choose. It has category 1 in the NCCN guidelines. Everything else is category 2B. The ADCs are coming up in a big way. Deruxtecan and TDM1 also have CNS activity. And I've had some experience with TDM1 in CNS metastasis in the clinic, and patients are doing well. And one would generally, after the data of Destiny 3, choose TDXD before TDM1. For patients with leptomeningeal disease, you can choose either the triplet or intrathecal or TDXD. So I've put forward a few clinical scenarios which will help us to make decisions in the clinic. You have a young lady who has HER2 positive metastatic breast cancer, well-controlled systemic liver metastasis. She's on maintenance trastuzumab and pertuzumab, and she comes with headache. The brain MR shows 3 lesions, the largest is 1.4. So in this case, what you'd probably want to do is refer her for SRS and continue the same systemic therapy. On the other hand, you have an older lady with HER2 positive metastatic breast cancer who's already on trastuzumab, pertuzumab with very stable liver disease. And after she has received SRS for 3 CNS metastases, within 6 months, she comes with new brain mets. So that's not a great sign. The brain velocity is very high. And rather than give a whole brain RT, you know that you have a combination of tucatinib, cape, and trastuzumab, which is active in the brain. So you would defer the SRS and probably change her systemic therapy. What about a 54-year-old lady treated with trastuzumab and pertuzumab and who's had SRS for 4 brain mets 11 months ago? Now she has progressive liver mets and the brain is stable. So in this case, you would definitely like to change the systemic therapy and you'd go for something as TDXD. If not available, then TDM1. And the last case scenario is a youngish lady with HER2 positive MBC treated with extensive systemic therapies, but presents now with leptomeningeal disease, and her extracranial disease is stable and controlled. So in this case, you'd probably give palliative RT, and you may consider intrathecal trastuzumab. So in summary, the management of patient with brain mets requires close multidisciplinary collaboration. Systemic therapy can improve outcomes in patients with HER2 positive disease. When we say the drug is not able to cross the intact blood-brain barrier, it does not preclude CNS activity, and you've seen this with antibody drug conjugates. And the blood tumor barrier is way more permeable than the blood-brain barrier. And inclusion of patients with both stable and active brain mets in clinical trials is very, very important to make progress with this difficult clinical situation. Thank you for your attention.
Thank you, madam, for your lovely talk. Thank you, madam. We will have question answers, not now. If at all, we can discuss in dinner. We are running short. So hereby, on behalf of Dr. Boral and Dr. Provi Bijaykar, I conclude the session. Thank you.
Thank you, ma'am, for the very informative talk. Moving forward for the next session, I would like to invite Dr. Subrata Saha, Senior Consultant Radiation Oncology, Apollo Multispeciality Hospital, Kolkata, Dr. Shyamal Sarkar, Senior Consultant in Radiation Oncology at Narayana Super Speciality Hospital, Howrah, and Dr. Arunabha Sengupta, Senior Consultant in Surgical Oncology at Apollo Multispeciality Hospital, Kolkata, to chair the next session.
Good evening, everybody, and thanks Shayan and Prashanjita for inviting me to give the talk. You would like to?
I would also like to invite Dr. Arnab Gupta, Director of Thakur Pukur Cancer Center, to kindly chair the session. Thanks.
Good evening. So I'll be speaking on managing the axilla in breast cancer surgery. Now, this has been a very changing field of late. When I was doing my residency in the late 90s and early 2000s in Tata Memorial Hospital, Mumbai, then managing the axilla meant doing an axillary clearance. We used to do that for all patients, be it a mastectomy or breast conservation surgery. But now things are changing and we have to move with the times, I think. So I've been covering three topics: management of the clinically node-negative axilla, management of axilla in neoadjuvant settings, post-neoadjuvant therapy, and management of the positive axilla. Now we all know this end staging of breast cancer, N1, N2A when it's a matted mass, N2B mammary, N3A infraclav, N3B both mammary and axillary, and N3C supraclav. Preoperative assessment of the axilla. Now, high resolution USG with FNAC provides 100% specificity and 78% sensitivity, and imaging in the form of CT or MRI is highly sensitive but less specific than high resolution USG and FNAC. Node negative axilla. So, assuming that most of our assessment, especially in early breast cancer, is happening with USG and FNAC, with or without FNAC, that is how we find a node negative axilla. Now we come to the concept of the sentinel lymph node, the node on watch, which is the first node to receive cancer cells, and then upstream. If that is negative, rest is negative. That is the premise of the basic premise of sentinel node biopsy. Who do you select for sentinel node biopsy? Early breast cancer, clinically and radiologically N0, and some DCIS patients. Contraindications: clinically, radiologically positive nodes, inflammatory breast cancer, pregnant patients. Relative contraindication LABC, but post-neoadjuvant chemotherapy, the role of sentinel lymph node biopsy is increasing. And previous breast and axillary surgery where the lymphatic channels may have been disturbed. We use radioactive collide and blue dye. Other agents are investigational. In our institute, we use methylene blue and 99 technetium sulfur collide combination. The combination gives a 95% sensitivity and a 73% specificity. We inject the collide on the morning of surgery, and we inject the blue dye 10 minutes before incision. And the best way to inject, the most sensitive way, is intradermal periareolar. That gives a 95% identification rate and a 6.5% false negative rate. So that is, I think, adopted across most institutions as far as sentinel node biopsy is concerned. How many nodes do you harvest? Now this is what we usually do is we use a gamma probe to identify the sentinel node. We make a small incision and we identify the hot blue node. We also use palpation, that is a standard technique. So it's also identifying the blue node, the hot node, identifying some other nodes in the vicinity. So if you biopsy 4 or more nodes, then your accuracy is likely to be 100%. The lesser the number of nodes, lesser is the accuracy. But sometimes we do find a single node which is giving a very strong signal and which is like deep blue, and other nodes are not giving a signal. So it's not that we always harvest 4 nodes, but we try to harvest as many nodes as possible. You can sometimes not see the sentinel lymph node, because if your gamma probe is facing in the direction of the nipple areolar complex, then you can get a shine through from the primary. Sometimes node is filled with tumor and there is redirection. Tumor size can compress, and of course there may be technical issues with equipment or manpower. Pathological examination. The most specific is touch imprint cytology. It is not always, the pathological expertise is not available everywhere. What we use in our institution is frozen section. which is 98.5% specific, 87% sensitive. And the most sensitive and specific is OSNA, which is one-step nucleic acid. We don't have that. Indications of sentinel node biopsy, which is invasive cancer with a clinically and radiologically negative axilla. A DCIS with suspicion of invasion or requiring mastectomy. And a node negative post-neoadjuvant chemotherapy. So let's come to the trials. There are a few trials which will take us step by step into the evolving concept of sentinel node biopsy and where exactly can we use sentinel node biopsy. The indications are increasing. So the trials to see the accuracy and morbidity were mostly the Almanac and NSABP B32 to identify patients who can be spared axillary surgery but are sentinel lymph node positive. We have ACOSOG Z0011 and IBCSG 23-1. And for high-risk nodal burden patients, can we leave them with sentinel node biopsy alone? We have ARMA. So I'll be covering these 5 trials very quickly. So coming to the Almanac trial, it's a multi-center trial to compare quality of life outcomes between sentinel lymph node biopsy versus axillary clearance. The trial was completed in 2003. 1,031 patients were adopted, and the overall quality of life in both the Almanac and the NSABP B32, I'm going a little fast because of time issues. The drain usage, length of hospital stay, time to resumption of normal day-to-day activities, everything was better in the sentinel lymph node group. So the interpretation of the NSABP B32 was, I would draw your attention to the line in bold. Overall survival, disease-free survival, and regional control are statistically equivalent between groups. When the sentinel lymph node is negative, sentinel lymph node surgery alone with no further LND was safe. But when the sentinel lymph node was positive, we needed to do an axillary clearance. This was the Almanac and B32, which provided this basic presumption, which we have been working on now, and good quality of life. Now, do all positive sentinel lymph nodes need ALND? Here we come to the ACOSOG Z01 Alliance trial. The eligibility was T1, T2 tumors, 1 or 2 positive sentinel lymph nodes, not more than that. Breast conservation surgery, post-op adjuvant therapy, radiation, etc. Patients were randomized to axillary lymph node dissection versus sentinel lymph node dissection. 1 to 2 lymph nodes positive, axillary lymph node dissection was not done. You can see that the 5-year breast recurrence, 5-year nodal recurrence, 5-year overall survival, more or less similar in both groups. So conclusion, don't look on the left because there's lack of time. I don't want to go through the limitations. There were limitations to the study, a lot of them. But the conclusion was, despite the widely held belief that ALND improves survival, no significant difference was recognized by this study. Now remember that this study focused on only women with 1 or 2 positive sentinel lymph nodes, not more than that. That brings us to IBCSG 23-1. These patients were again less than 5 centimeter in size, N0 clinically, radiologically, 1 or 2 sentinel lymph nodes positive. Now this study looked at patients with micrometastasis, less than 2 millimeter deposit in the nodes, and there was no statistical difference in disease-free survival rates, ALND versus without ALND. So again, we find the same thing. Now we come to the ADOS trial. These are designed for high-risk sentinel node positive patients who do not fit into the ACOSOG Z0011 in the sense that more than 1 or 2 sentinel lymph nodes were found positive. This was the first trial to compare axillary lymph node dissection versus radiation. So in this trial, T1, T2 primary breast cancer, no palpable lymph nodes, ultrasonography, no lymph nodes, so clinically, radiologically N0. Primary endpoint was non-inferiority 5-year axillary recurrence. February 2001 to 2010, 4,806 patients. AMARAS trial, 33, now 1425 patients with positive sentinel lymph node were randomly assigned to axillary lymph node dissection and axillary radiation. 33% of patients who underwent axillary clearance also had additional positive nodes. you see 5-year axillary recurrence, in spite of 33 patients having additional positive nodes in the ALND group, was 0.4% in ALND and 1.1% in RT. And lymphedema in the arm was significantly more in the ALND group. So, interpretation was axillary lymph node dissection and axillary radiation after a positive sentinel node biopsy, comparable local axillary control for T1, T2 primary breast cancer, and leads to less morbidity. So, AMAROS trial showed axillary radiation to be an acceptable alternative, but it is yet to be accepted as a standard approach. Can we omit sentinel lymph node biopsy altogether? That was the next question being asked. Yes, there are cases where we do no axillary staging, pure DCIS undergoing lumpectomy, elderly patients, T1, T210, hormone receptor positive, low Ki67, prophylactic mastectomy, and primary breast sarcoma. Now, abandoning sentinel lymph node biopsy, can we leave out sentinel lymph node biopsy altogether? So, this is a new trial in progress called SOUND, sentinel node versus observation after axillary ultrasound. I won't go into the details of the trial, but basically this is to verify whether in the presence of a negative preoperative axillary assessment and without the pathological data which comes from a pathological staging of the axilla and adjuvant therapy not guided by axillary data, is the survival same. The estimated study completion date was December 2021, but it has not yet been published, probably for COVID-related reasons, but we look forward to the publishing of this data. Can we omit the axilla altogether? Similarly, there is the INSEMA trial, restricted axillary staging. Not a very complicated design trial. This is restricted axillary staging in clinically and sonographically node-negative early invasive breast cancer. So patients will be first randomized to either no axillary surgical intervention or sentinel node biopsy. Patients with positive sentinel lymph node biopsy will be randomized again secondarily to sentinel node biopsy alone or completion axillary clearance. So there will be initially 2 arms which will go on to become 3 arms. The INSEMA trial will answer some questions like it remains unclear whether patients without SLNB can be offered partial breast irradiation alone in low risk situation and whether sentinel node biopsy can be avoided totally in patients with T1, T2 tumors who have a mastectomy indication. The estimated completion date is December 2024. Similarly, POSNOC 64 with a planned sample size of 1900. POSNOC is to evaluate whether women with breast cancer and 1 or 2 macrometastasis, whether the patient with sentinel lymph node biopsy positively assigned to axillary clearance versus radiation versus no therapy. So this result is expected in December 2026. So these are 3 trials where will be exciting to see what comes up. We of course know the axillary sampling, which is a blind technique, and we rely on it when there is a failed SLNB or no facility of SLNB. This also provides a 95% accuracy, let me tell you, in experienced hands. But the sensory loss and lymphedema is worse because usually more than 4 to 5 lymph nodes are sampled and essentially results in a level 1 axillary clearance. But it does have an accuracy of 95% in experienced hands. And sometimes we do have to resort to it when there's a failed SLNB, we don't get a signal, we don't find a blue node, we have to do this or we have to decide on doing an axillary clearance altogether. There is Dr. Burma's paper from TMH, there is sentinel node biopsy versus low axillary sampling, where to remove all the fibrofatty tissue below the second digitation, and they did it before doing a sentinel lymph node biopsy, and the false negative rate was not insignificant. So it was also an effective low-cost procedure in developing nations which can be used. Can we use sentinel lymph node biopsy after neoadjuvant therapy? Is it safe and reliable? Now, this is still debated for patients who were initially node positive on axillary assessment, later converted to N0 status. Most guidelines still recommend LND and we still do LND for these patients, but there are some things to be thought about. Patients with clinically node positive, it can eradicate nodal disease in 40% of patients, more for ER positive, HER2 positive tumors and triple negative tumors. A dual tracer technique can be used with the removal of more than 3 sentinel lymph nodes is good enough. This is a reliable technique, can be used after neoadjuvant chemotherapy also. But when it is used, as far as the ACOT, there are 3 trials which are in favor of this. When you look at the last red mark, over there, left hand side, lower left hand side, when you use more than 3 lymph nodes are removed, the false negative rate is 9.1%. The other false negative rates are not so good. Those are mostly above 10%. So we still routinely do axillary clearance post neoadjuvant chemotherapy, but probably with a dual technique you can. This is the Acozoc Z101. I won't go into the details. Targeted axillary clearance, a clip placement in the axilla. When you do it after neoadjuvant chemotherapy, you have to remove both the clip and the sentinel node. Add 3 nodes and you have almost equivalent accuracy to non-treated patients. Node positive axilla, we all know the indications for doing a node positive axilla. Node positive disease, inflammatory breast cancer, local recurrence, etc., etc. Complications of axillary clearance are well known. Lymphedema doesn't happen so often nowadays with modern methods of dissection, but yeah, it is a clear and present risk factor. So the conclusion would be, if you look from below upwards, initially it was axillary lymphadenectomy level up to level 3, then we moved to up to level 2, then we moved to blind axillary sampling, then to axillary sampling targeted, then came the sentinel lymph node biopsy, node negative, even for node positive patients. Now we are moving to node axillary surgery based on the results of the SOUND trial. So the conclusion is, we are switching to a new paradigm from the maximum tolerable treatment to minimum effective treatment across surgery for almost all cancers. And that is what the future should be, because quality of life is now more important than ever. Thank you. We have to await the results of these trials which are finishing in 2024, 26, etc. But maybe, I wouldn't say axillary clearance can be omitted altogether, but the role of sentinel lymph node biopsy will increase and targeted axillary dissection will increase. Complete axillary dissection would probably become less and less. Sorry, time is up. No more question is allowed. Call Dr. Tanvi Shahi. Panel discussion on locally advanced breast cancer. Thank you, Prashajit sir, Sayan Paul, my friend, and everybody for putting such a great show. I've been requested to complete the panel discussion in 15 to 20 minutes max, so we'll try to hurry it up. Okay, so already all the panelists are over here. Vikas Agarwal, Vikas Agarwal, he was here somewhere. Neha is here, Anand Mandal, Arindam Mandal is there, Samin Das is there. Amit is not, so instead of Amit, Sudeep is filling his place. Sudeep is he there? Yes, so Sudeep is there. Reema is here, Mukti, Vikas, and Anupam, all are here. So this is not a cookbook case, it's a real case, and we have just treated this patient, and this patient has been treated from Tata itself. So she's a 40 years old premenopausal lady, and she presented with a right breast lump since last few months. And on examination, there was a 5 into 5 centimeters lump in the right breast with a small axillary lymph node on the right side itself. So I'll begin with Neha. Which investigations you will offer in
face was the cost of PET scan is lesser, and patients have to go twice for two appointments. And the evidence for PET scan, as stated in workup, is also we can go for a PET scan.
So Dr. Nihal means in practicality we do PET CT, but cross-sectional imaging like CT scan, thoracic focus along with bone scan. But in practicality we do PET CT. So right was which mass which was category 4. But what was interesting in that there is a left breast, there was also one of the lesion which was 1 into 1 centimeters. Somehow it was a like and it was indeterminate. So for this should we do MRI? And I'm just putting this case because in this case MRI was done, and that is the reason I said that
MRI is used to try and solve decisional conflicts like these where you have indeterminate contralateral breast or ipsilateral breast satellite nodules, which you want to upfront figure out what you want to do. And if I'm not wrong, she's a premenopausal young lady.
Yes, she's a premenopausal.
So several times such women have dense breast.
So Rima, sorry to interrupt, but the reason why I'm asking the MRI, isn't it a too big investigation? The reason I'm saying is not that commonly available because of the breast coil, that's important. So can this be tackled with just a good ultrasound with a good localization?
So I'm assuming since this was bilateral mammo and sono done at PMH, you have a breast-specific radiologist looking at the ultrasound. And even if after that it's indeterminate, so we have something called as contrast-enhanced mammography that we are doing these days. But when that is also not available, perhaps MRI can help.
Okay, so that was the reason why MRI was done in this case, and it's really very interesting because this patient was a general category patient, but yet MRI was went and done. And right lesion we could see a mass in the right breast, and in the left breast there was a dawn enhancing mass in the left breast, and that was basically the suspicion basically. And this is again the same the MRI picture. Again I'm coming back to Neha. Neha, can you just say about this, because this is the left breast lesion, and here I could see something which is suspicious. Probably this might be the culprit for which the MRI was done.
So, first of all, this is a heterogeneously dense breast. It's not a very fatty breast. So, some small lesions can be obscure. Second, yes, we can see in the upper half, this is the left.
Left.
So in the inner part, we are able to see that there is a small density which looks suspicious. I think that should be well.
So that's the reason. So, okay. So, any role of MRI in LABC? Mukti, can you just be very brief? We are talking about the already discussed about the role of MRI. Now I am talking about MRI in LABC.
Yeah, for like Dr. Rima ma'am already told that ipsilateral breast, any other that multi-centric disease is there or not in contralateral, as well as for if neoadjuvant therapy is being planned, so for that also MRI is a good modality.
Okay.
For responses.
So just to point here, routine MRI in LABC is not indicated. MRI is indicated only in certain scenarios if the mammography is very dense and you're not able to see it properly, or if there is an occult, if there is a positive axillary node and you're not able to find a lesion in the breast on ultrasound or mammography, or in cases where which is very high risk, like we have a BRCA1 or 2 patient.
Okay.
In those cases, or indeterminate lesion as you know.
Okay.
So, just can I make a comment?
Okay, so
because we have students.
Like
So the
just to interrupt, so it is Dr. Prashanjit Chatterjee's question is that what is the take home for MRI?
Yeah,
Can you
yes. So
both the breast coils.
So the indications are very clear. Axillary nodal mates without a known primary, number 1. Number 2, Paget's disease. Number 3, if you are having an implant, to investigate that. Number 4, to screen very high risk young patients with denser breast. These are the indications for diagnostic purpose. For the purpose of once you diagnose as a case as a LABC, then number 1, to look for any multifocality in the ipsilateral breast, to
to look for any occult lesion in the opposite breast, especially the patient is younger with denser breast. Next, if you are planning for an NACT, sometimes to see the response, if you are specially planning for a post-NACT breast conservation surgery.
Absolutely. So yes, so it is with the breast coil. Sorry, sir.
Sir, routine MRI is not indicated, only
routine-
specific.
so it
You
has-
don't have to do MRI in all cases of
So
LVC.
that
There
is
is
very clear. The routine MRI will not work. It has to be with the breast coil, and even if you want to do a biopsy, that also has to be MRI compatible coil. So coming on to Dr. Vikas, again I'm coming back to this question, like when you are sitting in the OPD and the same patient comes, PET CT scan you are doing, and what advantage you'll be getting by doing a PET CT scan?
The PET CT scan, if we, as Dr. Prasenjit also asked, you don't have a breast coil in most of the places, it will highlight about that indeterminate lesion. It will clarify the distant metastasis if which is missed. As Dr. Neha was saying, CT, abdomen, CT, chest and bone scan. But at the same time, in a practical point of view, it will reduce the chance of cost toxicity to
so
the
it
patient.
has a-
Apart from it, the PET CT has a higher sensitivity. Correct.
The PET CT scan is not done primarily for the primary disease or the axillary
Not at all.
disease. It
Not
is
at
for
all.
the distant
Yeah, for the
metastasis
distant
only.
Okay, so any of PET CT scan was done for this patient. It showed a right breast mass and there was a small axillary lymph node, and it was diagnosed as the stage T4B N1 M0. T4B because skin was involved, but it was a very focal skin involvement, and it was HER2 negative. Now, core biopsy was done, which it proved to be invasive breast carcinoma, ERPR positive, HER2 negative, and the core biopsy was done from the right breast, which came to be a fibrocystic disease. Now, what pre-chemo intervention should be done for tumor bed localization? Now, this is very important because, as such, Dr. Gupta is here, and Dr. Shubhadeep is here, Dr. P.V. Gar is here. Sir, how many times when a case comes to us, you send it to surgeon or so that they can put a clip something kind to so that at the time of surgery you can identify the tumor bed. How many times you do that? So, I mean, Arindam can take, anybody can take. I mean, how many times is that possible? I mean, do that it is a routine practice.
So, routinely the biopsy is taken by us, surgeons. So, most of the times it becomes easy. Once we get the report, then sending for implant where it is available, implant localization to the radiotherapy, yes, we do. But routinely in a busy setup, like for example, when we in TMH, we used to do only the scar, which we used to give a proper scar to the biopsy basically. So that itself would be a guide, like a tattoo.
So
Basically,
I was
other
off, and Somen, you want to add something?
If you are planning for a post-NACT BCS, then it's a mandatory kind of thing. Otherwise, if you are planning mastectomy, if you have planned it right now that I'm going to do mastectomy later on,
Then I
it's
don't
not a
require,
mandatory.
of course, yeah. So yes.
So, sir, in this case, this is T4B lesion. What you told is there is a localized perineum lesion. Now, this makes it LABC with T4B lesion. The evidence of BCS post NACT in LABC is limited. But at this stage, we need to understand, are we going to offer this patient mastectomy or a BCS? If we are offering this patient BCS, then the accepted method is to put a clip at this point of time.
So,
What Dr. Arindam was saying is put a stitch on the
So the reason you are absolutely right. I'm saying that theoretically it is absolutely right. My question was a practical approach, that how many times you do. Often when I was discussing with you, you told that as a routine, wherever you feel that BCS will be done, you will definitely put. But what do you do, sir, in your practice, Dr. Gupta, sir? You do it. You do it. You put a clip. Okay. So no, sir, not in this case. I'm asking, like, even in LABC, like where you feel so that this patient will be probably can be taken up for BCS, then will you put it or not?
LABC or not, when a patient is going for neoadjuvant therapy, suppose you have triple negative early breast cancer, going for neoadjuvant therapy, and if BCS is planned, you put a clip.
So, Dr. Vikas, you are adding anything?
Clip is agreed. The scar, it was a past practice, but now the problem with the scar, the practical, whenever a sonologist,
that is not sensitive. That is not sensitive, but still.
And the position of the patient in the table of the USG is by the side. And when we do surgery, it is this, but the scar will change.
But even like, even I think it was Dr. Nayar's paper, you know. Which
So actually, I discussed this very much in detail with Nutan that we have in Tata, we have been putting a stitch on the center of the lump to have a core biopsy scar, and that is what we've been following. And we just use that as a marker, take out the skin till the depth of the peg. And when we take that scar, we do it in a position that it is in the center of the lump.
So in the
What they have done in Tata
Dr.
is
Neha,
they have
Dr. Neha,
analyzed.
stop it in the positive time will move, you know.
They have, they have analyzed the retrospective data, and the difference is not higher.
Yes, so the thing is that it is mandatory. So what Dr. Gupta sir told that if you are planning for NACT, go ahead and put it. Now it is to Dr. Vikas and Dr. Sudeep both.
That is the exam answer.
Exam answer, right. No, but PGT is accepting you to give the exam answers also. So this patient is being LABC taken up for NACT. So because you can take up some and Sudeep will add up because he's a hardcore medical oncologist, will add up to the expertise. You take it one by one.
So NACT is given, yes,
Yes.
and definitely there is a lot of discussion already today regarding ER
Lot of discussion, yes.
and HER1 positive versus HER2 positivity. So that will definitely change the regimen, and if the patient is affordable, if HER2 positive, Suzumab or something will be added up. Okay. NACT will complete 4 cycles and followed by assessment for surgery. Yes.
Okay, so NACT is a must. So Sudeep, you want to add anything else? I mean, we are not going to the details. I mean, still.
So regarding NSCT for HER2 negative, everything is standardized. It is 4 cycle of anthracycline and it should be dose dense. That should be the current standard, and that followed by taxane. Of course, there should be in between clinical assessment by the surgeon also between the anthracycline and taxane. Taxane should be also 4 cycle dose dense or at least weekly, not 3 weekly. That is not considered the standard of care today. And if it is HER2 positive, I'm not very confident that using a dual HER2 blockade, how much benefit you will achieve. The benefit is in IDFS, it is not in OS, and that benefit also close to 1 or 2% IDFS benefit. So I'm not very big fan of HER2 blockade in neoadjuvant setting.
Okay.
Rather, I am happy with taxane and trastuzumab.
So moving on to Dr. Anupam now. Any role of neoadjuvant hormonal therapy in LABC vis-a-vis comparison to neoadjuvant chemotherapy?
Not in premenopausal.
Okay.
In postmenopausal patients who are not eligible for neoadjuvant chemotherapy due to medical comorbidities or age, we can consider like we did during our COVID times.
Absolutely.
Otherwise, not in premenopausal, certainly not.
Excellent. So this is the paper which I got, and it was not for premenopausal, and it was found to be that neoadjuvant hormonal therapy was inferior as compared to neoadjuvant chemotherapy. Patient as patient was taken up for 4 cycles of BC followed by 4 cycles of taxanes, and thereafter patient was planned for BCT. Probably I think this is because of very focal, but otherwise patient went for SMAC. You know, that is simple mastectomy axillary clearance. Now again, I can take it to Arindam itself. Is it oncologically safe Arindam to do?
Actually, I had a question before that. Since we saw there was a satellite lesion on this, which was in a different quadrant altogether, 1 o'clock and 9 o'clock.
Right.
So how, regarding a plan of BCS for this patient?
The FNAC was done, and FNAC did not prove it to be.
On the left of
Yeah,
on the
so
same
FNAC was it was proven that. So is it so the thing is that I'm not aware, at least I was one, that is it oncologically safe to do BCS in a LABC?
So as Dr. Neva was telling, the evidence is not very strong, but then we have evidence from MSKC and also from DMH.
So we
And we have MD Anderson.
Yeah, so in a decade-old paper by Dr. Vani Kamar, which had shown that it was comparable as such, but this is really an old paper. Remember, any randomized control trial hardcore, except for the Lebanon study, which was just classed. So this is the technology, and so I'll not even ask you. This is positive time. Again, and then that message also should go. She's against transmission in the name of LABC, not
patients who is high risk patient that she was requiring chemotherapy, so she will be benefited with total ovarian surface. So this should also, yes, this should also. Agree? Everybody agrees to that? The time we end, and thank you so much. Thanks a lot. I'm sorry I have to rush through because that was the instructions given to me. I'm very sorry for that. I had to rush this side. Thank you so much. To this wonderful session, I request Dr. Vijay Anandreddy, who is the Director and Senior Consultant at Apollo Cancer Hospital, Hyderabad, to come to the podium for his deliberation. Breast Cancer Review Summit 2022. Very good evening. I also sincerely thank Prasenjit and Sam for inviting me. Pleasure to be here. Really sorry for my team. Chennai, so Prasenjit did not allow me to change my attire. Very briefly, heard this I most of it probably would be a repetition. So briefly what's new things that have happened in the recent past. I'm only going to touch base on the innovations that have happened in various aspects of radiation therapy and breast cancer, indications, remuneration, delivery techniques, protein versus protein and fragment fractionation. So in addition to the standard indications that we have now, breast cancer plus radiation, selected plus and bacterial and zero and control. Otherwise, most of the patients in breast cancer usually go for breast radiotherapy and post mastectomy. So again, gold standard indications, P3D4 and no lymph nodes and emerging positivity. So what's new that has happened in the recent past? The reason is modern radiation and early breast cancer has been back and forth. We do some no radiation and there's 4 nodes positivity and then back to 1 to 3 lymph nodes. So this is wonderful meta-analysis of early breast cancer triangle presented in February 2019. Notably, significantly reduced breast cancer recurrence, breast cancer mortality, and overall mortality. Significantly, 0.0002. Now, we have this trial, axillary radiation versus axillary dissection, MIRA study, that Shaikh has already mentioned about it. And here also we see that when you do axillary dissection and axillary radiation, if the sentinel node is being 1 or 2 nodes positive, there is no difference in DFS or overall survival. 10 years later, in this trial, axillary recurrence after 10 years in patients with tumor positive sentinel node biopsy by
mutation. The 9% recurrence of invasive disease-free survival in 3 years, which is maintaining. 32% reduction in death actually, which is 3.4%, and toxicity is manageable, and maybe this will be the little bit practice changing type if somebody can afford.
Thank you very much for your wonderful deliberation, Dr. Mahapatra. I suppose there's not going to be any question, is that right? From the organizers? Okay, yeah. So may I call upon Dr. Bharat Patodia, who is a medical oncologist, senior consultant, Asian Institute of Gastroenterology, Hyderabad, as a discussant.
So thank you very much for the presentation. I am from Hyderabad, Asian Institute of Gastro. I see lot of Bengali patients. So, but I would like to ask, in your practice, how many early breast cancers actually you are doing germline BRCA mutation testing?
We actually we are not testing in, previously.
Yeah.
Maybe now we have started testing.
Okay.
And I think same actually.
Please be on the dais so everybody can see you.
Thank you.
Under the strong light that we are sitting in.
So because I see a lot of patients from Bengal, and major problem was, of course, there is a bias with the patient who comes there comes with a limited financial resources. So even the patient who comes determined that they will get evaluated, I am not able to send BRCA at all. And now this setting where germline BRCA mutation you are offering in a early breast cancer. So how many do you think you will be able to prescribe this test?
See,
from Monday morning.
When we started with ovarian cancer BRCA actually, previously we are not used to send. Now we are sending actually. And we are seeing patients with BRCA positive.
So
in breast also we have started actually.
So will you be testing for all HR positive, HER2 negative, or will you follow any?
We send by the NCCN guidelines actually. Till
So
now,
all triple negative we are sending.
all triple negative 60
HR
years,
positives.
60 years, or somebody have a strong family history.
In HR positives?
HR positive, if somebody has a strong family history or more less than 50 years of age, we are sending.
Okay. As I remember, it is probably younger HR positives we recommend.
Mostly the NCCN tells around 50 around.
And do you think that the toxicity difference in this setup where it is early breast cancer, it is simply because reflection of a patient having a early breast cancer versus other settings where olaparib has been studied like metastatic ovarian? So do you think it is just the disease status where toxicity profile is lower in this?
Difficult to tell. It's what we see is as per the trial actually. If you see the trial here, the toxicity, the discontinuation rate are less actually. But if you see the other olaparib trials, there may be a little bit more actually. But it all depends upon this because these patients are in this trial, its average age is around 41, 42. So younger patients.
So I felt that in few of the patients where I could use olaparib, the main limiting side effect was fatigue and anemia. But in this, that problem was not there. So
This trial also same. It is over this trial actually. The anemia is 5:1 actually, and the fatigue is 3:1. So anemia is the main the anemia and fatigue. And
how do you deal in this setting anemia? Like you will prefer blood transfusions or EPO?
Not like that. We see the patient actually. What is the hemoglobin level? That the patient is symptomatic.
So EPO versus blood. EPO versus.
We are running late. I will request you to please finish this discussion. We can continue with the deal.
Yeah. 1 minute more. This question. So EPO versus blood, which one you will prefer?
EPO we are not using actually. Whatever olaparib we have used, we have not used one EPO actually. And we are seeing if it's 7 less than 7, sometimes we advise blood transfusion.
So blood is your preference. Thank you very much.
Thank you, Dr. Maharashtra. Our next talk, thank you very much. Our next topic is hard to negative MBC, and the speaker is Dr. Joydeep Ghosh from TMC, TMC Kolkata.
So I'll be talking about the future directions in HER2 positive metastatic breast cancer. So these are the subtopics that we are going to discuss: the background, the novel anti-HER2 therapies, what is the clinical evidence, future considerations, and the conclusion. So we all know that there are very few discoveries that have shaken the foundation of cancer treatment, like the discovery of the HER2 oncogene, and the incidence of HER2 positive breast cancer in Indian population is higher than the Western population, and sometimes in some series it is seen in almost 50% of the cases. And the HER2 overexpression confers an aggressive tumor biology, but also is an opportunity to use targeted therapies. Now, 2 decades ago, when trastuzumab was not there, it was only the standard of care was chemotherapy, and during that time, approximately 2001, we had the major pivotal study by Dr. Slaman et al. Published in NEJM, which clearly showed that addition of trastuzumab to chemotherapy significantly improved the overall survival. And after that point, trastuzumab became part and parcel of treatment for breast cancer. And it was seen that almost there was a 20% reduction in the risk of death with the addition of trastuzumab. Now, although HER2 targeted therapies have improved the disease outcome, they are not curative in the metastatic setting, and most of the patients ultimately, almost all patients actually progress at some point of time. And if you look at the proportion of patients who go into the second or the third line, so almost 22% of the patients do not receive any second line therapy, either because they are demotivated or there are toxicity issues which prevent them from giving further chemotherapy. These are the more, or the disease progression which they do not want to treat further. And if you look at the second line proceeding on to the third line, again around 35% of the patients do not actually receive a third line therapy. So sequencing decisions depend on the previously administered therapies, the progression-free intervals, sites of progression, tumor burden, patient preference, and quality of life. So it is important that we increase the initial lines, increase the progression-free interval in the initial lines, so that more and more patients stay longer without the disease, or rather the disease in control. There has been an unprecedented flourishing of anti-HER2 therapies that we have seen in most of the clinical trials recently. Almost 8 anti-HER2 drugs are currently authorized by the US FDA for metastatic breast cancer, and half of them were approved in the time frame of 1 single year. So trastuzumab deruxtecan was one of the initial ones to be approved. Then we have neratinib, tucatinib, and margetuximab, and we are in the spectrum where more and more HER2 targeted therapies are coming up in the pipeline. If you look at the ESMO 2021 metastatic breast cancer guideline, they were adapted to incorporate the novel therapeutic agents beyond the second line. So in the left-hand side, you can see that if the patients progress, then the second line treatment after trastuzumab plus pertuzumab, you have the options of trastuzumab deruxtecan or TDM1. Also, you have the option of tucatinib plus capecitabine plus trastuzumab or TDX1. Now, in the third line and beyond, you have again the similar options: TDM1 or TDX1 or tucatinib capecitabine plus trastuzumab. And this is to show you the NCCN guidelines, their preference for the drugs. So in the first line, the preferred regimen still stays the Cleopatra type of regimen, where we combine a taxane plus trastuzumab and pertuzumab, and that has led to the highest median overall survival in this population. In the second line, you have both the options of the antibody drug conjugates, the TDM1 as well as the trastuzumab deruxtecan. And when the patients progress after these really effective HER2 blockade therapies, we have the option of combining trastuzumab again with either chemotherapy of different types, or you have the option of capecitabine plus lapatinib, or trastuzumab lapatinib plus trastuzumab capecitabine plus tucatinib. Now coming to these individual drugs, first one to discuss will be TDX1. It is a highly potent, it contains a highly potent topoisomerase 1 inhibitor payload. Along with that, there is a 8:1 drug to antibody ratio and a cleavable linker. So what happens is this complex molecule binds to the HER2 receptor, gets endocytosed, and inside the cell, it breaks down into its individual components, and the chemotherapy component leads to the target tumor cell damage. Now, how is the trastuzumab deruxtecan different from other ADCs? Well, there are a couple of differences. One is the chemotherapy component in TDM1 is an anti-microtubule, but for TDX1 it is a topoisomerase 1 inhibitor. Also, the drug to antibody ratio is 8:1 versus 3.5:1 for TDM1. And the tumor selective cleavable linker is present in TDX1, and there is evidence of bystander anti-tumor effect in TDX1, which is not there in TDM1. Coming to the Destiny Breast-03 trial, this is the first randomized phase 3 trial of TDX1. So patients who had a metastatic HER2 positive breast cancer who were previously treated with trastuzumab and taxane in the metastatic setting, and they were randomized into two arms, TDM1 versus TDX1, and the primary endpoint was progression-free survival, and the secondary endpoint was overall survival. So here you can see that TDX1 led to a highly significant and a clinically meaningful improvement in the PFS by blinded independent review. So the 12-month progression-free survival rate was 75% with TDX1 versus only 34% with TDM1, and which has a extremely high statistical significance. You can see that p-value is 7.8 into 10 to the power minus 22. Also, if you look at the subsets, this is quite assuring, because if you look at all the subsets, not a single subset has actually crossed the midline, and that is the reason why the p-value is so low that the chance of having rather I would say the difference caused just by chance is extremely low, and all these subsets have actually favored the TDX1 arm. Also, they looked at the subsets of those who had brain metastasis at baseline versus no brain metastasis. So patients who had brain metastasis, their 12-month PFS was almost similar to the one in the overall population, 72 months versus 20 months. And in patients who had no brain metastasis, it is slightly higher, 76 months versus 36 months. So the takeaway from this particular slide would be that even in those who have brain metastasis to begin with, the median overall, the PFS is not affected by the mere presence of the brain metastasis, because the intracranial activity of trastuzumab takes care of that to a significant extent. Coming to the safety summary, well, the median treatment duration was 14 months with TDX1 and 6.9 months with TDM1. And the most common treatment emergent adverse effect associated with treatment discontinuation for trastuzumab deruxtecan was interstitial lung disease or pneumonitis, which was around 8.2% compared to only 2.7% with TDM1. And the most common adverse event associated with dose reduction were nausea and neutropenia. And for TDM1, it was thrombocytopenia and liver dysfunction. Coming to the overall and exposure adjusted safety summary. So although the rates of any adverse event and adverse events more than grade 3 were generally similar between the arms, If you look at the exposure adjusted rates, which takes into account the duration for which the patient takes the investigational agent, if you go by that, the exposure adjusted rates were actually lower with TDX1 compared to DDM1. And also that same thing applies for other adverse events. Now coming to the adverse events of special interest, if you look at the ILD, the grade 3 ILD was present in just 2 patients, which was 0.8%, and none of the patients in the TDM1 arm had grade 3 ILD, but there were no grade 4 or 5 ILD caused by any of these drugs. And also they looked at the reduction in the left ventricular ejection fraction. Mostly it was grade 1 and grade 2, and grade 2 was around 2.3% with the TDX1 arm versus 0.4% in the TDM1. So there is numerically there is slightly higher incidence of asymptomatic reduction in the left ventricular ejection fraction. Coming to tucatinib, we have the HER2 CLIMB trial, where the key eligibility criteria were the patients had to have a prior treatment with anti-HER2, with trastuzumab, pertuzumab, as well as TDM1. So we are looking at a very heavily pretreated population, and a baseline MRI was required as one of the important criteria. So these patients were randomized into the investigational arm of tucatinib plus trastuzumab plus capecitabine versus trastuzumab plus capecitabine alone. And these are the results where you can see that the longer PFS with tucatinib in the overall population of patients with brain metastasis was achieved via control of both the intracranial as well as the extracranial disease. So on the left side, you have the PFS, or median PFS was 5.6 in the placebo versus 7.8 in the tucatinib arm. And also, if you look at the OS, it was 17.4 versus 22 months with the tucatinib arm. And if you look at the exploratory overall survival in patients with brain metastasis, this is the first trial which demonstrated that there is a clinically meaningful benefit in OS among patients who have a brain metastasis, probably because this is a small molecule and it has a higher propensity of crossing the blood-brain barrier. And it, including in patients with active brain metastasis, reduction in the risk of death was 51%, and prolongation of median OS was almost 9 months. And also, if you look at the intracranial response rate, it was 47% versus 20% in the control arm. Tucatinib in combination with trastuzumab and capecitabine was associated with toxic effects, with the majority of the adverse events being low grade, and the most common ones were diarrhea, hand-foot syndrome, nausea, and fatigue. And the discontinuation due to the adverse events were around 5.7% with tucatinib versus 3% in the placebo arm. Coming to another TKI, that is neratinib. This is a NALA trial design where patients, again heavily pretreated patients, randomized into neratinib plus capecitabine versus lapatinib plus capecitabine, and the primary endpoint was a co-primary endpoint of PFS and OS. So this again led to a PFS improvement of approximately 2.2 months at a restriction of 2 years. And also in the overall survival, the difference was approximately 2 months, although it did not reach statistical significance. And these were the safety concerns. The most important safety concern that we have in combining neratinib with capecitabine is the diarrhea. And we are yet to see, because this drug is not yet commonly available, so we are yet to see how our Indian patients actually react to the diarrhea propensity of this combination. Lastly, there is this drug called margetuximab, whose effect has been proven in the SOPHIA trial. I do not think that this trial has made much of a clinical impact, because there is a very modest improvement in the PFS, and this drug is actually beneficial only in a specific subset of cytochrome P450 allele type, and most of the labs do not have the facility to test those alleles. So I don't think this is going to be a really game changer in HER2-directed therapies. So this is in summary the drugs that are there. I have discussed all of them. And if you look at the future considerations, the world is moving towards HER2 low expression, because there is preclinical evidence that even in HER2 low population, there is some effect of the newer antibody drug conjugates. And that is the reason why the later generation of Destiny trials are enrolling patients who are HER2 low into the standard of care versus trastuzumab deruxtecan, and they have started showing improvement in the overall survival as well as the progression-free survival. So these are my conclusions. Although the existing HER2 therapies have improved the disease outcomes, they are still not curative. Obviously, it's not possible to have a curative situation here. And the major therapeutic improvements have occurred in the recent past. The way forward is obviously the HER2-directed antibody drug conjugates, and many more drug conjugates are yet to come. So we're looking forward to exciting times ahead. Thank you.
Thank you, Dr. Jaideep, for very detailed discussion, especially on the newer molecules. Now, before going to the panel discussion, any question from the audience? Okay, so let us go to the last session. That is the panel discussion. And pardon, Dr. Shudit Das, the medical oncologist from Medica Super Specialty, is the moderator. Please start your session, and please allow us to step down to the hall so that you can continue with the panel.
It's a very challenging task when the bar counter is open and it's already 9 p.m. So may I request the organizers, may I have one group photo and end this session very quickly. So thanks Dr. Prashanjit sir and Shanda for giving me this opportunity. Quickly I am inviting all my esteemed panelists, Dr. Shona Nag, Dr. Jaideep Ghosh, Dr. Shayan Kundu, Dr. Sagar Sen, Dr. Konishku Sarkar, Dr. Tanma Mandal, Dr. Shekhar Keshri, and Dr. Arundhati De. We have medical oncologist Dr. Jaideep, Dr. Shona Nag madam. We have radiation oncologist Dr. Shayan Kundu, Dr. Arundhati De. So all the panelists are here. So my first case will be 47 years old lady, T1N1M0 left-sided breast cancer. She was treated as early breast cancer, locally advanced breast cancer disease, and completed maintenance trastuzumab 1 year back. Now she came to in your clinic, and on routine follow-up, she was complaining of pain abdomen. CT scan picked up liver mets. So what's next? My first question to Dr. Sagar Sen. So what should be the next management? So there is a pretty good number of liver mets.
So by the look of the disease, it's quite extensive. So it will be prudent if you take a biopsy from this metastasis.
Well, so the question is biopsy or FNSC? Dr. Konishko?
That would be a true cut biopsy.
Okay. No, he's just giving his opinion, madam. I will hear from other panelists. Dr. Konishko? It will be a true cut biopsy. True cut biopsy. Dr. Jaideep, you differ, right? I don't need a biopsy. It's a HER2 positive, node positive disease which have recurring warning. So that follows the timelines. Yes. So let's see this data. This is a meta-analysis, and it is a huge number of patients who are analyzed, and this meta-analysis shows that the disproportionate ERP and HER2-neu result from the primary biopsy and in the recurrent setting because even if you do a biopsy and find that it's negative, you'll be confident to commit chemotherapy. Yeah, but that's a very tricky question because from where the biopsy was taken. So it depends on the adequacy of the biopsy also. So then what is the first choice in this setting? Dr. Tanmay, what should be the first choice? There is no debate in regarding the first choice among a medical oncologist because it is well established. Leave apart the access issue. Okay. Okay. So my question to Dr. Samala, madam, what percentage of your patients with HER2 positive MBC receive dual HER2 blockade? I'm pretty sure that you must be dealing with a lot of good profile patients, but what actually, I'm very curious.
Yeah, I would say about 20-25% of my patients do take the dual, but it's a mixture of private and central government, so it's easier to afford it. And now that the fees are available, the cost is cut down.
Thank you. Dr. Joydeep, you are working in a academic institute with high volume breast disease. So, what is your experience? What percentage of your patients are actually eligible for, not eligible, they are actually taking dual HER2 blockade? 10 to 15%. 10 to 15%. So, this question is not because the TDM1 is in coming years maybe phasing out from standard second line treatment after the Destiny 3 has come up. So, any role of TDM1 in first line, Dr. Joydeep? Yeah, trials are evaluating that, and especially if you have a very short disease free interval after the adjuvant treatment within 1 year, then we may as well use a ADC rather than Bactiopartin. Or Platinum also. No, in such cases, you don't use trastuzumab pertuzumab combination because I think in the trial, the minimum interval was at least 1 year. What do you have to say?
So basically, the 6 months to 1 year is a little gray area, but yeah, 6 months I would still do trastuzumab, pertuzumab. But if the patient is relapsing very quickly within 6 months, that tells me there's heavy resistance going
Yes,
on
yes,
there.
yes.
I would prefer a drug like TDM1
Yes,
because TDXT is not available with
yes,
us.
yes. So that's true. Because so the message is that for in Emilia trial, the resistance definition was kept 6 months, and in the Cleopatra trial, it was kept 1 year. So what about from 6 months to 12 months? That was the question. What, so my this question was pertaining to if many of the patients they are very elderly and their PS is not that good. In such setting, Dr. Tanmay, are you comfortable to avoid chemotherapy and using only HER2 directed therapy in such situations? So in such a situation, patients are real. They come in our clinic. So if the patient is not eligible for taxane-based chemotherapy, elderly, so we can go ahead with the TDM at the first go. Correct. So one trial was patent trial phase 2 study that showed that trastuzumab and pertuzumab combination also has some activity. And this Marian trial that showed that TDM1 in first line, it's not inferior, but it is not superior also. So in such population, maybe this is justified. You want to agree with me, Dr. Madam?
So I think this turned out to be a non-inferiority
Yes,
trial. There were
it's
three
not
arms
inferior.
that were used here. So if you go by toxicity, I think TDM1 alone is also a good choice if a patient wants to avoid the toxicity of a taxane. So I think it's quite reasonable, but it didn't show any superiority, which is what we were hoping.
So this patient was affordable and she continued with paclitaxel, trastuzumab and pertuzumab. And 8 months later, there was a stable disease in liver and CR in the breast. in your practice, suppose day after tomorrow, Monday, a patient is coming to your clinic, what will you choose? TDX is not available till now. So now the patient has crossed the TDX, but patient was earlier on trastuzumab and trastuzumab plus multipixel. Then I have go ahead with the TDX one. So that is the realistic solution we have presently. And however, because this is an academic forum, so I must discuss that based on available evidence, the standard second line anti-reactive therapy should be trastuzumab deruxtecan after the result of Destiny 3 trial, and it was TDX compared with TDM1, and that showed remarkable PFS benefit with a 12 months of PFS of 34% versus 75 months doubled. And it was beneficial in across all the subgroups, whether the patient received prior trastuzumab treatment, yes or no, and see the fast plot. So in brain mets positive patients also see the hazard ratio. That's so impressive. So the patient was taking, and this patient was taking actually TDX1, must be very lucky. And after 18 months, now there is new progression in lung. So what should be the next treatment? Dr. Sayan? So medical oncologists, they have very few options left. So now we want to take help of different modalities. It's only in the lung, it's only also in the liver, and suppose there is one or two one or two progressive lesions in lung. The rest of the lesions are well controlled. So then I can go for stereotactic body radiotherapy. So how strong is the evidence? Not enough. You don't have any other chemotherapy drugs. So that's the only option if other areas are controlled. Any other radiation oncologist want to differ? I would like to continue with the systemic therapy because the patient is metastatic. So I guess Dr. Sayan was not ruling out that we want to stop TDX1. He was saying that we can give stereotactic radiotherapy and TDX1 is to be continued, right?
So in that case, giving like, Madam, what will be your take on this in such situation?
Yeah, one thing that you have mentioned that new and isolated progression in the lung lesion. See, thing is there that we have some criteria to treat the lung. While you are asking for the local radiations, definitely patients should not have a fusion kind of thing in that particular area. Number one. Number two is it should be very much covering in the field that there should not increase the toxicity as well. SBRT may be the preferred options or may have some other kind of local therapy. It may reduce the size of the lesion. Or if patient is symptomatic as well, definitely you should prefer first to give up local RT.
Ma'am, you want to agree with this?
So you can't get better than TDXT according to the data. It would be very difficult to, based on one new metastasis and all the others are responding, to throw away the drug. So
because this is EGFR positive lung.
No. So I've had a few patients where they've been on Transport and they've had just a single site of progression. And I've given them radiation and they've gone on for 6 months more, 8 months more, and then switched to another agent when they really, really progress in a big way. So you've got to individualize the case, go by the clinical scenario, go by how symptomatic they are before you take a call.
Thank you, ma'am, for your input. Now, so what are the situations where you will prefer TDM1 over TDX in the second line metastatic setting?
The only scenario that I can think of is somebody having a baseline interstitial lung disease.
So TDX1, it was reported to be 10%, almost 10% interstitial lung disease in Destiny 3 trial. Now, suppose the patient was on trastuzumab and dolutegravir regimen, and she progressed in brain, but she was completely asymptomatic. On an MRI, brain picked up this lesion. So any one of the radiation oncologist
should be your next step? Dr. Sandeep?
I would like to go for radiotherapy, and in this scenario we can do two ways. One is whole brain radiotherapy with SIB boost to the single particular lesion, or we can go for SRS. So
This is
depends
a
on the
single
patient's
lesion. This is a single lesion, and the patient has still a good survival chance of good survival even with TDM1, leave it for TDX. Still, you want to go ahead with whole brain RT, or you want to prefer stereotactic radiotherapy?
So I have
There is chance that she will live for more than 1 year.
say SRS would be ideal option for this kind of patients. See if there is some criteria there. Reason is looks like it's less than 2 centimeters in the size. The single lesion.
Okay.
Will be definitely one
Okay.
option.
Dr. Sharan?
Definitely SRS is an option,
SRS.
provided the size of the lesion is less than 3 centimeters and it's away from the
Critical structure. Dr. Kanishka, you want to prefer or say?
Definitely, I will do an MRI before I go ahead with the plan of stereotypes. To rule out any other lesions.
So, Destiny 3 showed that TDX1, it has shown that very remarkable.
Dr. Sudeep, is there a role for resection? I'm just asking.
Yes, that is also a very good option, but we don't have any neurosurgeon here. But yes, that is a very good and valid option. Yes. So, Destiny 3 clearly showed remarkable CNS. Will you agree or differ, Dr. Joydeep? What's your take on this?
I think the way you do response assessment in a brain, PFS is based on that largely. So even if if there is no tumor and it's just normal tissue or fibrotic tissue, that would still come as stable disease, and it won't be a PFS. Event, but because it's getting controlled, maybe the patient is living longer. That is one of the possibilities.
Thank you. Thank you. So my next case, I will be finishing this case very short, very fast. So this is a case of TNBC. This is a triple negative breast cancer patient who had multiple visceral mets. Do you typically revive a patient in such a setting, Dr. Arundhati?
As this is triple negative, so I would like to do the rebiopsy.
Biopsy.
Yes.
Okay. So any of the radiation oncologists, why we need a biopsy? Or if we are doing biopsy, are we doing any molecular test on that biopsy, Dr. Tanmay?
Mutation status now, but that can be done from the baseline block also. Or if you do a repeat biopsy, then we can do it from this.
Yes, because if we are doing BRC, there is a germline mutation, so we can get it done by the archival tissue also if that is available. Anything else? Because this is a IO era.
And yes, MSI and PDL1 testing.
PDL1 testing. All right. So, Dr. Jagdeep, on which tissue you are, which block you are asking for PDL1? Because these are some implication.
If we have
from the recurrent side or the original archival tissue block,
I would do it with the recurrent side. But if the TNBC has progressed very fast, then there is no point doing a biopsy.
Okay. And if recurrent setting, suppose there is a recurrent local tumor also and there are visceral mets also, from where?
I think both are equally good. There is a good concordance as far as few preliminary data.
Okay. And which antibody do you use to check this PDL1?
Ventana SP 142, I guess.
Ventana. So you are in favor of Atezo?
Yeah, because there is a study which has shown a very high concordance of both the platforms. And we have it available in our hospital, so we use it.
So, quickly going through that, atezolizumab and pembrolizumab, these are the two immunotherapy drugs which got approved in metastatic breast cancer TNBC setting. And atezo had very debatable response efficacy. Yes, ma'am.
If I may make a comment, it's very important to do the test, which is a companion diagnostic for the immunotherapy that you're going to use.
Yes.
So if you're using Pembro, do the DACO. If you're using Atezo, then do
I'm coming in that one. So Atezo was tested in two trials, Impassion 130 and Impassion 131. In Impassion 130, the chemotherapeutic partner was nab-paclitaxel, and Impassion 131, it was conventional paclitaxel. Surprisingly, in Impassion 130, it showed PFS and OS benefit, but in 131, it was a negative trial. So this is the result. And you see, that's why I was asking that question. That this is the data of Impassion 130 trial only, and when you get you assess PDL1 status on the primary tissue, the chance of immune cells it is 44%, and we do the PDL1 testing of immune cells. It is not CPS4, and where we get it done from metastatic tissue, then the chance of getting positive is 36%. Apart from that, liver and others, there are some sites where the chance of getting a positive PDL1 score is also actually less common. And one of the another criticism of this Impassion 130 was that when they progressed on immunotherapy, actually in this TNBC group, very few of the patients they received cisplatin or carboplatin, less than 20%. So, as your preference for a chemotherapy backbone determine the IO agent and the choice of PDL1 testing. So, this is valid because another agent IO, which is pembrolizumab, that was clubbed with nab-paclitaxel or gemcitabine, carboplatin. So, and here, as Ma'am was telling, the platform was DACO platform, and that cutoff was CPS 10. So, in Keynote 355, if CPS was more than 10, then there was PFS and OS benefit. And these are the three chemotherapeutic regimens which were used with pembrolizumab. So, five patients received pembrolizumab plus chemotherapy, and 20 patients progressed. The assessment of background mutation status at the beginning, or when the patient actually advanced multiple lines of therapy. Then you will use this agent in the first line.
If, yeah, in the first line, well, I think there are two trials, the Olympiad and the talazoparib Embraca. So one of them has them have mentioned that whether it can be used for first line. It's just that less than equal to 2 chemo lines. So if you have somebody who has progressed quite fast after AC taxanes as adjuvant, you might as well consider, but I would keep it at a later line after the initial lines of therapy.
Well, I will just show you two slides and finish my panel discussion. People are waiting eagerly. So, in Olympia trial, patients who never received any chemotherapy for metastatic setting, they are also enrolled. They were 25% patient, and see the forest plot. Even in those patients who did not have any chemotherapy naive, in those setting also, olaparib worked very well. So that is very interesting information, and uh, in fact, in fact, the, one of the yes, one of the observation was that when this was tried in first line setting, olaparib, then the benefit was better than when it was actually post chemotherapy. However, the biggest criticism of this trial can be that we all know that TNBC are very sensitive to platinum, and none of these patients were exposed to platinum. So they are actually all of them were platinum naive. So with this, I think I will thank all my panelists and all the delegates for patiently listening to me at this hour. Thank you. Thank you all.
Thanks, Dr. Sudeep. Thanks all the panelists. We are extremely sorry for the delay. So our meeting comes to an end. I'd like to thank all the faculties, international and national faculties. A special thanks to Professor Barve for taking out time from his busy schedule and coming to our meeting in Kolkata. And all our national international faculties, I sincerely express my gratitude for coming and making this event a success. I want to thank Apollo Hospitals and Association of Radiation Oncologists of India West Bengal chapter for allowing us to host this session under their banner and supporting us throughout the conference. I sincerely thank our sponsors. Without their support, it would not have been possible. I thank our event manager, Orange Productions, for doing this event nicely and without any hitch. And last but not least, I want to thank Team Apollo. Special thanks to our young team of Apollo, Dr. Jeevat Bhattacharya, Dr. Nazima, Karim Khandekar, Dr. Arundhati De, Dr. Mukti Mukherjee, Dr. Tanmay Ghosh, and the team of our students who has been working very hard for last 2-3 months. And without their support, it would not have been possible. Our students, Dr. Shomudeep, Dr. Aditi, Dr. Arko, Dr. Sriya, and I want to thank all our colleagues who have been a support, like Dr. Subhadeep, Dr. Tapas, Dr. Sunny, and from the medical oncology team, Dr. P.N. Mahapatra, Dr. Indranil Ghosh, and Dr. Amit Dattadwari, Dr. Deblina, all have worked very hard to make this a success. May I request Team Oncology to come on stage so that we can have a group photograph. Dr. Jeevat, Dr. Naziba, Dr. Prasenjit Chatterjee, who is the backbone of this conference and who has actually conceived this idea of having a breast cancer conference. So may I have you on stage? We can have a photograph. Dr. Jeevat, Dr. Naziba, Dr. Prasenjit, Dr. Shubhadeep, Dr. Tapas, Dr. Mukti, Dr. Arundhati, and all our students. Can we have you on stage for 2 minutes? And we can have a group photograph here. Dr. Tapas, please come. You can keep your glass on the table and come on the dais. We'll have a 2-minute session of photograph and then, yeah. Dr. Prasenjit, please. Dr. Prasenjit Chatterjee, please come on stage. We'll have a group photograph and we'll end the session. Yeah. Arko, Sriya, Shomudeep, Aditi, Sujan, Tanmay, Mukti, Dr. Mukti, Dr. Arundhati, Dr. Tanvi has already left, I know. Dr. Sheila, Dr. Suchanda Goswami, Dr. Subrata Saha, Dr. P.N. Mahapatra sir, Dr. Saikat Gupta sir. Dr. Saikat Gupta sir, can we have you on stage and we have a group photograph here? Dr. Sunny, Dr. Sunny. Mahapatra sir, Dr. Mahapatra sir, can we have a photograph please? 1 minute. So from Apollo, I invite everyone to come on stage and have a group photograph. Sir, please. Prasenjit sir, Saikat sir.
भात के राखছেন কে মাল কথা
One more. Sir, 1 minute. Thank you all. Please enjoy your dinner.